Sanjay, I am ready.
Yeah, okay, you can, I'll just tell Nikusha.
Yeah.
You can come on. Are you online?
Yes, I am.
All right, I'll just tell Nikusha.
Okay.
Good morning, sir.
Good morning, Mutusha. How are you?
Fine, sir. So, shall we start?
Yeah. Shall I go share screen? Somebody has
Just
to.
a second, sir. I'll just introduce and then just a second.
Yeah. Okay. Fine. No problem.
Got
Bye.
it. Good morning, everyone. Welcome to the second day session of Masterclass Back to Basics. And yesterday was a really comprehensive, exhaustive session. But all of you stayed tuned late till 12:10 almost. And today we are back with the more exciting topics and important ones. The first topic, which is going to be taken, is on chest X-ray introductions, and this topic will be taken by Dr. Anbarasu sir. Sir is a consultant radiologist and director at RN Diagnostic Imaging Coimbatore. Several publications and book chapters to his credits. Sir is totally inclined towards academics and promoting academics, and we are thankful for all his efforts and his courses. We welcome you, sir, and over to you.
Thank you, Mutusha. Let me just share the screen. Can you all see the screen, Mutusha?
Yes, sir.
Okay, fine. Thank you very much. Thank you, Sanjeev, and all the team, Indian radiologists, for making this happen. And thank you to all the other speakers, exciting speakers with the superb topics for the whole day. Let me just give a little bit of introduction, which we have done it in the masterclass in the past 3 editions. So it's something which is a basic, which has been taught by various people, including recently Professor Rami Ramakanthan did wonderful teaching on you will see what you're looking for. And this is one example here that what you are seeing is it a bull or is it an elephant? Both actually share a same head. So if you're looking from the bull side, it will look like a bull. If you're looking on the elephant side, it will look like an elephant. But sometimes there will be always be a clue. And if you see the clue is here, there is a person there who is controlling the elephant there. And that's sometimes the clue that is the elephant side. So these type of clues are always there in your imaging. So sometimes you have to look at these clues, which will give you the diagnosis. So these type of examples are just to drive you that you will see what you are looking for. So chest radiograph is the commonest radiograph. It is relatively easy to interpret, and that relatively is a relative for many people. So where the lesions are also missed easily too, because we are not giving that enough respect, sometimes enough time to look at each areas. Learning and adhering to the basics important, like in any imaging methods. We should be taking pride in reporting a radiograph. In fact, that is where our profession started. So we should start, take the pride that we should be good in radiograph, and that is something which every radiologist personally thinks should be working for, and particularly in relation to chest X-ray. So this is sort of planned today, but I'll be doing the sort of introduction. So the radiograph is a black and white photo negative. So if you look at here, this is an image of a scenery where you will see dark areas and very, very bright areas. In between, there is a shades of gray. Same thing in a chest X-ray, you see the dark area, which is a lung or air, and the bright or the whitest area, the bone, very dense bone. And in between, you have a shades of gray, which includes soft tissues of your heart, the blood vessels, and then small tiny calcifications which are slightly less dense than the bone. So these type of shades are always visible. The key thing is we have to look and differentiate these shades when you look at a chest X-ray. So the plan is to revise the anatomy a little bit and then use the precision words for description and how to describe. And this has been sort of discussed, and there is some sort of an agreement with the Flush Nurse Society that these are the words we should use. And how to read. Is there a technique to read a chest X-ray? And what are the errors we commonly do in reporting? What are the limitations? And there are some limitations which we should know how to express in our report. So let's start with a little bit of basic anatomy, a review of lobes and segments a bit more. And yes, this is lungs. Yes, you can see from graphic. The lungs are seen overlapping with the liver on the right side, as you can see here. and it is overlapping with the heart, almost covering the heart in the midline. And you can see its close relation to intercostal vessels, ribs, and overlapping with the diaphragm. But when you take a chest X-ray, what you will see is that complete structures from anterior to posterior overlapped with each other. As you can see the lungs, you can see the diaphragmatic margin, and then below that it's all soft tissue density because of the density, like liver is always sort of whitish, because we are actually aiming for our chest X-ray mainly to see the lungs. And you can see the blood vessels going through the lungs. We can see the intercostal spaces, ribs, clavicle, and all the other structures. And if you look at this particular study, which is a very old bronchogram, we used to sometimes put a little bit of tube into the trachea and then inject a little bit of dye, which nowadays practically outdated and not recommended, and nobody does that. And you can actually see the divisions of the bronchus. We can actually see the upper lobe bronchus dividing into apical, posterior, and anterior. And then we got an intermediate bronchus, and the intermediate bronchus, let me just get that arrow. The intermediate bronchus is okay. The intermediate bronchus is here, which is sort of dividing into middle lobe bronchus, and then intermediate bronchus is here. This is the middle lobe bronchus, and the lower lobe bronchial divisions are here, and the lower lobe bronchial divisions are dividing into 5 segments, as you all know. On the left side, on the right side, it is a little bit of an oblique view, which actually differentiates a little bit of the lower lobe bronchial divisions much better. On the left side, what you can see is the upper lobe bronchial division, and then a lower lobe bronchial division. This is the upper lobe bronchial division, this small short area, which divides into proper upper lobe, and this is the lingular segment. And this is the lower lobe bronchial division, and you look at the superior segment here, and then all the sort of basal segments. And we all know that because the heart is taking a little bit of the position of the medial segment, that particular area is called anteromedial basal segment. But with the coronavirus, we have changed the classification here a little bit differently. But for anatomical purposes, we know that there is 8 segments on the left side and 10 segments on the right side. So right lung has got an upper, middle, and lower lobe. 2 plus 5, so 10 segments. Left lung has got an upper lobe, which is a proper upper lobe containing 2 segments, apicoposterior and anterior, and lingular segment, and the lower lobe has got all segments except the medial basal, which is actually called anteromedial basal. Now, the zones versus lobes. The zones are important part of description. If you don't know where the exact location is, the upper zone, mid zone, and lower zone, description is very useful. So now if you draw a line there at the lower margin of the second rib, as you can see here, this connect these two, and there's another line which is drawn at the same level as the 4th rib here, and whatever is located above this second rib inferior margin is the upper zone, and between the 2 lines is mid zone, and below that is the lower zone. This is purely for description. If I and then anything part of this above the clavicle, this area is called apex. So if I overlap the upper lobe, you can see it is actually going into the mid zone, and that's the region of middle lobe, and that's the region of lower lobe. So you see, there are sometimes the report, we unconsciously make a confusion between zones and the lobes, and that actually becomes very incorrect and sometimes misleading. So you have to be very careful when you use the word zones and lobes. You can see that is the left upper lobe, and that is the lingular segment, and that's the lower lobe. You can see how much is the overlap with the zones and lobes. So this need to be understood. This is again a bit of a basic. Coming to fissures, and fissures are made up of 2 layers of visceral pleura, and therefore there are 2 fissures on the right side. The major fissure, also known as oblique fissure, and the minor fissure, horizontal fissure. The azygos fissure is a variant which again contains 2 layers of visceral and parietal pleura, and that is due to embryological development of the azygos vein. And so the fissures, as such, the normal fissure is made up of 2 layers of visceral pleura, while azygos fissure is special, it is much more thicker. And azygos fissures are can be accessory fissures, like superior and inferior accessory fissures can also be seen. And you can see here, this is a chest X-ray, and that is the orientation of the oblique fissure or the major fissure, and that's the orientation of the horizontal fissure. As you can see, starting from the oblique fissure, approximately at the level of hilum and going towards the hilum, and on the left side there is only one oblique fissure, and you can see that here on this drawing. You can see the location, and on that lateral view, that is the orientation of your oblique fissure, and that is the orientation of the horizontal fissure on the right side. And from this, you can actually see this is the upper lobe, and this is the middle lobe, which is overlapping with the heart, and this is the region of lower lobe. So it's easy to identify on the lateral view. And how do you identify the horizontal fissure? Horizontal fissure is very thin, sometimes can be seen, not many times seen, but in this particular patient, we're actually seeing a consolidation in this area, and you can see it is actually associated with a little bit of volume loss, and therefore this horizontal fissure is actually pulled a little higher up, but it is still seen going towards the hilum, and this horizontal fissure is seen there. And this particular horizontal fissure is appreciated particularly because we are having an opacity, and we all know by anatomically this area is is in the region of the anterior segment. So sometimes you can actually localize using this fissural thickening and fissural malformation, deformation. You can actually say this is a consolidation in the anterior segment. And another opacity here, which you are seeing in the left lower zone in this area, looks like a consolidation or mass, but look at the clue here. There is a heart is enlarged. There is also pleural effusion in this. And the follow-up X-ray after cardiac failure treatment, it has disappeared. So this is a pseudotumor. This is called the fissural effusion or the pseudotumor, and that is also tells you the orientation of where the horizontal fissure is located. So we have to start thinking about these particular conditions whenever you come across an opacity in this particular location. And this is azygos fissure. As you can see, it's much more thickened, and this little opacity located at the inferior margin of azygos fissure is the azygos vein on the X-ray, and you can see on the CT the course of the azygos vein going through and forming this particular separate lobe-like area, and that's called the azygos lobe. And that there is a paper which says that the azygos lobe is usually of a slightly increase in density because of these overlapping structures compared to rest of the upper lobe, and that should not be mistaken for an abnormality. Here is an inferior accessory fissure, which often, with the corona, you will be doing a lot of HRCTs and you will be start seeing accessory fissures much more easier. Inferior accessory fissure, separating the medial basal segment from rest of the segments, and this is part of the superior accessory fissure, which is sort of seen sort of extending anteriorly. But when you come to the anteriorly, what you see here, this is actually the major fissure, and little bit of middle lobe and little bit of the medial basal segment of the lower lobe is separating these two structures, and you're able to see it in this particular CT, but not always. Sometimes you can see it completely goes and disappears in this area. All right, and a chest X-ray here. So that is, I'm just trying to show you an area here which is hid, and when I showed in the real meeting, many people said that this is the right hilum, this is the right heart border, but there is something which is hid in this area which we don't normally pay attention to it. And if I show you this particular structure here on the left side, many people correctly said this is actually the pulmonary bay, but on the right side, this is the esophageal recess on the right side, which is hiding behind this cardiac border. And this is the AP window or the pulmonary bay, which sometimes call it the gap between the bulge of the ascending, the arch of aorta, and this is the pulmonary artery. And between that, you get a little dip, and that's the AP window, which we see on the CT scan. And just to show you the esophageal recess on the CT, you can see this is sort of going in between. And this is an area of sometimes we miss lesions on chest X-ray. So you just need to be aware. And in this particular X-ray, what I'm trying to show is another important structures which you sometimes don't pay much attention. That is the right paratracheal stripe. And the right paratracheal stripe is an important structure. So the key areas are esophageal recess, AP window along the left heart border, paratracheal stripe. Paratracheal stripe should be, the 4 is the sort of remembering. It should be less than 4 mm in thickness, usually 4 centimeter in height. And it is not seen in approximately 4% of adult radiographs. That means it is seen in 94-95% of the adult radiographs. So it is seen in many of the patients. So it is made up of the tracheal wall, the mediastinal tissue, and the pleura. All these 3 structures together form this particular right paratracheal stripe. Paratracheal stripe widening is an important aspect to look for in a chest X-ray, because that must be maybe the sign of an enlarged node. Let's go to the precision words for description. Okay, and this is from the Flushness Society publications, available free for you to download. The scientific writing calls for a precision as much in naming things and concepts as in presenting data, and this has been sort of a starting point in Flushness Society publication. So the words we use, okay, opacity is a non-specific term. That's what they say. It does not indicate the size or pathological tissue of abnormality, but it is a very, very non-specific term which is useful in many circumstances. Parenchymal opacification is a term which they tend not to prefer. Instead, airspace opacification is probably much more appropriate, because parenchyma, what you actually mean is different from airspace, which is actually meant as the alveoli and respiratory bronchioles. And so the consolidations, ground glass appearance, some of the alveolar nodules like acinar nodule, they actually are airspace opacities. The ground glass opacity, we all know, we are now familiar with the ground glass opacity. That is actually the mainstay of money payment for many radiologists this season, and where vessels are seen, and consolidation opacity, where dense enough the vessels are obscured, but air bronchogram may or may not be present. It is not necessarily, it is seen, it is helpful. If it is not seen, then not necessarily, it is not a consolidation. Apical cap is a cap-like opacity or lesion on the right lung apex up to 30 millimeters. So beyond anything more than 3 centimeters, we are dealing with something else. Atelectasis is an area of opacity. It can be linear, it can be discoid, it can be rounded. When the atelectasis become more severe, we call it collapse. It may be segmental collapse or lobar collapse, but when it is subsegmental, generally the word atelectasis is used. But nowadays it is used interchangeably between the collapse and atelectasis. It is not a big issue. Bronchocele is defined as a Y or V-shaped opacity, so-called classic gloved finger appearance. I'm not giving you all the complete glossary here, but those which are important for our day-to-day practice. Just to give you an example of a ground glass opacity, I'm sorry, it just went fast. Ground glass opacity, where we are able to see the vessels in this area, but this is a consolidation here. We are not able to see the vessels, but if you look carefully, we are able to see the air bronchogram in this particular case. Apical cap, atelectasis, collapse, branching opacity. This is an example of a branching opacity here. Sorry, and I'm just trying to show you that it's just the animation went differently, and you can see the plate-like atelectasis just above the diaphragm in this particular patient. And this is the lobar collapse, as you can see here, affecting the right upper lobe. How do you describe the lucent areas? Hyperlucent area is it can be sometimes a hyperinflation, because you carefully should have to look for the vessels. If the vessels are present, we are dealing with hyperinflation. Emphysema, when the vessels are very narrowed, and something we will start describing it as mosaic perfusion, and bullae, when there are no vessels are seen. Cyst is usually less than 2 centimeters. There is no background emphysema. The wall thickness is generally less than 4 mm, but it has got a very well-defined interface with the normal lung. Cavity tend to occur within a lesion. It can occur in consolidation, carcinoma, or even in a ground glass change. And the wall thickness in a cavity is generally regarded as more than 4 millimeters. Air crescent sign is a typical appearance of a crescent-shaped collection of air, and it's been described in fungal ball. As you can see, we are dealing with cavity here, thick-walled cavities. You can see the cavity with fluid level. You can see that there. And this is what looks like a lung cyst or pneumotocele, very thin lined walls. Is a patient with pneumocystis. And this is another lung cyst which we started appreciating. But if you look carefully, there's actually a fluid level in this area. So this could be an infected lung cyst, and you can start seeing the air crescent sign in a patient with a fungal ball. And this is a foreign body, and this foreign body is something which is very important. I'm sure the pediatric talk will be able to give you more clue. This is an expiratory film, as it is written here, and you can see there is increased density of the right lung, which is normal, and expiratory X-ray, when it is showing hyperinflation, then that is the area of site of abnormality, usually due to a foreign body occlusion resulting in air trapping during expiration. So you have to be very, very careful in interpreting pediatric radiographs. So pneumatocyl appearing as an approximately rounded thin-walled airspace opacity in the lung. Between the cavity, the differentiation is that pneumatocyl has got a smooth inner margins, usually no fluid, very, very thin wall and very regular. And in the absence of symptoms, you usually see a pneumatocyl, but in India, the tuberculous cavity at the later stage of treatment sometimes can mimic like this, but usually these type of cavities are associated with surrounding fibrotic changes or calcification, and usually we don't call them as pneumatocyl. Pneumatocyl tend to be seen usually on the resolving phase of inflammation. How do you differentiate a pneumatocyl and bulla? Pneumatocyl tend to occur in the central part of the lung, and usually it tend to have a little bit of opacity around, and bulla is usually in the peripheral margin of the lung and associated with the COPD. And nodule. Nodule is a rounded opacity. It is well or poorly defined up to 3 centimeters. Miliary nodules are 1 to 4. Acinar nodules are 5 to 8. And then anything more than 3 centimeters is a mass. A pseudonodule is something which can mimic like a pulmonary nodule, and we have come across that quite a few in our practice. As you know, something like a rib fracture or a skin lesion, like the nipple shadow, and sometimes the device on the surface of the patient, like tubes, anatomical variations, sometimes composite area, 2-3 vessels and a rib crossing over each other produces this pseudonodule in appearance. And that involves a lot of attention and a little bit of practice, and always useful to compare with previous radiography. And just to give you an example, miliary TB chest X-ray sometimes looks normal because of the projection. And as you can see, this is the miliary nodules, as you can see on zoomed, and you can see that on the CT scan. Miliary nodules, miliary tuberculosis, another nodule here on the left side. You can see that there, and you can see that here. And on the CT scan, you can actually start picking up those small calcifications consistent with the pulmonary hematoma. And here is a patient who is having what looks like a pseudonodule. There is a nodule-like area here, and on the CT, you are actually seeing multiple neurofibromas along the inferior margin of the ribs. And you can see here what looks like a nodule. This is actually not a pseudonodule, true nodule, but it is extrapleural nodule in this particular location, pseudonodule-like appearance. Reticular pattern is opacities where you will see linear patterns and then crisscross patterns. And sometimes it can overlap with nodular pattern, therefore it is called reticular nodule. You can start seeing this reticular or linear opacities in this patient. You can start appreciating these curly B lines at the periphery, which like horizontally oriented peripheral lines. And if it is in the upper lobe, it is called the curly A lines. So these are the linear, and reticulonodular is associated with fibrosis, while linear can be associated with just a simple septal thickening and not necessarily fibrosis. Now, coming to the silhouetting, or silhouetting is a commonly misused word, which I am trying to tell you because it has been told by many senior radiologists over the years, and still when you come to the exam, people jump into the conclusion that I am seeing an opacity in the right middle lobe silhouetting with the heart, and therefore this is the right middle lobe consolidation, which is a completely grammatically wrong sentence. And you can see why. When you say silhouetting, means silhouette is an outline, that means you are seeing the outline. Silhouetting means it is outlined, and silhouetted is also means outlined. But silhouette sign is the outline is gone. You are not seeing the outline. Just to sort of teach you via Google, you just type the word silhouette and you see the outline. And so Google actually makes people believe rather than sometimes teach us. Silhouetting, you can still see the outline of many of these. And you see silhouetted, you can see everything is still seen. The margins of the particular abnormality or particular shadow is still seen. So all the three words actually mean, but you are mentally or in your mind, you are actually feeling that it is actually obscuring. So silhouette sign is loss of outline, and this is the example of all the silhouette signs you can see on the Google search images, and you will see the outline is lost. So silhouetting and silhouetted means you are actually able to see the outline. The word you should be using is opacity obscuring the right heart border. Here is an opacity at the right midzone obscuring the right heart border, and therefore consistent with the silhouette sign and the right middle lobe consolidation. Opacity at the left lower zone obscuring the left heart border, consistent with the sellout sign, and this is the lesion in the left lingula. And I'm trying to say here it is partly not obscured here in this area, but definitely it is obscured in these two areas. So it is still, if it is obscured, it is obscured. Here is a lesion in the right lower zone. Right lower zone. The right heart border is sort of reasonably seen, and it is still a right middle lobe consolidation. And just to give you an example why it is still a right middle lobe consolidation, and this is another something which is used in the exam. There is no sellout sign, so it is not a middle lobe. And the opposite is, we know it is never true in medicine. And here is a patient who has got an opacity in the right lower zone, mid zone overlapping area. And you can see that, right heart border is very well seen. And you cannot use the word there is no opacity, there is no sellout sign, and therefore it is not in the right middle lobe. But if you look carefully, it is actually abutting the horizontal fissure. If something is abutting the horizontal fissure, if it is above, it is in the anterior segment of right upper lobe. If it is below, it has to be in the right middle lobe. And you can see that here. If you see the right horizontal fissure, this is the anterior segment, and this is the right middle lobe, and this is actually located at the lateral segment of the right middle lobe. So it is still in the right middle lobe, not causing any loss of outline. Okay, so you need to be careful when you're saying there is no sellout sign, and therefore it is not a consolidation, or it is not in the right middle lobe. That opposite assumption is not true. Now, how to read? Is there a technique? And there are people who have analyzed how to read something and how people are reading, and you can see that on the net. Tracking eye movements on the postgraduates and experts while reading a chest X-ray is an interesting study which was done. So what is the classical teaching in US departments to postgraduate to how to look at the lungs? Okay, this is something which basic, which should be taught on the first day of the radiologist residency, and again, at least you got the opportunity to learn now. So the teaching, classic teaching, is you start from the right costophrenic angle, go up like that, and then like that, like that. So you go up in the zigzag manner till you reach the right lung apex. This is the way to look at for somebody who has never seen a chest X-ray, like you are teaching to a final year medical student or whatever. But this is very well useful for somebody wanted to really becoming good in chest X-ray, right? I will tell you the reason why. And here you go to the opposite side and you do a little bit of zigzag appearance. And apparently this sort of gives you protection against missing lesions. Again, it is not 100%. And then once that is finished, you start seeing the scans in a slightly different way. Now you start comparing the right side and left side, going in that zigzag manner from top to bottom like this. Okay, so these two, if it is done, usually you will be able to pick up the lung lesions, it is said. And so the question is, how many of you will follow this after 6 months now that I am teaching? And in a hall of about 150, there are about 6 or 7 or 8 people raise the hand, and I'm sure that will be the case here. And the study also confirms that only 4% will follow this after about 6 months. So does the experts follow this method? This is another question which people ask, and the real answer is no, but they all started like this. Okay, how do the experts actually see? The experts actually do not follow any particular pattern. This is again based on that study. The pattern is variable depending upon what they see first and what is the clinical setting, and they have got what is called less dwell time. They actually know what they are looking for. So they have reached a level where once they see in one particular opacity, they immediately sort of don't give too much importance to it. They go to the other areas and they should looking for a few other clues and signs and things, and look at the other areas. And trying to tend to have less missed lesions and less interpretative. They develop what is called the random pattern after certain experience, and I am sure some residents will start having random pattern even from the first day, like an expert. That's fair enough. Okay, so now is least to what we are going to miss, what we can miss if you don't follow this method. Yes, we can miss. Even the experts do miss, but we can miss lesions at esophageal recess, posterior costophrenic angle, because these two structures are not actually well seen on a chest X-ray. Part of the lungs in the midline overlapping with the heart and sternum, paratracheal strip, hilar lesions, apical lesions, lesions obscured by bones and muscles. Some of them are genuinely can be missed. Some of them are missed because we haven't paid attention to that area. So you can have a method of reading the chest X-ray. You can start with the lungs, heart outline, CP angle, ribs, and spine. And you can have a review areas like epiphysis, hyla, behind the heart, below the diaphragm, shoulder, and soft tissues. And so this is an important for the exam. At least you should show them how you look at the chest X-ray and how do you look at the review areas. And there are quite a few people who have taught how to look at the chest X-ray and the radiology masterclass. UK uses this ABCDE: epiphysis, bones, cardiac, diaphragm, and then edges. We all know that many times we miss lesions at the edges of the film, and therefore we have to look at the edges much more. So this is another mnemonic to use. You can use that ABCD now to practice here if you want: apex, basis, cardiac, silhouette, diaphragm, and then the edges of the films. And the radiopedia teaches a little bit extra: A, B, C, D, E, F, G, H, I, and I'm sure there will be another site which will go up to Z in about 5 years' time when you all become consultants. So it starts with saying assessment of quality, airway, bones, cardiac, diaphragm. Look for effusions, extrathoracic abnormalities, lung fields, fissures, foreign body, great vessels, gastric bubble, hyla, and mediastinum. You choose whatever you like, doesn't matter. So you can use this A, B, C, D, E, F, G, H, I to look at this radiograph. So whatever you see, you shouldn't look at, you shouldn't miss lesions. Now, can anyone say what is going on here? Let me just, anyone make a diagnosis here, just to give you 2 seconds more. Okay, and if you look carefully, you will be able to see the left lower lobe collapse situated behind the heart. Sorry, there is a little bit of computers playing up. Just okay. So you choose what suits or create your own mnemonic. It doesn't matter. The key thing is do not miss lesions. That is the most important concept behind this. Okay, let's go to the errors. So the concept is you should know how to look for, you should know the correct words of description, and you should not miss lesions. This is the basic thing which is underlying any interpretation of any radiograph or scan. So what are the errors? We used to do a lot of audit of discrepancies, errors, feedback. There is a lot of issues with somebody, then we go for retraining and teaching. And this is sort of a drawing of the areas where we have missed lesion. A group of consultants practicing in one of the UK departments in the past, and the 22 of us, and just as an audit of this, which actually showed that there are lesions which has been missed at various places, including everything. And just to show you a couple of examples here, there is an abnormality in this which we have missed, and this patient presented with the chest infection, SOB. There is actually a little bit of fullness at the AP window that was thought to be due to blood vessel and ignored, and later on it turned out to be a carcinoma. This is an error of perception which people haven't actually paid attention to this area and did not give any importance to it. Another example here in this patient who was sort of able to see the cardiomegaly and some sort of pulmonary congestion. All has been reported as cardiac failure related changes, but later on patient HRCT showed turned out to be a subpleural widespread fibrotic change, and the patient was not improving and kept on cardiac treatment for about more than 6 to 7 months. Although it might not have changed the outcome, our interpretation was different. We didn't think about fibrosis in this particular setting. So, but see, this is something which we have to think about. You should probably have to go back to the history. If this has been persistent for several months, you just probably think that are we just dealing with cardiac failure, which has been persistent for 7 months, which is not treated at all. That is unlikely in this particular era. The patient should have had some treatment because he will be breathless. And therefore, if it is something persistent, and you can actually, the beautiful thing is always these people tend to have an X-ray from the previous year or previously done in the past. So you just need to sort of compare and see if something is persistent, just raise the possibility to do, at least advise them to do an HRCT lungs. An X-ray here, which is very dark, and if you look at here, just to show you that there is an opacity which is at the posterior cardiophrenic angle, which again was seen on this particular really done bad film. And later on, it found to have been present for years without no change. It was missed, but it did not do any harm to the patient because it has been found on the previous year radiograph and it was interpreted as not significant. Another patient who presented with cough and cold, again, the chest X-ray was reported as having a little bit of mild enlargement of the heart, CP angle blunting, no major consolidation, but what was missed was the absence of acromion on the left shoulder. Okay, again, it was actually turned out to be a metastasis. Just the zoomed image, you can see that particular acromion is completely missing, and the spine of scapula is missing, and the AC joint is just hanging somewhere in the air. It's a renal metastasis. Again, we missed it. Perception was not there. So another patient who has got a cystic cavity area mentioned in the follow-up scan. You can see the right lung apex. There is a cavity here, and only thing was they thought it was just a simple cavity, probably probably already treated. This is assumed that it was already treated, and it was not related to, but they didn't actually mention it should be compared, it should be followed up. So there was an error in communication after the interpretation, and it actually turned out to be an active pulmonary TB presenting like an innocuous residual cavity. So this type of wordings and expressions are very important in terms of perception, interpretation, and communication. Now, how to express some of the limitations in your report, and this becomes important in our day-to-day practice. This is just an example. Some people can disagree with this, absolutely fine, but make sure that what is communicated correctly to the patient. For example, many people say no FB seen. Sometimes for medical legal purposes, the correct thing is to say no radiopaque foreign body seen. You could argue the chest X-ray will only show radiopaque foreign body, agreed, okay, but there may be usually peanut is not shown on the chest radiograph, and how the judge, when it goes to legal proceedings, will interpret. These are some of the advice we got it from our legal department in our previous this thing. So this is the way sometimes they can reduce the issues. Lung normal instead in this particular location where no foreign body seen. You can say either lung normal, or you could say that you're looking for lung, but you're looking for foreign body, but there is no secondary hyperinflation, there is no expiratory radiograph provided for this particular. So at least the process knows that you know what you're looking for, you expressed it in the positive way. So at least instead of saying impression normal chest X-ray, if the suspicion is high, if there is a persistent, you advise the clinician what is the next step to do. I'm sure they will do it. But in this idea of giving the correct guidance to the patient and to the clinician, this is what should be mentioned. We are now assuming the clinicians know all this. Some clinicians actually get upset that if you advise them, but we have to do the right thing. Known breast carcinoma, follow-up X-ray, lungs clear is a statement. Yes, you could say that. Sometimes people use the word no major lung lesion demonstrated because we know that small nodule here and there, we may be missing it. Bony thoracic edge appear normal. This is something which I have reported, and the patient has got multiple bony lesions which are small, which are definitely not seen on chest X-ray, but seen on the CT scan or MRI. So we now started reporting as no obvious bony lesions seen. Again, if you're confident, yes, you could say bony thorax appear normal. So in summary, we have reviewed the anatomy, what is zone, what is a lobe, and we have reviewed the fissures and its associations and its relationship with the lobes. We use the right words for description. At least we come to know how do we describe and what the words we should use. And you have got the Flushner Society article available. You can go and read it. The technique of reviewing each and every radiograph, the way of interpreting either zigzag manner and comparing right and left opposite side, it is just for the lungs. And all the others is something which you can develop using these clues which has been provided. And review area is something which is important, not only for chest X-ray, but for every CT scan, everything. Otherwise, we will miss lesions. And where do we miss lesions? I'm going to show you an example that we can miss anywhere, and anybody can miss it. And how do we express some of the things in our report? We saw some examples. So we have to use it appropriately and take your guidance from your seniors and the people who has got experience of getting into trouble and how they got out of it. And these are all very, very important to avoid you, to give you a much more confidence and much more better interpretation. And the key thing is become confident in chest X-ray reporting. As a radiologist, it is something like a basic thing. It is like a driving license. You know how to drive, but driving license is important. You actually go there even before you drive. Sometimes you pick up the driving license, but it is an important thing. It is like a driving license interpreting chest radiograph. It's an important for your adult life. Thank you very much. Mitisha, I have completed. I'm just looking at Q&A if possible. How to trace horizontal or oblique fissure with landmarks? Okay, that one question has been asked by Nitesh Agarwal. Thank you, Nitesh. The horizontal fissure is located at the level as the people use the sort of starting from D4 and going towards the right cardiophrenic angle for the major fissure. Yes, that is one point, but sometimes not always useful. But as you know, the D4, D5 is the area is where the horizontal oblique fissure starts in the uppermost part. And the horizontal fissure is actually seen, but it is not always seen. If it is seen, you will be able to trace it, but if it is not seen, where will you see it? Superior inferior axillary fissure on chest X-ray or CT, it is seen on CT. Very rarely it has been shown on the chest X-ray as well. Okay, can you explain the concept of secondary hyperinflation again? Secondary hyperinflation is basically an hyperinflation due to some cause, like bronchitis or whatever. But in an area of hyperinflation, there will be vessels. If the vessels are normal, it is just called hyperinflation. Like, for example, a compensatory hyperinflation in a patient who has actually had a pneumonectomy or lobectomy. Okay, but when your vessels are shrunken or small, then you use the word mosaic perfusion or emphysematous changes. In emphysema, there is hyperinflation, but the vessels started going very thin. So that's a differentiating point. Can we describe GGO on chest X-ray or only in CT? Yes, we can use GGO on chest X-ray. If you're able to see the vessels going through a very vague opacity, nowadays we are able to window it, on the DICOM images. So you will be able to actually, appreciate even small opacities. How to identify segments of lung on X-ray? You will not be identifying each and every segment, but there are some segments are very, very useful. For example, if the patient has got a right middle lobe opacity obscuring the right heart border, then it has to involve the medial segment of the right middle lobe. And then if it is abutting the horizontal fissure, I showed an example, but it is not obscuring the right heart border, it has to be in the lateral segment of the right middle lobe. And you can see there is an opacity which I showed you in that horizontal fissure, where it is located above the horizontal fissure. It has to be in the anterior segment of the right upper lobe. And if you see a lesion in the right lung apex, it has to be in the apical segment of the right upper lobe. And if something is at the right lower zone, which is obscuring the right diaphragmatic border, then it has to be in the basal segment. Which basal segment is difficult to assess, but it has to be in the basal segment, but not in the superior segment of the right upper lobe. So these are all the some of the areas where you can localize the segments. Sir, can you help with hilar density and differential diagnosis? So that's a completely different talk. And the key thing is that the hilar density is equal on both sides in a normal chest X-ray. If one hilar, so the abnormal hilar has got two signs. One is enlargement. The other one is increased density in spite of enlargement. That's a question. That's an answer for Snehal. I think there are not much questions here.
Hi,
Thank you very much.
Hello, you can answer just one question which asked by Sailesh. What is prominent bronchovascular markings? We see it in reports. People say it's congestion bronchitis. Can you answer this once and for all?
Yes, that is a very, very useful non-specific term which is used by all of us, prominent bronchovascular markings. When you're going to say prominent bronchovascular markings, then you should be ready to accept the word congestion after that. The prominent bronchovascular markings suggests that normally you see the blood vessels up to about an inch away from the costal margin, right? Sometimes when there is a prominent bronchovascular markings, you normally see slightly more than the number of vessels. It is tend to reach more closer to the costal margin. It tend to be more slightly larger than the usual way. And it is associated with the cardiac enlargement, little bit of blunting of CP angle. That means we are started getting a little bit of early effusion. You look for curly B lines. So that means, we are dealing with pulmonary congestion, maybe due to cardiac failure. Maybe it is leading to the early effusion, which is starting, and there may be curly B lines due to interstitial pulmonary edema. So I personally use, and I am going to say there is prominent bronchovascular markings. It can also be been described in bronchitis. In bronchitis, sometimes you look for the slight thickening of the bronchial wall, and therefore it looks like a prominent bronchovascular markings. But I personally don't use, because you will be able to see an end on bronchi near the hilum, which will tell you whether the bronchial wall is thickened or not to say it is bronchitis. So if you wanted to use a prominent bronchovascular markings, that means the vessels are slightly prominent and we are dealing with a case of pulmonary congestion. Otherwise, we probably dealing with a normal chest X-ray rather than bronchovascular markings, because with the hyper, if you're going to do a high kV radiograph, when we sort of had the transition with normal chest X-ray to high kV radiograph, you will see everything as a hyper prominent bronchovascular markings. That's sometimes a normal appearance. Sanjeev,
thank you very much. That was wonderful. And thank you for taking time out of your really busy schedule. So thank you very much for being there for Masterclass.
Thank you, Sanjeev. Thank you all, and all the best.
Yeah, thank you. And you can just disable your screen so I can move on to Dr. Sanjay. Yeah,
absolutely.
Thank you very much. So we have with us Dr. Sanjay Jain now, who will be taking the next lecture. Dr. Sanjay Jain has been editor-in-chief of the Indian Journal of Radiology and Imaging for 3 years. And it was a wonderful period of 2013 to 2015. Tremendously important articles were published in that period. He was also ex-joint editor from 2007 to 12 with Dr. Bhavin Shankaria. So welcome, Sanjay, and good morning to you. And he will be starting his lecture on chest X-ray with pediatric imaging. Sanjay, can you, we can't hear your audio. Can you just switch your audio on? Yeah, bottom left, yeah. Can you share screen also, Sanjay? Dr. Sanjay will be right back. He's just logging in again. So just allow for a couple of minutes.
I need to share this, right?
Yes, Sanjay. Yeah, that's
okay.
Right.
Great. Am I audible, Mani?
Yes, very good. We can start actually. You can just.
Okay.
Yeah.
Good morning, everyone. At the onset, I would like to thank the sponsors of this event, AGFA and Indian Radiologists Group, floated by Mani, Jignesh, Shailendra, and Patkar, for giving me this opportunity. As a sequel to Arsu's lecture, we are going into the neonatal age group, and the perspectives in neonatal age group are a little different. We have large heart sizes to deal with, and certain things like air bronchograms are seen till the second generation of bronchi, and the diaphragm is normally seen till the 6th rib anteriorly, or you may say the 10th rib posteriorly. Anything less than that would be hyperinflation, and less than that, I mean more than that would be hyperinflation, and less would be lung high, what we call low lung volumes, basically hypoaeration or hypoinflation. Okay. The topic actually is respiratory distress. Okay, the appropriate discussion for the next half an hour would be respiratory distress. Remember, respiratory distress is a symptom and not a disease. A very common question that I have been asked by the neonatologists in day-to-day practice is there cardiomegaly. Okay, you see a thymus, which occupies almost the whole of the chest. It's going on the right side, the left side. But if you have to say cardiomegaly on a chest X-ray, the posterior heart border has to overlap the anterior margin of the vertebral bodies. When you see something like this, you are pretty confident about cardiomegaly on plain films. Otherwise, by and large, I'll show you a couple of cases in which there is cardiomegaly, but on a PA you can definitely interpret. But otherwise, it's very difficult to diagnose cardiomegaly on chest radiographs. Okay, unless in this situation. Not every neonate with respiratory symptoms have respiratory distress. Okay, that's very important. We have systemic causes, medical causes, surgical causes, and congenital anomalies and diseases. The volume concept is more of, just a take home for you to keep in mind, because diffuse lung disease patients may have absolutely normal lung volumes. So it's just uh, a guideline rather than a rule. So be particular about this. Just don't jump to high volumes, low volume based on whatever I've stated. You see multifocal consolidation in a newborn. The first thing which should come to you is these are large areas, large lung volumes, is sepsis. Okay, that's something which is very important for you to remember. And that's something which the clinician, the neonatologist will tell you. And you just need to corroborate with the chest radiography. These tend to become worse with time if the sepsis does not get corrected, and that would be the terminal event in this situation. Coming to important medical causes, we have preterm and term infant. So whenever you look at a neonatal X-ray, you need to know some basic history. Is it a preterm or it's a post-term infant or a normal term infant? That will really help you in coming down to narrow diagnosis. Like in preterm, we have a different set of diseases. Okay, we have typically low lung volumes, coarse granular opacities. The commonest that we know of is RDS. And the other infection, which is prevalent in the neonatal age group, is the beta hemolytic streptococci. And on the other hand, in term infants, we have perihilar streaky densities, high lung volumes, three situations commonly seen: meconium aspiration, TTN, and neonatal pneumonia. Coming to premature infant, we have two entities that I will be talking about: immature lung and RDS. Immature lung is typically seen, in 23 to 26 weeks of age. The findings are typical. You see coarse linear densities. The lungs may be of normal volumes or decreased or increased. You may not have air bronchograms, and you might see few areas of atelectasis. That's a classical example. This was just a 24 weeks, 540-gram child. Okay, very small, and he was kept in the nursery. So all you are seeing is perihilar streaks. Look at the lung volumes; they are pretty decent. Okay, so that's what a premature, a smaller version of it would look like. Here is another child. This is near normal X-ray, 27 weeks, nothing really to be done. Not all premature children, do have respiratory distress. That's something that you need to remember. You just need to keep them in nursery and they grow and they just move on. Coming to RDS, deficiency of surfactant leading to alveolar collapse, as we know. But most important, remember, children who are born by cesarean section and who are born from diabetic mothers, they also may develop RDS. So RDS is not always seen in premature. It can be seen in term infants. An important perspective, this is a type 2 pneumocyte. You see this pink areas that I'm showing, they would just come if you look at carefully. These are the areas where surfactant is released into the cytoplasm, and that's what decreases alveolar collapse. Now that's missing, so that's why you get RDS. What is the classical radiological appearance? Fine granular appearance of the lung. You see air bronchograms. One important, very important aspect radiologically and clinically is, if you see a normal film after 6 hours, like if somebody argues at 24 hours, can you have RDS? No, it never happens that way. RDS is something which will manifest immediately. The clinician will be the one who will tell you that this is RDS, and radiologically, it has to concur. And this is one condition in which you would see a lot of air bronchograms which extend peripherally. Remember one thing, in today's time, I seldom get to see, RDS with low lung volumes, as is the textbook description, because these are the patients who have been ventilated. Okay, they have already been given surfactant. So the volumes typically expand, and by the time you have a radiograph in front of you, all this would have happened. So definitely the old age concept of low lung volume no longer applies. Now, to stage it or grade it is something which I always like to delve. And we have stage one, in which you have fine granularity with some air bronchograms. Then we have distinct coarse granularity with extensive air bronchograms. Then we have increasing opacity with decrease in air bronchograms. Okay. And then we have a whitewash lung. Okay. In fact, you don't see any air bronchograms in that. These are the grades. Few of the neonatologists do ask me the specific grade, although I really do not put it down on paper. But definitely, these are the grades that you need to remember. And if asked to put it down, you need to look at it from this perspective. Okay. Then these are the examples of earlier, pictures that I had. We have fifth rib and, low lung volume. These are all the patients with RDS. Coarse granular appearance. This is an ET which has gone into the right bronchus intermedius, pretty down. In fact, it is again here. This is well positioned ET. I'll talk a little later on. These are all examples of RDS. Post surfactant, it changes the radiological picture. We see clearing of granular opacities and increased lung volumes. At times, you might see asymmetric response. Remember, if you see no radiographic findings, of response, it is associated usually with poor prognosis. Here, for example, this was day one, and you see clearing of, the RDS picture. And here we had an RDS and surfactant was given. You see clearing on the left side. However, the right side is still maintained. Here you see clearing on the left lung and the right side is still maintained. This is okay as long as the child is fine. Important complications, very, very, you need to be very particular about putting it, reporting it in your reports. I think that's really important. I'm going to show you examples. PIE basically represents interstitial emphysema, a very important finding, because in which case they have to decrease the ventilatory pressures. And this finding is critical for the neonatologist. Here you see these linear streaks, radiolucent streaks. This is nothing but PIE. You are the one who is going to pick up. Okay. The clinician would suspect something unusual. And he's the one who will actually ask, is there PI? And we have, of course, a right upper lobe collapse and coarse granular appearance bilaterally. In a neonate, do not hesitate to take a shoot through X-ray should the clinician or the neonatologist suspect a pneumothorax, because it can be very challenging to pick up a pneumothorax. For example, this radiograph, it's very difficult. Do we have any answers to this? Is there pneumothorax on the left side? Do we have a pneumothorax on the right side? And to be a little more analytical, I'm sorry, you look at the right diaphragm. It is very sharp in outlines as compared to the left diaphragm. Okay. And there is a collapsed lung here that you see. So this lucency, abnormally lucent diaphragm, this is what we call subtle finding of pneumothorax. So that's something that you always need to remember whenever you are interpreting radiographs. Here we have coarse granular pattern with mediastinal emphysema and surgical emphysema. You see air tracking all along. A bit of air is displacing the thymus, not so classical, but I'll show you one more X-ray. This is classically the displacement, superior displacement of the thymus by air, which is in the mediastinal cavity. And we have subtle air along the left cardiac border and the inferior border. That is the base of the heart. So this is nothing but angel. This sign is angel wing sign, and this is pneumopericardium. Okay. RDS, you can have complications like pulmonary hemorrhage. Remember, it's impossible to distinguish hemorrhage consolidation due to pneumonia on X-ray, you need to know the clinical presentation. Hemorrhage would present with epistaxis and hemoptysis, in which case the interpretation would be pulmonary hemorrhage. The causes are varied. They vary from surfactant therapy, complication of PDA, and so on and so forth. Here we have example of the CRP going up, and this is infection. We have large areas of consolidation bilaterally in the mid and lower zones. This was proven to be Klebsiella. Now this is a case of RDS. Day 1, day 10 there was hemorrhage, and later on day 30 we see coarse linear opacities with high lung volumes. These are pretty reasonable lung volumes. It's going towards BPD. An entity which is rare, yet you need to be aware of, is secondary surfactant deficiency. This was a patient with RDS. This is typically about grade 3. Everything cleared off, no issues at all. There is a bit of a persistent collapse here. This was thought to be a pneumonia. And again, there was a large area of consolidation on the right side, and we had to give surfactant again. So this is what we call secondary surfactant deficiency, and you might occasionally have to give a surfactant again. Coming to chronic neonatal lung disease, or CLD as we call it. Earlier it used to be called BPD. It's a disease of prematurity, and these are typically the patients who need ventilatory support. It's a catch-22 situation. All events that cause lung damage increase the need of mechanical ventilation, which increases lung damage. So this is a schematic diagram that I have taken effort to make, and I'll just cluster them today. This is typically the arrested acinar development that you get in post-surfactant BPD. Okay, you have collapse of the acini peribronchial fibrosis, and so on and so forth. This is absolutely normal situation. And you have thin septae. You see these septae, you have virtually very thin septae. And that's the pathology behind BPD. You have stages of BPD initially with ground glass still fibrosis and cystic emphysema, in which you might have a higher rate of mortality. That's a classical appearance. What I would describe as RDS would be areas of hyperaeration or emphysema with diffuse reticular opacities. You might see areas of atelectasis. You might see areas of cystic lucencies. That's typically the concept of our CLD. Here again, we have a CLD. There's a large lucency overlying the liver. This unfortunately was a perforation due to necrotizing enterocolitis. So this was nothing but a pneumoperitoneum. Coming to full-term infants, we have transient tachypnea of the newborn, meconium aspiration, and neonatal pneumonias. TTN typically occurs, in the initial 24 hours, and it's absolutely self-regulatory. You see coarse streaky opacities. You might see a bit of fissural fluid and so on. Now, if you see something like this, coarse streaky opacities, you might see a little fluid here and there. That's absolutely fine. And that's TTN and nothing else. Here, this was TTN on day 1, and 24 hours later, everything disappeared. An important concept is meconium aspiration syndrome, which is the first bacteria movement, below the vocal cords, and you have increased lung volumes, perihilar distribution, irregular aeration with pores, patchy densities, which move from the higher level to the periphery. You might see peripherally air trapping, which would be responsible for chemical pneumonitis. Air block phenomenon like pneumothorax, pneumomediastinum are pretty common. Now that's a classical appearance of large lung volumes with perihilar streaks and some consolidation. Here we have the ET tube right hand side, and you might find occasionally patients who are not responsive to be given surfactants. So this is absolutely fine, and it does really show good clearing in this situation. At times, we might see atelectasis, which is nothing but due to mucus plug. You repeat it now. You just, since an endotracheal tube is there, you just put in a bronchoscope, remove the plug, and all the lung expands completely. This is the classical example of air block phenomenon, in which we have a lucency which lifts the thymus, and this is called angel wing sign. We saw it earlier in RDS, and this is the sign which talks about pneumomediastinum. You might see pneumopericardium as well. Here, look at the lucency. Very subtle. You might be the first and the only one to pick up pneumopericardium. So don't hesitate to report if you do see. This unfortunately was a terminal level event. This was meconium staining and gross bilateral pneumothorax. I wish they had asked us immediately. They could have revived the child by putting in 2 intercostal drainage tubes, but it was too late. Neonatal pneumonias, most common beta hemolytic group B streptococci. Then you could have Klebsiella staphylococci, bilateral granular opacities. And if you have low lung volumes, the differential is RDS. Remember that. And very important, pleural fluid, the ranges, the existence is between 25 to 67 percent of the times. That's a classical example of staphylococcal pneumonia. You have a large pneumonia in the right lower lobe, and you see multiple cystic lucencies, in about 3 days, 4 days developing. So these are nothing but pneumatoceles. So this sums up the whole gamut that I have been talking about. Low lung volumes. Remember, low lung volumes can occur in premature children with neonatal pneumonias, and the rest is TTN, meconium aspiration, and neonatal pneumonia in term infants. Okay, that's the sum which tells us all. Surgical causes very important because the key decision making happens just based on plain radiographs and very, very occasionally CT, especially in the neonatal period. But later on, as we have bronchopulmonary foregut, which manifest a little later on, we have CCAM and things like that coming up. CLE, we need CT for that. Okay. We have diaphragmatic hernia. Remember, it's not just a finding, it's a syndrome. It comprises of many things, such as hypoplasia ranging to PPH. Now, this is how I've just shown a schematic diagram, a diagram of diaphragmatic hernia. So that's the diaphragmatic hernia. Even the liver would tend to go up in the thorax. Now, this was an interesting chest X-ray. The resident came to me, "Sir, do we put in an intercostal drainage tube?" I said, "Look, this doesn't look to be. Although I am not really seeing the diaphragm, this is definitely not pneumothorax," and we deferred it. We just repeated an X-ray again. I was sure this is a diaphragmatic hernia and nothing else. And so was the pediatric surgeon, and they operated. This is the post-op X-ray showing the various tubes and lines, which I'm going to show you a little later on. This was pretty much expanded left lung. Of course, there is some bit of hypoplasia involving the left lower lobe, which is usually associated with diaphragmatic hernias. Lateral, anterior, and central tendon defects are the various types of hernias. Is this a diaphragmatic hernia or this is a eventration? You are still seeing the entire diaphragm properly. You can see this. So this is nothing but eventration. Very important. Look at the tracheomediastinal shift. The trachea is shifted like this. The mediastinum has gone pretty much on the right side. So this is, a massive eventration. Remember, pediatric surgeons take eventration, severe eventration, as a diaphragmatic hernia. Congenital pulmonary airway malformation is the other situation. It used to be called as CCAM. It's basically a hamartomatous lesion. We see proliferation of bronchial structures which form cysts and lack alveoli, and the associated airways which supply the like cartilage. Stocker classified them, this is a recent classification in which they have added type 4, which is large peripheral cysts. And 4, it may be, they say on pathology, it will be difficult to differentiate from type 1. So in a sense, we have, these types to look at. Type 5, type 1 is basically, 2 to 10 centimeter large cysts shown here. Then we have small cysts about 2 centimeters or less, multiple small cysts. That's, I've shown it schematically here. And then we could have a solid mass, which they are all microcysts. Now that's a classical example. Your large opacity, well defined, no air bronchograms. You do a CT, you see, kind of septations, and this might be a slightly not exactly hypointense, slightly isodense to hypodense. It's and this is classically an example of congenital pulmonary airway malformation. Another case, you see multiple large cystic lucencies in the left mid-comma lower zone on the chest lateral. That's the area. And CT is diagnostic. We need to do. You see multiple cysts. Okay, they are, again, more than 2 centimeters. This is typically type 1. And occasionally you might miss CCAM on plain films unless you look very carefully. For example, here, it's to be picked up on this. And, on the lateral view that we took, this was in the posterior basal segment, subtle lucencies, and on CT, there was confirmation of the same. CLE is not a specific disease. Most of the time it is the left upper lobe, or 20% of the times it's right upper lobe, and intermediately you may have the right middle lobe which is involved. You will see hyperaeration or hyperinflation of the lobe which is involved, and you might see compressive atelectasis. Most important, usually no septal or cyst walls are seen within the expanded lobe, and there is, most important, contralateral mediastinal shift. CT is diagnostic. You really don't need to do anything beyond CT. That's an example of congenital lobar emphysema. Look at the mediastinal shift. That's significant. That's the heart on the left side. And during surgery, the surgeons do tell us that this is nothing but a spongy lung. And another example, we have area of hyperaeration or increased translucency in right upper comma mid zone. The rest, there is atelectasis involving the right lower lobe. I'll show you the CT. We had a classical example of, again, a right upper lobe involved. So that's the CT, and it shows markedly, a hyperinflated right upper lobe and causing significant mediastinal displacement to the opposite side. Again, another example of massive hyperaeration of left lung. I felt there is something wrong at the hilar level because I was just not able to trace the left bronchus. We did a CT. It shows a classical cystic lesion at the carinal level, the classical location for a bronchogenic cyst. Bronchogenic cyst, very important. You see normally no wall enhancement unless it is infected. And you might see mucin content in which the attenuation value goes up. One example that I want to highlight here, there is a bit of hyperinflation in the left lung. The right lung seems to be okay. Look at the diaphragmatic borders. This is definitely depressed. And this is classical appearance of pulmonary sling or aberrant left pulmonary artery. I'm showing you this picture for a reason. This goes between the trachea, this is the trachea, and the esophagus posteriorly. And the reason I'm showing you, because I want you to understand the concept of indentations of the aortic arch and the trachea over the various structures over the trachea and the esophagus. This is the anterior trachea, and this is the posterior esophagus. Okay, so just remember that we have this situation. For example, the double aortic arch will have indentation over the anterior border of the trachea and the posterior border of the esophagus. Then innominate artery compression would be just along the anterior border of the trachea. Aberrant subclavian artery would have indentation along the posterior aspect of the esophagus, and the aberrant pulmonary artery, which is the left pulmonary artery, is the only anatomical structure which would indent the posterior aspect of the trachea and the anterior border of the esophagus. Tracheoesophageal fistulas in the neonatal age group, the commonest that I have seen in day-to-day practice is the type 1. The rest are there in which you have no fistula, you have proximal T fistula, no distal fistula. And then you have upper and lower fistulas. That's what we call double fistulas. And this is a single tube, and or what we call H or N type fistulas. Now, the most important thing as radiologists is we need to at least pick it up. You just put in a Ryle's tube, and if it coils, in the upper esophageal pouch, that's the end of the story. This is a tracheoesophageal fistula and nothing else. Regarding congenital anomalies and diseases which cause respiratory distress, we have intrapulmonary, which is cardiac. Now, this is type 1, this is 1, and type 2, which is what we always remember as the figure of 8 or the snowman's heart. Okay, these are cyanotic congenital heart diseases responsible for respiratory distress. Although common atrial canals and PDAs also can cause respiratory distress, they fall in the spectrum of non-cyanotic or acyanotic heart diseases. Congenital Congenital pulmonary lymphangiectasia is a diffuse reticular, or you see diffuse reticular or reticular nodular opacities. They usually present in infancy, late infancy, or first, second year. They might be seen with lymphatic anomalies such as Turner syndrome or Noonan syndrome. This is an example. You have high lung volume with Coats reticular opacities. Remember, this is a diagnosis of exclusion. Tracheomalacia, a concept which pediatric surgeons keep on talking. They really don't need us when they want to diagnose tracheomalacia. You, of course, need to do paired inspiratory, expiratory X-rays and CT. CT is diagnostic. I have one example to show you. You see diffuse narrowing of the trachea. Okay, if you're lucky enough to take it in 2 phases, you have the various types of narrowing in which you have generalized hypoplasia, and you have what we call funnel-like changes, and then you have segmental changes. Now that's the CT that shows the trachea in inspiration, and on expiratory views, you see a C-shaped luminal narrowing of the trachea. Endoscopically, it is called fish mouth appearance. This is a normal appearance, and the pediatric surgeons are pretty confident about it the moment they put in the scope. Extrapulmonary would mean, bony anomalies such as osteogenic imperfecta, asphyxiating thoracic dystrophy, thanatophoric dysplasia. All of them actually cause respiratory distress. Here we see decreased in mineralization, multiple rib fractures. Okay, and that's osteogenesis imperfecta. This is a textbook picture of thanatophoric dysplasia, short ribs, bell-shaped thorax, and that's thanatophoric dysplasia. Tubes and lines, an important concept in interpreting neonatal chest. Not to forget, the ET tube should be 2 centimeters above the carina. The umbilical arterial catheter should be at the level of the 6th to the 10th ribs. The umbilical venous catheter should be at the base of the right atrium. Typically, if you measure it, about 0.5 centimeters to a centimeter above the diaphragm, that is the ideal position of these interventions. That's an example. That's where the umbilical venous catheter should be. And we have 2 positions for umbilical arterial catheters. Higher ones, T6 to T10, and the lower one is L3 to L4 levels. Basically, is to avoid the ostia, the celiac, SMA, IMA, and the renal veins. Now that's the plain radiograph, which shows a normally positioned endotracheal tube. We have a well-positioned umbilical arterial catheter. Remember, umbilical arterial catheter dips as you go down in the pelvis, and then you trace it up. That's the arterial catheter. This is a nasogastric tube or the Ryle's tube coiled in the esophagus, not an acceptable thing. A highly placed endotracheal tube is not acceptable. It can get extubated. You need to just tell the resident or whoever. What do you think about this? I don't know whether we have the chat box option.
Yeah, we have it on. Sanjay, we have it on. Yes.
Okay. Anybody wants to answer this? What's up? What do you think is wrong with the endotracheal tube? Is it where it is supposed to be, or it's somewhere else? We have the nasogastric tube also going down.
So they have said ET tube in stomach.
Well, stomach, actually, it's more of the esophagus. Absolutely correct. And you see massive distension of the stomach. Okay, that's iatrogenic because the ventilatory pressures are going into the stomach. Okay, absolutely correct. Here we have endotracheal tube in the right main bronchus, not acceptable. There should be a collapse any moment of the left lung. Umbilical venous catheters, as they go through the portal sinus, you can see a slight bit of a curve. So that's the point to remember. And don't forget the classical dip of the umbilical arterial catheter in the pelvis. Here we have a constellation of everything crazy. We have endotracheal tube in the right main bronchus, which is causing collapse of the left lung. Umbilical arterial catheter, which is way up. It is almost at about T5 level, not acceptable. It is probably reaching close to the origin of the subclavian. And we have umbilical venous catheter, which overlies the liver, which I would expect it somewhere over here. Okay, so that's the bridge that they need to cross. They need to withdraw the ET. They need to pull it down a bit, the arterial catheter. Then we have umbilical venous catheter in the right atrium. The nasogastric tube, look carefully, it is in the distal esophagus. So if you are feeding, there's a good chance of aspiration. This ought to be in the stomach. Okay, so that's something that you need to remember. Here we are seeing coiling of the umbilical venous catheter in the right portal vein. Here we see the umbilical arterial catheter at T2 level, not acceptable. Immediately they need to withdraw it or push it way up. And the venous catheter has looped in the superior mesenteric vein. Here the venous catheter has gone into the splenic vein. This was pretty aggressive. The umbilical arterial catheter is at the aortic arch level, extremely dangerous. And the venous catheter has gone through the foramen oval from the right atrium into the left atrium. Okay. And remember, after cannulations, many times we see portal venous gas. Remember, in such a situation, you need to ask the history. When was the cannulation done? If it's within an hour or two, for God's sake, don't report this as necrotizing enterocolitis. This is absolutely normal variation. And this is just iatrogenic air which has been introduced, and nothing really needs to be done about it. This was unusual. If you have a femoral line supporting the patient, then the line again has to be at the base of the atrium. It should just end here. Unfortunately, this is going right up IVC, right atrium, SVC, right into the internal jugular. Pretty aggressive approach. So that's the summary of what we saw: premature conditions, post-maturity conditions, surgical conditions, congenital anomalies and diseases, lines and tubes. Mani, do we have time or I should quit?
5 minutes more.
Great.
Yeah. Oh.
I have some questions. I would request, I don't know if the pad thing is in place or not. They can, put it from their cell phones. I don't really know. But I have Q&As. I have just 5. They are very simple slides, but thought-provoking. Now, this is the chest X-ray. This is question 1. Just see it carefully. I have shown you, if you were very attentive in the lecture, you should be able to answer it. If you were not, it's perfectly okay. It's your problem. Choose the correct one. Do you see pneumomediastinum, pneumothorax only on right side, pneumothorax bilateral, or you see pneumothorax on the left side? Mitusha, or do we have any answers to this?
Sir, I think the third option, and few are towards second one also.
Okay, great. I'm glad at least people are looking at bilateral. Now look at the left diaphragm. This is pretty decent the way it should be. You might mistake it for something, but still this is okay. There is nothing here laterally. But this diaphragm, definitely there is marked increase in lucency, and it is very sharp in outlines. And that is the collapsed lung. I am showing it to you. I am drawing it for you. That is the collapsed lung. Okay. So definitely the correct answer is there is pneumothorax only on the right side. Then question 2. This is the radiograph of a patient that I have shown you earlier on. Which line tube is incorrectly positioned? Umbilical arterial catheter, umbilical venous catheter, or the endotracheal tube? I don't know. Mitusha, you need to get back to me on
Yes.
the
So they're
answer.
saying most of them are saying second, but few are saying third one also, sir.
Okay, great. I'm glad. See, the endotracheal tube, as long as it really in children, if it is about 2 centimeters above the carina, it's pretty okay. Unlike in an adult, where there's a good chance that it may go into the right main bronchus. This is pretty okay. So don't bother about that. The umbilical arterial catheter is well positioned. It is the venous catheter which is a problem. It is overlying the liver. It needs to be pushed up and it needs to go here, okay, at the base of the heart. So that's the answer for umbilical venous catheter. Question 3, very simple. We have seen this X-ray again. We are seeing actually this X-ray again. The Q&As. So I'm sorry. I jumped it. If nobody saw it, then it's okay. What is not present? Pneumothorax, pneumomediastinum, pneumopericardium, subcutaneous emphysema. Just get me the answers.
So they're saying the first option.
Great. I'm glad they were very attentive. Very glad. This is the angel wing sign. That is pneumomediastinum. This is pneumopericardium. And we are seeing air going into the neck. So this is subcutaneous emphysema. So basically, the correct answer is pneumothorax. This would be a challenge. I hope so. This is a premature child who had an endotracheal tube, in the right main bronchus. There is collapse of the left lung. I'm describing. The questions are not related to that. And later on, we told them it pulled it up. Look at the distance. That is the distance that you would expect in a neonate. Don't expect anything more than this. Okay. But there is something else which is happening. Which abdominal condition are we dealing with? This is a premature child, as I have already stated. The options are liver abscess, intestinal obstruction, midgut volvulus, or pneumoperitoneum due to necrotizing enterocolitis. Could I have some answers?
So they're saying third one.
Oh,
Third
great,
option, yeah.
great. I also was honestly lost in this case, very much lost. Remember, this is not bowel. Okay, let's go back. You already had liver lucencies to begin with. These are all taken about 2 to 3 hours in the interval. Okay, you are seeing increased lucencies. So definitely this is something significant. Here we see the entire liver to be, almost radiolucent. So this was a bit of confusion, but when I got the history and I knew that this is a patient with RDS, and all that I had to put down was this is perforation. This is pneumoperitoneum. Perforation really doesn't look classically the free gas, that we see in adults. Perforation in children looks different. That is nothing but perforation, and the correct answer is pneumoperitoneum due to necrotizing enterocolitis. Remember, if the child is premature, you have RDS, the abdominal condition that is most worrisome to a neonatologist is necrotizing enterocolitis. Again, I'll repeat on an X-ray, how to diagnose necrotizing enterocolitis, fixed focal dilated bowel loops. Okay, if you see that, if you have been following it up for the next 24 hours, fixed focal dilated loops, that is the answer for diagnosing necrotizing enterocolitis. However, if you see something bizarre like this is nothing but perforation. The last question, this is pretty straight, but I'm not sure how many of y'all would have seen it. This was a premature child. He had developed classical bronchopulmonary dysplasia, and some shadows, acinar shadows here, and on the lateral view, they're all clustered here. And there's something else. What's correct? Is it just CLD? Is it CLD with pneumonia? Is it CLD with pulmonary edema? It is CLD with pneumomediastinum, or CLD with pneumonia with apical lung herniation? Anybody? Mitusha, please
They
give
are
me the.
seeing the fifth option, sir.
Sorry?
The last one, fifth option.
Wonderful. Excellent. Look at the X-ray carefully. Go back. So you see this lung herniation here in the right apex, and you see this lung herniation in the left apex. And the correct answer is, of course, there. And remember, this lung herniation is just a bit of unusual phenomenon. You need to know it as radiologists, and this is caused by the weakness of Simpson's fascia, which is a strong facial connective tissue which overlies the superior thoracic inlet. And most important thing, if you see something like this, for God's sake, don't tell the surgeon, or the surgeon, if he asks you, I need to push the lungs down, don't tell him. Don't tell him to do any such mischief. This nothing really needs to be done. As the child grows, the situation improves, and this actually goes back into the chest. This is an article. This entire talk, you can read it as an article. I think they are porting, they are moving from, the IGRI is moving from Walter's Clore to theme. So you may not be able to access it, but whenever it becomes online, this is just published last quarter. So everything is there inside it. You can have a look, read it. And thank you very much for your attention.
Thank you, sir, for taking this really important topic with these details and making it simplified for us. So I'll just check if there are questions, if we can take few important ones.
Sure, sure. I think there is nothing much. Slide of PT and RDS I have already seen. Right pneumothorax I have already shown. Anyway,
Yes.
I think these are all
Answers
related.
we are giving, to
Yeah.
these questions.
Yeah. Okay.
Yeah. Okay. Thanks a lot, sir.
Okay. Thank you.
So if you could just stop your screen sharing, I will just do it. Yeah.
Okay. Done.
So after this wonderful talk, we have covered the chest X-ray introductions by Dr. Anbarasu, and now we read and learned about the neonatal X-rays by Dr. Sanjay Jain, and a lot of important topics coming up. Before we go ahead, I would like to bring to your notice that the 20th MRI teaching course will be again this time as the monsoon edition, and this will be 7th, 8th, 13th, 14th and 15th of August. This is an elaborate and comprehensive course spread over 5 days. It's a hybrid version, online, on-site, both. So the details of the program will be shared soon, but please block your dates and do register for this course. Also, Indian Radiologist is coming up with full day sessions on focused advanced imaging topics like breast imaging and cardiac imaging. The breast imaging masterclass will be on 16th of May, and eminent international and national speakers will be there, and entirely it will be a case-based approach. So stay tuned and do register for these focused masterclasses on breast imaging, and later we'll come up with the cardiac imaging as well. So before we go ahead with the next session, which will be by Dr. Sumit Datta, I would request our educational partner AGFA and Sunil from their end to please take over.
Thank you, Dr. Mitusha.
Thank you, Snehal. You can start your slide share. I'll just stop mine.
Yeah. Good morning, everyone. My name is Snehal Khilari, and I take care of product and marketing for AGFA. Today, I would like to bring to you AGFA. I would like to introduce AGFA to you along with this product portfolio and what are some of the key unique launches that AGFA has taken So let's move forward. So AGFA is a Belgian-based organization having its headquarters in Montreal. Basically, it's backed with 150 years of experience. Thus, we say imaging is in our DNA because it's backed with more than a century of imaging experience, which enables us to deliver diagnostic imaging solutions that set standards in productivity, clinical value, and cost effectiveness. So, giving you an insights about AGFA India. So, it's a 450 crore organization with a fairly decent market share for all its product portfolios, PHCR, PR, or imagers, and also a very strong team into sales, service, and channel partners. So, we are having around 70 plus channel partners for sales and an equivalent number for service as well. So moving towards the portfolio of AGFA, we have the CR portfolio. Here we have different ranges of CR comprising which can cater to different levels of institutions, diagnostic centers, patient workload, application, be it different departments. So in case anyone who wants to start up a new center, okay, here we have CR10X, which is an solution with easy payment scheme. Thus, anyone, I mean, you can have financial options as well into this solution. Also, these are CRs which can cater to different applications like general radiography, full leg, full spine, OPG, and also veterinary. Out of these, a unique solution that we have is everyone would have heard about uh, phosphor image plate, but we have along with phosphor image plate we have something called as needle image plate. So what does needle image plate mean? So it is basically a sort of a image plate which is more or less equivalent, or it can be compared with the recent DR detectors. The make and the structure is equivalent to the current DR detectors. Here you can see that the crystals in the image plate or the scintillator are arranged in a very uniform manner. Thus, it reduces a lot of scattered radiation, and also it reduces a lot of dose that is delivered to the patient. Thus, you can achieve more about 60% of dose reduction and also achieve superior image quality. It is ideal in case of examinations where you have to deliver a high exposure dose like spine or sacrum or pelvis examinations. Also, we have other solutions for mammography and also for FLFS as well. So as we all know that the entire world is transforming to digital radiography. So we also have a lot of other solutions in the DR range, depending upon different application, different departments, different level of institutions, different patient workload as well. So here we have mobile DR, which is ideal in case of ICUs, bedside examination, OT or emergency ward. So also in the current context of COVID, mobile DRs are absolutely working extremely sturdy and they are very beneficial. Also, we have the UARM, which is a full room DR, which is completely automatic. It can serve or cater to a workload of around 300 to 400 patients per day. Then moving on, we have the ceiling suspended, wherein you can see that that the tube is mounted on the ceiling. It's again a full room DR, which can bear a workload with heavy workload of around more than 400 patients per day. Then moving to a floor mounted DR, this is where your tube is mounted on the floor. Thus, it has a capability of catering to a workload of around 300, 400 patients per day. Today, you can upgrade your existing analog modality to DR directly without changing your existing analog modality. That is through the help of a DR retrofit. So this is how you can do it, which is like an easy upgrade solution. When you buy a retrofit along with the workstation, you can directly upgrade yourself to DR at a very cost effective, affordable solution. We also have the imagers, which are the diagnostic printing portfolio. We have imagers depending upon where you want to configure these images to different modalities like CT, MRI, ultrasound, mammo, and also to different workload. Like in case if you have a small workload environment, you can have a single tray printer or a dual tray printer, and moving on to a very high volume centers like government hospitals or private hospitals, you can have the three tray printer as well. So these are so the films are capable of daylight loading, so it's very convenient for anyone to use this. So MUSICA is an acronym to multi-scale image contrast amplification. It is basically a nerve center for the entire CR and DR workflow for AGFA. So basically we call it as a gold standard because it is a very intelligent tool. It doesn't require a lot of post processing, and it is independent of exposure parameters or improper positioning or collimation also. So it will automatically analyze the image and deliver the right image quality very instantly, and that's we call it as a first time right image. Also, it facilitates excellent connectivity, thus it can be configured with the existing RIS, HIS, PACS, etc. And it is compliant to the current regulatory standards like HIPAA, and also it is cyber secured. Thus, it would help in securing your data by not misusing it by anyone else. So as we all know that the entire world is fighting against COVID. So as an initiative from AGFA as well, we also wanted to assist in the battle wanted to fight against COVID. So that is the reason we came up with this unique campaign called #CountOnUs. So wherein AGFA supported to fight this battle with its most advanced software, which is MUSICA Chess Plus, which is for gridless bedside imaging, free of cost for 9 months. So what happened because of this is that the number of patients were increasing, but the workflow was also increasing by around 30%. So this proved to be very useful tool during this trials because as you all know that like it requires very minimalistic post-processing parameters, and no in fact post-processing is required, and also it is independent of improper exposure also. So we had installed these softwares across India in various COVID centers where we had our solution. So one of these center is in South, which is ICRA Hospital, for which this is a customer testimonial. In case if anyone wants to read this, you can please visit our website under the Count on Us campaign. You can find this article, or you can share it across on WhatsApp. So I would like to ask everyone a question. Is digital transformation a necessity of time? If your answer is yes, do you want to elevate to high quality digital radiography? Again, if your answer is yes, then this is a solution from AGFA. It's a floor mounted DR solution, which is a newly launched solution. So let's have a quick look at the solution. So it has DR400i is basically a first-in-class 32 kilowatt monoblock generator with a very high frequency of 200 kilohertz. What does monoblock mean? Monoblock is something wherein you have the high tension, the high voltage tank directly in the tube head itself. So you reduce the high voltage cables running from the generator to the tube. This saves a lot of space, and basically it doesn't have, you don't have the cables being hanging from the tube head to the generator, and your movement of the tube head becomes more flexible. Also, it has the vertical wall stand for chest and standing X-rays. You have the touch screen display over here for controlling your exposure parameters and collimation and everything over here. Then you have the fixed table and a four-way floating tabletop for easy patient positioning. So overall, it gives a very different look and feel as you compare it with the existing modalities. When this entire solution is combined with the existing DR detectors of AGFA, okay, be it of different size, like be it 14 by 17 or 17 by 17 in size, which you want. And also the scintillator meat, it best suits the clinical exams and the budget requirements of the customer. So what are the clinical benefits that we offer with this? As you all know that there are a lot of aged analog modalities available in the market, which yield poor image quality and consume a lot of radiation dose. So this is an ideal solution for this because when this entire solution of 32 kilowatt generator with 200 kilohertz frequency combined with the AGFA detectors and music image processing will altogether give you a very superior image quality and reduce your dose. These modalities and modalities are prone to repeat failures. So, with this as an upgrade, you would get a very high quality solution and also service from a very reputable brand from the market. With this solution, we also offer a lot of clinical and dose efficiency tools, which we can have a look at further. So also, as I told you, with all these added features, it provides operational benefits like excellent workflow, improved throughput, productivity, and it's a very, due to being a very easy and user-friendly solution, it gives altogether a very different patient experience to both patient and radiologist. So what are the clinical tools that AGFA can offer? One is full leg full spine solution. So what does full leg full spine mean? So it's a non-invasive technique to evaluate a spine in fraction of seconds if possible. So these are some of the images as you can see over here. So this potential application includes accurate measurement of spine angles, okay, and distances between skeletal entities, assessment of the evaluation of therapy over time, and identification of orthopedic surgery indication. So these are some of the clinical advantage tools that you can benefits that you can opt with this tool. Also, you can see we can stitch 3 to 4 images together in a very seamless manner automatically with a very continuity and without any distortion and without any clinical rows of information and provide accurate measurements across for further diagnosis. Second orthopedic tool that we have is OrthoOne. So what is OrthoOne? It's a application which helps in calculating difficult and time-consuming measurements instantly and with accuracy and precision. So here are some of the examples like iliac index normal down, CCD angle, Cobb's angle, or full leg measurements that you can opt or which can guide you to kind of complete this examination very much faster. OrthoOne package is intended to assist clinicians in the analysis of anatomy and pathology by providing 2D interactive measurement scheme and comparison against the normative references to aid diagnosis of disorders and deformities. So there's a guided procedure that you have to follow by following these dots, and within fraction of second you get these images measurements directly. You also have a comparison done to understand it, and it can be used in the fields of musculoskeletal radiology, orthopedic, traumatology, pediatric, etc. Thank you very much for your time. In case if anyone wants to further understand any of these solutions in details, you can please call me up. You have the number on the WhatsApp group as well, or you can contact AGFA and we can get in touch with you. Thank you very much for your time.
Thank you, Snehal, for giving us these details. And once again, we are thankful to AGFA for their constant support for this academic event.
Thank you.
Good morning, sir. Good morning, Dr. Datta.
Yeah. Good morning.
So, sir, I think, sorry to bother you, but there was just a message from Dr. Upreti. He was just requesting if he can take his session first. He has some other meeting lined up. If it's okay with you, then only. Otherwise, we take yours. I was trying.
Okay. So I'm in the waiting. Okay.
Extremely sorry, sir. Extremely sorry.
Okay.
So first we'll take the session by Dr. Upreti sir, and then we will continue with the session by Dr. Datta sir. So I would request Upreti sir to kindly start his screen sharing. He'll be talking about science in chest radiology. So, Dr. Upreti is immediate past chairman of ICRI and Dean Rajiv Gandhi Super Speciality Hospital, New Delhi. Sir had taken extensive session yesterday, which was of benefit to all the residents and the consultants as well, on topics like HSG and barium studies. We welcome you, sir.
Hello.
Yes, sir, you can start your screen.
Okay, thanks a lot. So, thank you so much for allowing me to, for changing your schedule and allowing me to start. So, this is now a talk on science in chest radiology, recognition and utility. See, there are numerous science in chest radiology, but this talk would be focused on the signs which are seen mainly on the chest X-ray and which are useful to you in your day-to-day practice. Okay. So why do we need these signs? The signs basically they signify a very recognizable and characteristic pattern of matching appearances of abnormality. So once you know that this sign is being talked about, it is usually associated with a kind of finding or a pattern, so you can immediately correlate and narrow down your differential diagnosis. Most of these signs they help in localization of the lesion, especially on conventional radiology, and also in characterization, that is what could be the underlying pathology and making a good differential diagnosis. So as you would see as we go along the talk, Dr. Felsen, who is the author of that classic book on chest röntgenology, he had this propensity of naming this sign. So when he was asked that why this thing is there, that he would try and find a pattern, then make an uh, converted into a named sign. So he said this name saves times, helps you remember the sign and advertises it. They say what I mean. So actually what it means, once you know what this sign means, you can just look at that particular thing, interpret it that way, and make a good interpretation and a differential diagnosis. And most of the sign what we have in conventional radiology, the majority one which are useful in your day-to-day reporting, they are be described by Felsen. So that we see as we go along. Most important thing in conventional radiology is this Sillard sign, which was described by Felsen, and many other signs, they are basically extension of this sign only. They are just applied to different anatomical areas. So just this we need to remember. What is Sillard sign? This is how Felsen described it. This is, I'm just reproducing verbatim as given in his book. An intrathoracic lesion touching a border of heart, aorta, or diaphragm will obliterate that border on the röntgenogram. An intrathoracic lesion not anatomically contiguous with the border of one of these structures will not obliterate this border. So there are important thing here that there is a lesion and then there is a normal structure. All right, and when they come in close contact, so the interface between them would be totally gone. Just remember from your anatomy, we have a cardiac silhouette, we have the diaphragmatic silhouette. So if any lesion is present close to that, all right, and it is touching that, the interface between them, that would be obliterated. So this is what is known as the silhouette sign. It relies upon the radiographic densities of the structure, and it is a very important localizing sign. And most of the signs which are used for localization are a corollary of the silhouette sign only, and both its presence and absence, they are important. One thing that you need to remember, although this is described in thoracic radiology, this works everywhere. It works in abdomen also. In abdomen, you know that, for example, there is kidney shadow, and kidney shadow is very well seen because there is fat around it. Because and when there is soft tissue density, supposing there is retroperitoneal mass in that area, which is not fat density, that particular contiguous segment of the kidney and the psoas shadow, that would be obliterated. So that way you can localize a region to the retroperitoneum. Important point to remember is that the silhouette sign works on the principle that the two structures are contiguous, number one. Number two, most important that you need to remember, that they are of similar density, right? So soft tissue lesion touching a soft tissue structure will produce a silhouette sign, but an air containing lesion or a bone lesion or a calcific lesion, if it is touching a soft tissue density border, it will not be obliterated and you would not be able to localize a lesion. Okay, so just to re-emphasize, contiguity is important and density is important, right? So now we see the example of silhouette sign. Here what we see, this is basically CT scanogram. We see this is a big mass, and we know the right left cardiac border here, it is formed by the left ventricle. Now the interface between this density and the left ventricular border, that is obliterated. So here the silhouette sign is positive, and we know by definition that the left ventricular margin is lying anterior, so this opacity is lying anterior. Okay, you can very safely say that this mass is placed anteriorly on the plain X-ray, and this you can corroborate on CT scan also, where we see that there's this huge mediastinal mass which is lying, kind of lying in close contact with the left ventricle and producing this silhouette sign on the chest X-ray. Now another case, what is happening here? You can see this is basically a case of mitral valve replacement. Okay, and here on this side again we see that the upper cardiac border is not seen well. Okay, so that means there is obliteration of this border. Silhouette side is present on the right side, and so this is lesion. This lesion is most likely is present anteriorly. You can see the lower border is also gone. The part of the right border is seen here, but in the inferior part it is lost. So at some point along its mass, along some point this mass is contacting the right atrium. Okay, so part of it is definitely lying anterior. So here you can see this is the X-ray, and corresponding CT scan, you can see this mass lesion is touching the right atrium, right? And we could make that diagnosis here also, you can see. So we can make the diagnosis on the plain X-ray itself. All right, another case. Now, do you see the normal contour of the cardiac shadow? You don't see it at all. The entire cardiac silhouette from the upper part to the lower part is gone. So that means there is mediastinal widening that you can see very clearly. You don't see the right cardiac border. Okay, so that means this opacity, which is the left cardiac border, so this opacity is present anteriorly and obliterating the left cardiac border. Similar thing you can see on the right side also, and you can see another density. Okay, another density which is also kind of obliterating the right heart border this side. So on both sides the cardiac border are obliterated, bilateral process. So most likely on chest X-ray you can deduce that this process is lying anteriorly. All right, so this is the CT scan. You can see in the lateral view this retrosternal space that is totally obliterated, and on the CT scan you can see there is this huge lesion, mildly enhancing lesion in the prevertebral space. We are not going right now into the differential diagnosis of this. This is just to emphasize that how you see the things on chest X-ray. You're very well conversant with the CT anatomy, and CT localization. And but same thing, if you are careful, if you are aware of these signs on conventional radiology, you can make the same interpretation on the chest X-ray itself. Okay, like we decided that uh, the left border is gone, the right border is gone, so it's a bilateral lesion which is lying anteriorly and very well seen on the CT scan also. All right, so now what is happening in this case is the left cardiac border is clear. There is an opacity present here. It's a triangular kind of opacity, and if you look carefully in the upper part, the right cardiac border is gone. Okay, so which part of the lung contacts the right heart border? This is the right middle lobe. And also you can see there is this sharp outline to this inferior margin. Okay, this is basically the oblique fissure, which is because this opacity is lying in the right middle lobe. This is the oblique fissure. This is the lower lobe. So this sharp interface is being produced here. You can also see part of the, maybe you are able to appreciate, you can see part of the horizontal fissure also. But the basic thing here is that the right cardiac border in the upper part, that is obliterated, sorry, in the middle part is obliterated, and this is a feature of right middle lobe pathology. Okay, remember that, and you would see a very sharp configuration of the fissures also. You could, like here you see a oblique fissure very nicely, and same way you can see the horizontal fissure sharply on many occasion. But you do localize this pathology to the right middle lobe, that is for sure. So this is the lateral view where you see this opacity which is present in the, which is subtending in the region of hilum. This particular border is being formed by the oblique fissure which is shifted anteriorly. This particular border is being formed by the horizontal fissure which is got displaced inferiorly. Okay, so again this is a right middle lobe collapse. This was basically carcinoma which was obliterating the right middle lobe bronchus. Now see this particular case. You can see the right cardiac border very nicely. All right, what you see is that there is an opacity which is present behind the heart. Can you see? This is the cardiac shadow. There is a soft tissue shadow which is present and very nicely seen through the heart, and it also has a sharp border. So this kind of appearance is seen in cases of lower lobe pathology. You can see there is obliteration of the contiguous segment of the diaphragm. Okay, so this part is contacted usually by the posterior and medial segment of the lower lobe. So what we have is a soft tissue density which is obliterating the adjacent diaphragm, okay, which is kind of pulling the oblique fissure down. All right, so this is a feature of right lower lobe pathology. This is not right middle lobe. Right middle lobe would cause obliteration of the right cardiac border, which is not happening. Okay, so this impression you can make, diagnosis you can make on the chest X-ray itself. See, this is a slightly penetrated view where all this pathology is very sharply outlined, the right cardiac border and this opacity, the fissure being pulled down, and there is obliteration of the dome of diaphragm. And lateral border, you can see normally we have this lucency increasing as we go down along the vertebra. So that is not happening here. We are seeing an ill-defined soft tissue shadow. So meaning that there is some pathological process here contributing to this soft tissue shadow. And this is the CT scan where you can see that the right lower lobe is, part of the right lower lobe is kind of collapsed. You can see there is obliteration of this posterior and the medial segment, which we could see on the chest X-ray also, and a mass is present here. Okay, so everything we saw on CT can also be replicated and seen on X-ray if we are careful enough about these signs and are making effort to look for these signs. All right, so what is happening here now? What we see here is that there is an opacity present here. This is the zoom view. You can see there is an opacity present here. but you can see the right cardiac border very clearly. Okay, this was a case of, you can see this air is going from here into the chest. So this was a case of Morgagni hernia, but Morgagni hernia, we know that it is anteriorly placed, but we are not able to see the silhouette sign here because here there is air present in this lesion, and the silhouette sign will not work if the radiographic density are different. So even if this mass is anterior, the anterior part of heart is not obliterated for the simple reason that the density of these two structures are different, and there will be no obliteration if the density are different. So that is something which you need to understand, and that is something which is illustrated by this example. All right, now moving on to the other sign, hilum overlay sign. This basically helps in localization of the mass, whether it is involving the hilum or separate from the hilum. So if you see a hilar opacity, what are the possibilities? That this mass could be a hilar mass, number one. This mass could be a mass which is lying anterior to the hilum or posterior to the hilum. Now, if in these situations, the mass can be parenchymal or mediastinal. So, the soft tissue density, 5 possibility. Hilar mass, anterior parenchymal, anterior mediastinum, posterior parenchymal, posterior mediastinal. Okay, so what hilum overlay signs tells you that this mass is not hilar, because if it is anterior and there is some part of the lung present between the mass and the hilum, you would be able to see the hilum very nicely through it. Sometimes people get confused, and if hilum overlay sign is positive, they say it is a mediastinal mass. I am here again emphasizing this doesn't tell you whether it is mediastinal or parenchymal. This just tells you that it is not a hilar mass, and you study the other parts also, and you take help of other sign, and then you can localize whether it is mediastinal or parenchymal. All right, so let's see few examples. Now this is a mass present here. What we see that you can see the hilar structure through this. All right, so that means hilum overlay sign is positive, and this mass could be either posterior or anterior to the hilum. Now you can apply the other sign. You can apply the silhouette sign. You can see that the aortic shadow is nicely seen through the mass. So the aorta is not getting obliterated. Aortic silhouette is seen. So this is not a posterior mass, and anterior structures are not seen. The right cardiac border is not seen well. So right cardiac border is obliterated. So most likely it is a anterior mass. Then mediastinal versus parenchymal signs, you can the features you can apply, and you can see this is working for mediastinal. There is broad base, there is this obtuse angle, and there is this sharp margin. So you have to combine more than one sign to exactly localize this lesion. Hilum overlay would tell you just that whether the hilum is involved or not. So X-ray CT, the mass is lying anteriorly, very well seen on CT, but can easily be interpreted on chest X-ray also. Okay, what about this? What is happening here? Again, you can see the hilum through the opacity. So it's a non-hilar pathology, number one. Then you can see the superior vena cava here. Okay, so anterior structures are not getting obliterated. Most likely it is posterior. If you see, there is another density. So this density also you can see through the cardiac shadow. All right, the anterior border of the upper border of the right cardiac border of heart, that is not getting obliterated. So most likely this is also lying posteriorly. Okay, so you make use of both hilum overlay and the silhouette sign and reach to a conclusion where this opacity is lying. So this is the CT scan where you see both of these opacity are lying posteriorly, and you could make out that because hilum overlay sign is positive, so this is a non-hilar mass. So this is hilum overlay sign is whenever you talk about that overlay sign, you have to talk about hilum convergence sign. It's a corollary of hilum overlay sign, and it is used to differentiate a cardiac or pulmonary artery, cardiac enlargement, pulmonary artery enlargement, or a mass related to pulmonary artery from a non-vascular hilar mass. Okay, so it helps to distinguish enlarged pulmonary artery from juxtavascular hilar mass or even cardiomegaly. Now, please understand the basis. In most of the people, the pulmonary artery on right side as well as the left side, they are either within the cardiac silhouette or they lie within 1 centimeter. In 98% of the patient, they would be at the same level, they would be on the inside or they would be within 1 centimeter of the cardiac silhouette. That is one. And plus, you would see the normal pulmonary vessel would be converging towards the pulmonary artery. As you can see, these are the pulmonary branches, artery branches, they are going towards this artery. Okay, and this relationship would remain the same if there is cardiomegaly. So once again, I would repeat, this is based on the premise that pulmonary artery shadow would be either within the cardiac silhouette, or that would be maximum 1 centimeter outside the cardiac silhouette. Now, if there is cardiomegaly or if there is pulmonary artery enlargement, this relationship is not going to change. As the cardia enlarges, the pulmonary artery also move laterally, and that relationship is maintained, and these vessels would go into pulmonary artery itself. So this was the normal thing. Now let us see how the pulmonary artery branches are behaving. So we can see pulmonary artery is seen well within this mass. It is more than 1 centimeter inside the outer border of this mass. And if we see the vessels, they are kind of converging towards this structure. They are not converging towards this mass. So this mass is not related to pulmonary artery. Now see here, in this case, what is happening? There is this prominent shadow. There is this prominent shadow present here. And if we see the pulmonary artery branches, they are all converging towards this. Can you see this? And similarly, here the pulmonary artery is dilated on this side also, and the pulmonary artery are again converging towards this mass. So that means this mass is an enlarged pulmonary artery. This is a case of atrial septal defect where we see a narrow aorta. Okay, we can also see an enlarged pulmonary artery and other feature of right ventricular and right atrial enlargement. Okay, so reproduced here just to um, be able to differentiate a enlarged pulmonary artery or cardiomegaly from a non cardiogenic juxtahilar mass. That is the utility of hilum convergence sign. Now coming on to cervicothoracic sign. This is basically again an extension of the silhouette sign in relation to thoracic inlet. So an intrathoracic lesion can be anterior or posterior. Any lesion which is present in the upper part, so that would be can be anterior or posterior. Now, if it is anteriorly placed and it is closely related to the soft tissue of the neck, so here again the silhouette sign works here. So this soft tissue mass would be merging with the soft tissue shadow of the neck. All right, so that interface would be lost. You won't be able to see the upper border of the lesion. So that means cervicothoracic sign is positive and the mass is lying anteriorly. Now what is happening posteriorly? Posteriorly, we have lung apices which are extending well above the clavicle. So if we have a posterior mass, whether it is pulmonary, whether it is mediastinal, it would be outlined by the air which is present in the lung apex. Just imagine pulmonary, I'll show you the example also, but just imagine at this point, lesion present in the apex, either mediastinal or lung would have some kind of air surrounding it, and it will be seen extending well above the clavicle. So you would be able to see the outline very well and you would be able to see the mass very well. So if you are able to see outline of a mass or a mass above the level of clavicle, the interpretation is that this mass is present posteriorly. Again, it doesn't tell you whether this mass is pulmonary or mediastinal. It just tells you that this is posterior mass. Okay. So let's see with the help of some example. This case, soft tissue opacity is present here. As we trace it up, we can see the upper border goes. As soon as it is reaching the clavicle, you are not able to see the upper border. All right, so this kind of implies that this lesion is lying anteriorly. So here, this is the lateral view, and on the CT, you can see very well that this mass is present in the anterior part of the lung. Okay. Now look at this. Here another mass, but now we can see that this mass is extending above the clavicle, and we can see it very nicely, and we can also see it having an interface with air. So this is interpreted as this mass is present posteriorly. It is not possible to say whether it is lying mediastinal or parenchymal. Just based on this particular sign, you have to take help of other signs. So this is the chest X-ray PA view. You can see the mass above clavicle. Most likely it is posterior, and this is seen on the lateral view and very well seen on the CT. You can see this mass is lying in relation to relationship to the spine. So this is posterior. Okay. Thoracoabdominal sign, we saw silhouette sign applying at the level of thoracic inlet. Now application of same sign in relation to the interface between the thoracic and the abdominal structure. Same principle apply. What it does is it kind of tells us whether a mass which is seen posteriorly, whether it is purely intrathoracic or this could be thoracoabdominal. So what is happening? We know that the diaphragm is a soft tissue structure, and we know that posteriorly the lung recesses, they go far posteriorly. All right. So a thoracic mass, if the lower border is lost, what does this mean? That either this mass is in contact with the diaphragm, or this mass is going through the diaphragm into the abdomen, right? So this is thoracoabdominal positive. So these are the interpretation. If you don't see the border is obliterated. The interpretation is mass is present either in the thorax only, but it is touching the diaphragm, or this mass is extending into the abdomen. On the other hand, if we are able to see the lower border clearly, most of the time these border would converge. And if you are able to see the lower border very clearly, you can safely deduce that this is a purely intrathoracic mass. Okay. So because this purely intrathoracic mass is not touching the diaphragm, okay, so you would be able to see the inferior border because it is outlined by air. So if it is touching the diaphragm, whether it is going inside into the abdomen or not, the fact that it is touching the diaphragm, it will lose its outline. Okay. So let's see with the help of an example. Now what you see here, there is this mass, it is obviously posterior. You can see that this is a retrocardiac density. This is an obviously mediastinal density having all the feature of a posterior mediastinal mass. So when I try and look at the lower border, I am not able to trace it lower border very nicely. So I kind of deduce that this mass is definitely touching the diaphragm, maybe having a intra-abdominal extension. One helpful sign which is not seen always is that if this border is kind of diverging as it is going below the diaphragm, okay, so that sometime would suggest that this has an intra-abdominal extension also, but that does not work all the time. Only thing you need to remember, the only significance is that it is touching the diaphragm or it is going to the abdomen. Both possibility can be there. All right. So when we see the CT, we can see this is a case of chronic pancreatitis with associated mediastinal pseudocyst, and this pseudocyst is going from the abdomen into the chest. Okay, and this you can kind of suggest on the basis of this X-ray itself. Now see the other X-ray. Again, a huge mediastinal mass, most likely posterior. You can see the entire outline, and you see the lower border is fairly well seen. You can see this is converging and it is fairly well seen. So a good possibility that this mass may be entirely intrathoracic. All right. So this is a penetrated view. little penetrated so that you are able to see the border very well. You can see the converging border and reasonably well defined border. Compare this with the lesion, the case I showed you before that, where the lower borders are lost as we come near the diaphragm. So here you can kind of assume that this mass is purely intrathoracic. Okay. So this is a long posterior mediastinal mass which is displacing the esophagus, and on CT we can see that the lower border is very nicely seen. Okay, that is how the thoracoabdominal sign helps. All right, so again another corollary of silhouette sign is the incomplete border sign, which is helps us in localizing a mass which is in contact with the chest wall. So if a mass is in contact with the chest wall, and if it is a soft tissue wall, the interface again between the wall and the mass, that would be obliterated, whereas the interface which is either superficial or towards the lung, that would be seen. So what do you see on chest X-ray is that the part of the border is seen very well and the part of the border is not seen at all. So this is what is known as incomplete border sign. A border is present here, a border is not seen here. So this is an indicator of a fact that this mass is connected to the chest wall. This could be a purely chest wall mass, or this could be a pulmonary mass which is invading the chest wall, and this is the reason that the border is not well seen. This would not working in chest wall mass, which is having like a mass which is projecting superficially from the skin. So what you will have is that because this is projecting from the skin and it has a very narrow base with the skin, like in case of a neurofibroma, so you will have air trapped between this mass and the skin. Just imagine that situation, that you have a neurofibroma, all right, and you would see the air between that mass and the skin. So in that particular situation, you would be able to see the entire border of the lesion, even though this mass is arising from the chest wall. So that is a caveat you need to remember. All right, so interpretation is, if you see this, it's a reliable indicator that there is a chest wall component. If you don't see this, that that doesn't mean that this mass is not in chest wall. It could still be a mass in the chest wall, just hanging from the wall, and all border being seen due to presence of air all around it. So you need to take one more view to settle that issue. All right, so here you can see this was a case of, on CT scan you can see this is a chest wall mass with chondroid calcification, a case of chondrosarcoma of the chest wall. So these were about the localizing signs, and as you can see, most of which, rather the all of these are in a way corollary of the silhouette sign only, which helps us in localization. Now there are few signs which help us in characterization of a lesion, and first and foremost, which you see in your day-to-day practice, is the air bronchogram. Air bronchogram means that there is presence of soft tissue in the air spaces, whereas the bronchi are patent, right? So you would see a soft tissue density, and within that you would see the dividing bronchi. So this air bronchogram is suggestive of pulmonary consolidation. Very safely you can assume, and when you see this air bronchogram, that this is a pericardial pathology, most likely consolidation. Golden S sign. So basically, what does this mean? S has two limbs, one limb here and then other limb this side. So this kind of appearance is seen in case of hilar mass, which is called complete collapse of the right upper lobe. This is valid for the right side. So you have a hilar mass. So this hilar mass kind of compresses upon the right upper lobe bronchus and causes right lobe collapse. And as the right lobe collapses, the fissures, they move upward. Horizontal fissure moves up, and you see this sharp shadow. So you will have a lower convexity, which is due to the presence of hilar mass, and then you have the upper concavity, which is due to presence of collapsed lung. And this particular sign most commonly seen in bronchogenic carcinoma, but can be produced by any lesion which can obliterate the right upper lobe bronchus. All right, so this is the X-ray, and here you can see that there is this mass which is obliterating the right upper lobe bronchus, and the entire right upper lobe has got collapsed, and the fissure has moved up, and you can see correlate these two, and on the X-ray itself you can make out that golden sign is positive, and we can say that there is a hilar mass and there is right upper lobe collapse. Now, corresponding thing on the left side is what is known as the left-Schickel sign. You know, on the left side, there is no horizontal fissure. So, if there is a mass which is causing complete collapse of the left upper lobe, all right, just imagine. So, what is going to happen as the left lobe collapses? It would move medially, and it would also move anteriorly, whereas the oblique fissure would move superiorly. So what happens? Left upper lobe would come to lie medial, it would come to lie anterior, and the fissure will move up, and the superior segment of the lower lobe would come to lie in relation to the this arch of the aorta. So arch of the aorta is unusually well seen. Like here in this case, we can see that the left cardiac border is obliterated, and the aortic knuckle is, however, very nicely seen. So this means left-Schickel sign positive. Most likely there is left upper lobe collapse. And sometimes it so happens that this inflated superior segment, it insinuates itself between the aorta and the pulmonary artery. So you would be able to see this air density between the aorta and pulmonary artery. Here you don't see any particular density. There is extreme collapse of the left upper lobe. It has got kind of hidden within the mediastinum, but you have this indirect left-Schickel sign. You can see the aortic arch very well. You can see air between the aortic arch and the pulmonary artery. This is an indirect pointer that the left upper lobe has collapsed. You can see there is these vascular marking are fairly widely separated as compared to the other side. Lung appearing slightly loosened. Other signs of collapse are there. So you cannot ignore this. This patient has to be subjected to CT to rule out whether there is some mass present which is causing obliteration of the left upper lobe. All right. So this is the same case, and you can see the CT that the left upper lobe is totally obliterated, and the superior segment of the left upper lobe, this has got insinuated between the aorta and the pulmonary artery. So it is a very useful sign. You don't see a mass, but you see this sign. You suspect that a mass is present there. Take the patient to CT. Now, bad swing sign, we all know what we have is this bat wing kind of appearance, perihilar haze with air bronchogram. This is seen in cases of pulmonary edema. Reverse bat wing sign, we have this kind of opacity peripherally, center being clear. This is seen in cases of chronic organizing pneumonia, in cases of eosinophilic pneumonia. These are some of the differential diagnoses which are associated, conditions which are associated with this appearance. Now, finger in glove sign. So finger in glove sign is basically presence of mucoid material in the bronchi. So what you would see that you would see dilated bronchi, and you would see soft tissue density which would be in the line of the bronchi, and they would be dividing. So this is a fairly reliable sign to diagnose allergic bronchopulmonary aspergillosis. You can see this is the shadow present here as it is going peripherally, it is dividing, and this is also showing presence of soft tissue density inside. The same thing you can see on the left side also. So this is different case showing the depiction of this gloved in finger sign, that soft tissue density which is causing bulging of the bronchi here, and the air is replaced by this mucoid material. This is also called as bronchocele. This is again most likely due to a allergic bronchopulmonary aspergillosis. Air crescent sign or monod sign. So this monod sign was first described in relation to aspergilloma. This was basically the soft tissue mass of the fungus ball which was outlined by air, and this was freely movable. So this looked like crescent on X-ray. Okay, so that is why air crescent sign is used kind of synonymously with monod sign. But the point to remember is that monod sign is specifically described with aspergilloma, and but it is also very commonly referred to as air crescent sign. And there are multiple causes for this air crescent sign. One of them is aspergilloma. Then if you have a cavitating carcinoma or presence of hematoma, right, these are the other causes of air crescent sign. The interpretation is that there is a cavity present there, and within this cavity there is a soft tissue mass, and that is outlined by the air. It has a differential diagnosis, and if you are asked the causes, keep aspergilloma at the top. Water lily sign basically is seen in cases of ruptured hydatid cyst. What happens when there is rupture? The air insinuates itself between the various layers of the cyst. So what you see is, you would see a membrane, hydatid membrane, presence of air, and then the outer membrane. Okay, so a soft tissue shadow followed by air shadow, and within that you would see this ill-defined lobulated kind of again soft tissue shadow, and you could see air in the endocyst also. This particular appearance is very characteristic because in the hydatid cyst there are circles within the circles, membrane within the membranes, and when the air gets insinuated between these membrane structure, you would see the outline of the membrane, and you would see the air in the cavity also. Okay, so this is another illustration, I think, which I showed to you in one of the spotters. You have this air, and then you have this lobular wavy outline, which is characteristic of a ruptured hydatid cyst. You can see this on the CT scan also. You have this ectocyst, then within the air is got into the deeper layer also, and you can see this multiple air cavity, and you can see the soft tissue shadow of the membrane on CT, right? So this is what is the water lily sign or the crumpled handkerchief sign. They all mean the same. Sail sign is basically a triangular opacity in children which resembles a normal thymic shadow. Mostly it is seen on the right side. Sometimes it can be seen on the left side also. All right, you should not confuse this with the spinnaker sail sign, which I'll show you later. Spinnaker sail sign is basically this thymic shadow moves little laterally, and you see air shadow medial to that. That is a feature of pneumomediastinum. I think I have a case. Right. Then coming to Chilaiditi sign. Chilaiditi sign is basically the presence of colon between the liver and the diaphragm. The importance of this sign is that the person who is uninitiated and early student, that he might confuse this sign with pneumoperitoneum. And pneumoperitoneum would generally imply a bowel perforation, and the patient may be the radiologist, if he is not experienced, he might raise the alarm that this patient has a bowel perforation. And then based upon the clinical sign, if the surgeon operates, if he operates just based on your input, that would be really unfortunate. So how to differentiate Chilaiditi from a pneumoperitoneum? As we know, Chilaiditi is due to the interposition of bowel. So you would be seeing the bowel fold within this. So if it is colon, you would be seeing the haustra, you would be seeing the wall. Whereas in cases of pneumoperitoneum, you would just be seeing a thin crescent of air. You won't be seeing this kind of soft tissue density present within this air shadow. Here again, you can see that the wall is seen very nicely in this. So this is a kind of subtle finding, and this is more or less gross finding. So in elderly, in patient with COPD, this is seen commonly. Be aware of this finding. Don't report this as pneumoperitoneum. Scimitar sign is basically, this is an abnormal vessel, which is basically anomalous pulmonary venous drainage, which goes on the side of the heart, has the shape of a scimitar, and you can see it going into the diaphragm. You can see the diaphragm is obliterated, and there are other changes which are suggestive of scimitar syndrome, like there is this kind of displacement of the cardiac shadow to the right side. There are features of pulmonary hypoplasia, and there is this characteristic soft tissue shadow. If you see this, actually there are hardly any differential diagnosis, and especially when you can kind of trace this particular shadow to the hilum to the pulmonary vessels, and definitely then you will have other features. All right, sometimes a collapsed lobe can create a confusion. Supposing there is collapse of one of the segment and that segmental bronchus is obliterated, so that would produce a case appearance like scimitar. All right, that would also have sign of loss of volume, but in that case you would be seeing a normal pulmonary artery, normal pulmonary vessel, which would be going towards a normal pulmonary vessel at the level of hilum, and you would be seeing a mass also which is responsible for that segmental collapse. So that distinction is usually easy to make. So you need to be aware of this density seen mainly in children, and you need to be aware of that differential diagnosis and how to make that differential diagnosis between a segmental collapse due to mass and a this anomalous pulmonary vein which is going below the diaphragm. Okay. Continuous diaphragm sign, we know that the central part of the heart that is resting on the diaphragm, and because they are of same density, so there will be loss of interface between that. But if there is air in the pericardium or air in the mediastinum in the upper part, and if there is air in relation to the lower part of diaphragm, so you would be able to see this lower border of the heart very well. So this is what is known as continuous diaphragm sign. Thing to remember is, if you see the entire border of the diaphragm due to presence of air, and if air is above the diaphragm, the diagnosis is either a pneumomediastinum or a pneumopericardium, and then you need to differentiate between these two entities by various signs. And if this is seen below the diaphragm, then this is due to pneumoperitoneum. And this is what I referred to as the spinnaker sail sign. This is a case of pneumomediastinum. You can see air everywhere in the chest wall in the mediastinum, and this thymic shadow is kind of shifted laterally, and you can see air present medial to this sail sign. This is what is called the spinnaker sail sign, and it is a feature of pneumomediastinum. So you see two features of pneumomediastinum in this spinnaker sail and the continuous diaphragm sign. Okay. All right, deep sulcus sign. This is a very important sign which you need to understand and remember, because this has got emergency implication. This you would be seeing mostly in the emergency setting, and if you see this, you need to take immediate action. So what happens? This is seen in cases of pneumothorax in a supine patient. You know, pneumothorax means presence of air in the pleura, and if the patient is erect, the air would come here. All right, so you would be able to diagnose pneumothorax very nicely. But if the patient is not able to have a PA view either in the erect position or in the sitting position, we take a chest X-ray in the lying down position. If there is pneumothorax, the air is going to collect anteriorly in the entire pleura. Okay, so this pleura, as we know, this is extending here. The lateral costophrenic recess or the posterior costophrenic recess extends pretty deep. All right, so what you are going to see is that you are going to see the outline of pleura to to an extent which is lower, right? Compare this. So this is the normal costophrenic angle, because there is soft tissue present here. This is seen till here only, but if there is air present, that would go in the costophrenic recess, the lowermost recess, because it is going to lie anteriorly. So you would be able to see the lowermost extent of the costophrenic recess, and you would be able to see the pleura very nicely till a lower level. So once you see this, you raise the possibility of pneumothorax. All right, try and take the PA view or do an ultrasound, confirm pneumothorax, immediately alert the clinician. This patient may need tube placement. A caveat is this deep sulcus sign can be seen in cases of chronic COPD patient, because there, you know, there is hyperinflated lung field, and these lung recesses would also extend deep. So you will have other features of COPD present. The patient would be having a history of COPD. You would be seeing flat diaphragm, and you would be seeing this on both sides, and this patient would be asymptomatic. So that is how you differentiate. So this is something which I need you to focus on, because this sign, if it is missed, you deny the patient an opportunity to get immediate relief from his symptom. Because if pneumothorax is diagnosed, we can put a tube and the patient would be okay within a small period of time. So these are the kind of signs which I described in the previous thing. Now I just want that the next session, next part of the session should be interactive, where I show you the images, ask you some question, and you answer on the chest box. Okay, I think there are 6-7 cases which illustrates this sign, and just to show how much you have learned. All right. So the question here is, where is this opacity present? So you can type on the chat box. Okay, so what we see here is that the upper cardiac border is obliterated, number one. So this is anterior. You can see the aortic arch is very nicely seen. So it is not posterior. It is not hilar, because we can see the hilum through this opacity, and it is having a feature of a mediastinal mass, in that it is broad based, it is very sharply defined. So anterior obliterated, posterior preserved. Still, I mean, the overlay sign positive, most likely diagnosis. Most of you have told correctly, this is an anterior mediastinal mass. Correct. All right. So this is the CT scan. You can see anterior mediastinal mass. All right. So what is happening here? This one. Good. So seen 2-3 responses till now. Anterior cardiac border normally seen. It is not gone. Aorta not seen. You can't see the outline of the aorta. Hilum overlay positive. So anterior ruled out. Posterior likely, because aorta is gone and hilum overlay positive. The features of mediastinal mass are present. So definitely it is a posterior mediastinal mass. Yes, aortic aneurysm is a very good possibility. So this was a case of aortic aneurysm. You can see the mass is present posteriorly. So where is this present? So Dr. Sabyasachi, I'll definitely repeat case 1. So you just focus on this one right now. So here the opinion is little divided. So what we see here is that this is the superior vena cava, which is not getting obliterated. So anterior structure is not getting obliterated. So this lesion most likely lies posteriorly. So that is the only interpretation I can give. Although it is having a wide base towards the mediastinum, okay, but the mediastinal margin is not very sharp. All right. Only thing I can say that this mass is most likely lying posterior, because SVC is not obliterated. Okay, so this is a mass lesion. You can see this is lying posteriorly, and now you can see that this is basically lying in relation to the pleura. But it is a posterior mass. That is the thing which I wanted you to pick up. You can see this is SVC, which was not obliterated on the chest X-ray. So air bronchogram is not there. Can you see the air bronchogram? Okay, let me just see. Oh yes, I think you could say on chest X-ray, yes, these kind of density are there. So this could be air bronchogram. I would agree there. Although on CT that is not seen. But yes, if you tell me that this is pulmonary and I can see that there are some bronchial shadows, yes. So I would not say that you are not correct. Is it not sure of pulmonary? Yes, it is. If you see this, it is sure of a pulmonary lesion, definitely. How to differentiate pleural and extrapleural? It is a very different call to make. Like in GI, it is difficult to make a call between whether this lesion is intramural or completely extramural. The findings, the features, they remain the same. A mass, pleural mass, well, would kind of produce a small localized shadow. Again, about the angle, I'm not sure. It can be 90-degree. In pleura, it can be obtuse also. So that distinction based on X-ray is difficult to make. On CT, that is possible because you have an extrapleural fat and you see the relationship of mass with the extrapleural fat. If the extrapleural fat is lying lateral, so this is most likely pleural. If it is lying kind of medial, it is most likely extrapleural. Okay. What about this? Not hilar, pulmonary. Where? Anterior or posterior? Can you make that distinction? Lung mass, not hilarious. So I think you mean hilar rather than hilarious. All right, so let us see what is happening here. What we see that this mass is hilum overlay sign is positive. So this is not in relation to the hilum. It is either posterior or it is anterior, number one. Then you see the anterior, you see this is part of the ascending aorta, the right cardiac border. Here you can see this is most likely ascending aorta. IVC, SVC would have a straight kind of configuration and that would be seen meeting the right atrium. So that is not happening. So most likely this is ascending aorta, which is again an anterior structure. Now that is not silhouetted. Okay. So that means most likely posterior. Then you look at the angle of contact. Angle of contact, this mass is broader here and a smaller here. So most likely the epicenter is here and this mass progressed like that and came in contact with the mediastinum. The interface with the mediastinum is small. So most likely it is a parenchymal mass, number one. Number two, it is a posterior mass. So we use all those signs and make this inference on this chest X-ray that this is a posterior parenchymal mass which is not related to hilum. Okay. So this is the lateral view and this is what you see on CT, that this mass is obviously this is lying posteriorly and most likely definitely it is not mediastinal. It is most likely a pulmonary mass. All right, I'll explain it to you again. So this is an important thing. Multiple things you have to apply. First thing is you see that the hilum overlay sign is positive. Okay, so this is not a hilar mass. It is either anterior or posterior. It is not obliterating ascending aorta. So it is not obliterating a anterior mediastinal structure. So this is posterior, number two. Number three, the epicenter is lying in most likely here. It is not lying in the mediastinum because this dimension of the mass is bigger than this dimension. So most likely mass began here, grew on all sides and now it has come to touch this part of the mediastinum. So then the interpretation is it is definitely not a mediastinal mass. Okay. So is it okay? Please explain the overlay part if possible. Overlay part is again because you can see the hilum through this. So hilum overlay sign is positive. Hilum overlay sign, as I said, it only tells you that this mass is not a hilar mass. This doesn't tell you whether this mass is anterior or posterior. This doesn't tell you whether the mass is mediastinal or parenchymal. Okay, you have to take the help of other feature to make that judgment. So sign rocks too, is it okay? Have you understood? Okay. So moving on to next case, this is a very good case to illustrate all the relevant aspects. right? So what about this? What information you can derive from this? We're talking about localization, golden S sign, good, anterior mediastinum, good, anterior mediastinum. All right. So what we see here is an important point which I wanted to, yes, now it is coming from Dr. Mariza, that this mass is extending above the level of clavicle. All right. So definitely it has a posterior component and it's a huge mass. All right. And in a huge mass, it is very difficult to tell whether it is a parenchymal mass or a mediastinal mass. You have to rely on other feature. Now here also again, the anterior structure are not very well seen. And we know that mediastinum is not a strict anatomical compartment. It is divided into anterior and posterior for our convenience. So point here is that this lesion has a posterior component. This is a huge mass. We cannot localize very clearly whether it is purely anterior or purely posterior. All we can say definitely it has a posterior component. I cannot also tell whether it is parenchymal or mediastinum. So just remember that point, especially when it is present in the upper part and if it is a huge mass, it is very difficult to make that distinction. So you should not commit. You just say that there is a large mass present in the upper zone, which is involving the apex, silhouetting this, that, hilum overlay sign positive or not. It is not possible for me to make a distinction whether it is purely mediastinal, purely pulmonary. All I can say that definitely it will have an anterior as well as posterior component. Okay. So this you can see, this is straddling anterior going to posterior. You can see this anterior, posterior, both sides are there. And this is apical, this is going well above the clavicle. So definitely this is lying posterior and this is lying apical. So please remember that. All right. So Dr. Himant, don't just commit yourself to this histological diagnosis on chest X-ray. Never. Never on the initial investigation. Please do not commit yourself to a pathological diagnosis, okay, unless you are absolutely sure. DDs would be a large, large upper zone mass would include all DDs of mediastinal mass and also parenchymal mass. It is then you have to kind of look at the age of the patient, look at the symptom and make a differential diagnosis. Yes, there is another lesion in left chest wall. This was basically a metastatic lesion. All right. So, but here I just wanted to focus the teaching points which are there in the mass lesion which was present on the right side. So this was a metastatic lesion. Lymphoma, yes, that would be a good possibility, definitely. But if you look at the image morphology on CT, on plain X-ray, maybe you can raise lymphoma would not be having this kind of enhancement. See, this is an enhancing mass with necrosis. So that is not generally the feature in case of a lymphoma. So if you want to put lymphoma, put atypical and put it a little lower down on the list. So this part is not the focus of this talk, right? Regarding it is just about the name of the sign and what do they convey and what you need to see and interpret when you see that mass. All right. So, but Anusha, I hope you're clear that the lymphoma would not be at the top of your differential diagnosis, right? Okay, so most of you telling that this is a chest wall lesion. So surely it is. You can see there are two lesions. Here you can see this border is nicely seen and this border is not seen. Similarly here the upper border is not very well seen. And another important point is there that in both of these lesions, there is destruction of the bone along with expansion of the rib. Okay. So this is an additional information. The fact that there is incomplete border tells you that most likely it is a chest wall lesion. But if you look more carefully, this entire rib on both sides, they are expanded. So this localizes the lesion definitely to the bone, because bone expansion cannot be caused by a non-bone lesion. It has to be caused by an intrinsic lesion to the bone. All right. So, well, although we are not discussing, but since Akansha has written metastasis, this is kind of very well-defined lesion. All right, metastasis won't be so well-defined. So what we see here is expansile lesion involving the rib. This is seen on the right side. This is seen on the left side, and there are lesions present in the spine also. This was basically multifocal ABC. Okay. Yes, this one. So this you should be able to tell me. Hierated meniscus, hierated. So all of you have got this, right? So very nicely, again, air shadow with not a flat meniscus thing, just a lobulated outline, convex outline. All right, so most likely diagnosis, it's a right-sided pathology, it's a lower lobe pathology. All right, so most likely diagnosis would be a ruptured hierated, and all of you have got it correct. Nice. So this is the CT scan, and you can see this is membrane in the prone scan. These membranes are falling off to the dependent portion. Here, they are in the supine, it is here. In the prone, it is here. In case 4, I'll just come back to that. Let me finish this. So, okay, we have finished. So I will just go back to the case 4. Case 4, there is no cervicothoracic. This is nowhere coming near. I think you meant case 5, is it? Did you mean this case? Dr. Atha? All right. So let me take this one. So we knew cervicothoracic sign says that if you can't see the upper border of the lesion above the clavicle, that lesion is lying anterior. And if you can see the upper border clearly and you can see it above the clavicle, so that means this lesion is positive. Cervicothoracic sign is positive. The interpretation is that this lesion has a posterior component, it has a apical component. In anterior placed mass, if it is soft tissue density, you will not be able to see the upper border. Reason for deep sulcus sign, reason for deep sulcus sign is, pneumothorax, the air is present in the pleural cavity, and air has a propensity to lie, to go to the highest point. Okay, so if the patient is erect, it would rise to the apex. All right, but if the patient is supine, it would rise to the highest point all along. So it would rise anteriorly from top to the bottom. And we know that the pleural, this ostophrenic sulcus, it extends far laterally down. So in the lowermost recess also, the air would be present, and you would be seeing air which would be kind of in the pleura against the liver. So what you will have is that you will have liver medially, then air in the pleura, and then the chest wall, and this would be all along in the lower part. So you would be able to see the lowermost part of the costophrenic sulcus. So sulcus would appear deep. Okay. Yes, 4 millimeter is a cavity. This is generally the definition. For more than 3 millimeter. Should we comment as silhouette? You don't say silhouette sign positive or negative. You just say that the margin is obscured or not. Okay. But generally it means when the margin is obscured, the silhouette sign is positive. But there is this paradox which I think Dr. Anna Barasi pointed me out. I used to be confused like you, but it is more correct to use this obscuration thing rather than using this silhouette thing. Okay, just tell about what is obscured, whether it is obscured and whether it is obscured or not. That is important. So I think there are no more questions. Mitusha? Hello?
Yes, sir. I think the questions have all been taken up.
Yeah.
And you have explained so nicely that I think most of their doubts also got cleared.
Yes. Thank you so much. So can I just stop sharing?
Yes, sir.
Okay. Thanks a lot. So please still question coming for left facial, hilum curvages. I think these are important concepts. So I am willing to spend some more time, but let me just go to the relevant images. All right. So first, let us take up this left facial sign, left sickle sign. So you know golden S sign on the right side. So corresponding sign on the left side is the left sickle sign. We know that the golden S sign is due to pulling up of the horizontal fissure. All right. On the left side, there is no horizontal fissure. So if there is any lesion which causes collapse of the left upper lobe, the left upper lobe would collapse medially, it would collapse anteriorly, and the left lower lobe would come up. The superior segment of the left lower lobe would come up. All right. So as it comes up, it lies against the aorta, and sometimes it insinuates itself between the aorta and the pulmonary artery. All right. So what you would be seeing an unusually sharp outline of the aorta, aortic arch, and also of the pulmonary artery. So this you see on CT, you see there is a mass which is causing collapse of the left upper lobe, and here you can see the air, the superior segment coming between the aorta and the pulmonary artery. The superior segment coming between the aorta and the pulmonary artery. So on X-ray, look at this image because there is air present here around the pulmonary artery. Normally this does not happen. All right, but in this particular case it is happening. So you would be seeing a very unusually sharp border to the pulmonary artery as well as to the aorta. This is what is known as left sickle sign. So sometimes you may not see the mass, you would just see this left sickle sign, and when you see this, time to subject the patient to CT. Is it clear, Dr. Kaladevi? Okay, so now let's go to hilum convergence. All right, so it is here. So hilum convergence means what we have normally is large pulmonary vessels. Pulmonary vessels would be converging toward the pulmonary artery, and pulmonary artery is very closely related to the cardiac shadow. It is attached to the heart. So pulmonary artery most of the time it would lie within the cardiac silhouette, or it would lie within the within 1 centimeter of the cardiac outline, and all the pulmonary vessels they would be converging towards the pulmonary artery. All right. So if the pulmonary artery is enlarged, like in this case, pulmonary artery is enlarged, this is basically a case of atrial septal defect with left to right shunting. You can see this aorta is narrowed. You can see pulmonary artery, central pulmonary artery is enlarged. Even this right pulmonary artery is fairly enlarged. And then you have all the features, right ventricular hypertrophy is there, right atrial hypertrophy is there, but then you see this mass. All right. So you are confused whether this is an enlarged pulmonary artery or whether it is a juxtahilar pulmonary mass. So what you do is you kind of trace these pulmonary vessels towards this mass. You can see this pulmonary artery, they are kind of converging on this mass. Okay. So that means it's a pulmonary artery. It is not a hilar pulmonary mass. Like for example, in this particular case, you can see there is a mass present here. Of course, it's a very large mass, but sometimes you will just have a small mass which is present here. And then you again try and trace the pulmonary vessels towards that opacity. If you can see the vessels through that opacity, and if you can see the vessels joining some other structure rather than this mass, then you can be sure that this is a juxtahilar non-pulmonary artery mass. It is not an enlarged pulmonary artery. So, Dr. KK, is it okay? Case 3. How to tell the mediastinal compartment in case 3. So, case 3 of the exercise, I hope. All right. So, this is case 3. All right. Compartment. Well, see, this is superior vena cava, which we know is an anterior structure, and this is not getting obliterated. So this means that this particular soft tissue density is posterior. So I localize it to posterior, whether it is mediastinal or parenchymal. As someone pointed out, there is an air bronchogram present in this, that at least that you can see on this chest x-ray. So this cannot be a mediastinal. You will not have an air bronchogram in a mediastinal opacity. Otherwise, you have all those signs, you know, the obtuse angle, the very sharp margin in case of a mediastinal mass. All I can say that this is posterior, and when we see air bronchogram, I can say that it is parenchymal. Okay. So I think I have kind of answered all queries. So what do I do? You want me to stop or you want me to continue, Mitusha? Still more question coming.
Sir, I think they will keep asking only.
Yeah. So I think
because even Dr. Datta was waiting.
Yeah. So
yeah.
we'll close. I think most of the
Yes, sir.
things they have been. Thank you.
Yes.
So thank you very much for your attention.
Thanks once again, sir, for taking all the queries as well. And thanks for your time. Now, we would request our next speaker, Dr. Sumit Datta, sir, to kindly take over. Sir is a senior consultant radiologist at Apollo Gleneagles, and he will be taking about the chest X-ray in various cardiovascular anomalies and pathologies. We welcome you, sir, and you can start your screen share. Yeah, we can see your screen. You can open your PowerPoint, sir. Yeah, you can go to the PowerPoint, which is there at the bottom bar. Yeah, you can open that also, sir. Yeah. So you are on mute. You can just unmute yourself. Yeah.
Yeah. Can you see me?
Yes, sir. Yes, sir.
Can you see my screen? Am I audible?
Yes, sir.
Yeah. So I start now.
Yes, sir.
Yeah. So today's topic is the X-rays in cardiovascular disease. So chest X-ray, PA view, in taken in full inspiration, we'll now see the silhouettes. So the cardiac silhouette border is formed mainly by the right atrium. Superiorly, there is a contribution of the superior vena cava, and inferiorly, there is contribution from the inferior vena cava. While the left heart border is basically formed by the left ventricle, with a superior contribution of the aortic knuckle and a small concavity formed by the known as the pulmonary bay, formed by the main pulmonary trunk. The left ventricle forms the left heart border, including the apex, while the base of the heart is formed by the right ventricle. In lateral projection, if you see the anterior silhouette is mainly contribution of the right heart border, inferiorly by the right ventricle and superiorly by the right atrium. While posteriorly, it's mainly by the left chambers, superiorly by the left atrium and inferiorly by the left ventricle. You can see the left bronchus just posterior to the left atrium. Now, talking of circulatory changes before birth at neonatal, The deoxygenated blood is carried by the two umbilical arteries to placenta for oxygenation. The oxygenated blood from the placenta is carried by a single large umbilical vein to the ductus venosus, which shunts the blood into two circuits, the inferior vena cava circuit and the portal venous circuit. From the portal venous system, it again entered the inferior vena cava through the hepatic veins. As it goes to the right atrium, it is guarded by a Eustachian valve, which directs this oxygenated blood to the interatrial septum in the region of foramen ovale. It has the flat communication between the right atrium and the left ventricle, left atrium, and the oxygenated blood goes from the right atrium to the left atrium. From the left atrium, it goes to the left ventricle, and it makes its way to the aorta for systemic circulation to supply through its branches the coronary artery and the carotid and the innominate artery for the further development of the brain and the myocardium. The deoxygenated blood or the desaturated blood from the right atrium also reaches the right ventricle and goes through the pulmonary circuit to the pulmonary circulation. But the pulmonary arterioles are in a state of severe vasoconstriction, anoxic vasoconstriction, in a state of fetal physiological pulmonary arterial hypertension, and they don't participate in oxygenation. So the deoxygenated blood is shunted through the ductus arteriosus to the descending thoracic aorta, from wherein it is again connected by the umbilical arteries for oxygenation, which makes its way to the placenta. At birth, what happens is this: as the placenta is shedded, its sole supply of oxygenation, there is fall in the pulmonary arterial pressure. As there is fall in the pulmonary arterial pressure, the pulmonary arterioles are now ready to participate in oxygenation. So the desaturated blood from the right ventricle goes to the pulmonary circuit through the pulmonary artery for oxygenation. The oxygenated blood reaches the left atrium through the pulmonary veins, and there is a rise in pressure in the left atrium, and that forces the foramen ovale to close. From the left atrium, it goes to the left ventricle, makes its way to the aorta for systemic circulation. The desaturated blood from the right ventricle no longer goes to the ductus arteriosus to the descending thoracic aorta. Rather, most of them makes its way to the pulmonary circulation. So the ductus arteriosus also closes, forming ligamentum arteriosum. So the resultant is this, that we have got two independent circuits, the right heart and the left heart, connected by pulmonary circulation, giving a figure of 8 pattern. The primitive cardiac tube, the fetal cardiac tube, is a small tube, but fixed at both ends. It consists of 5 dilatations: the sinus venosus dilatation, the common primitive atrium, the common primitive ventricle, the bulbus cordis, and the most cranially, the common truncus arteriosus. They are fixed on either both ends actually, but it's a fast developing tube. So it is bound to rotate, loop, and twist. In common fetus, it goes for dextrorotation or dextroloop. The dextrolooping is also seen in uncorrected transposition of great arteries, while the lever loop is seen in corrected transposition of great arteries. In normal population, the cardiac tube rotates in such a way, making the right ventricle the most anterior chamber and the left atrium the most posterior chamber. The left ventricle forming the most of the left heart border and the right atrium forming the most of the right heart border. So in this lecture, we'll be seeing the acyanotic heart disease of the congenital heart spectrum, the left to right shunt, the right heart obstruction, and the left heart obstruction. In the cyanotic spectrum, we'll be seeing the tricuspid atresia, the tetralogy of Fallot, the pulmonary arterial obstruction, that is the Eisenmenger's reaction, the uncorrected transposition of great arteries, the total anomalous pulmonary venous drainage, and the persistent common truncus arteriosus. And in other spectrum, we'll see the transposition of great arteries again, which here we will deal again with the corrected transposition of the great arteries, the right heart abnormalities like the Epstein's anomaly, and acute valvular heart disease like the rheumatic mitral valvular disease, the most commonest one. So we go to the ASD. In ASD, we see that the cardia appears enlarged, involving the right atrium and the ventricle, and the heart is mildly displaced to the left. There is enlargement of the main pulmonary artery with variable degrees of pulmonary plethora. The costophrenic septal edema is manifested as curly B lines. Now you can see in chest PA radiograph, so we can see the enlarged cardiac, this cardiomegaly with enlarged right atrial chambers and the ventricular chambers. There is dilated pulmonary arteries. The main pulmonary artery, which we saw already, forming the floor of the pulmonary bay, is dilated, and there is dilatation of the central, lobar, segmental, as well as peripheral pulmonary arteries with dilated right heart chamber. And most important, see, you rounded upward cardiac apex. So talking about ASD, there are three types of ASD. The commonest type is the ostium secundum defect, which is seen in 85% of the population. The second type is the endocardial cushion defect, seen in 10% of the population. It is again divided into septum primum. And the severe type is the persistent arterioventricular canal defect. The third type, the least commonest type, is the sinus venosus defect. So in septum ostium primum defect, the endocardial cushion defect is the milder variety. The more severe variety, as I told you, is the persistent atrioventricular canal defect. In this septum ostium primum defect, what happens? There is a misplaced mitral valve. So this is a 4-year-old boy. This is a frontal left ventricular cardioangiogram showing the left ventricle with a distorted upper right lateral border of the left ventricle because of this misplaced mitral valve. And the anterior leaflet goes on to attach to the crista of the interventricular spectrum, giving rise to a gooseneck deformity of the left ventricle. So what happens is that here the regurgitant flow, because of this malpositioned mitral valve, goes on. The regurgitant flow does not go to the left atrium, but it goes to the right ventricle, forming a gooseneck deformity. 1 year later, this is a post-operative film, 1 year later, when the left angiogram, ventricular angiogram again was done, we see that all the cardiac chambers here, which was enlarged before, has reduced in size. You can see the prosthetic mitral valve here in its characteristic location, but the gooseneck deformity of the left ventricle still persists. Talking of ventricular septal defect, this is the commonest of the congenital anomalies occurring in isolation or as an essential component of the Fowler cytology or a concomitant of any other cardiac anomalies like transposition of great arteries. The radiographic features are there is enlarged heart proportional to volume overload. There is enlarged pulmonary arteries, and in proportion to increased pulmonary blood flow. To note, unless the left atrium is noticeably enlarged, it's not possible and it is very difficult to differentiate the cardiac shape from ASD. So what we see here in this frontal radiograph, chest X-ray, we can see a dilated heart. There is cardiomegaly and there is dilated pulmonary arteries. There is pulmonary plethora as well. The right heart chamber is enlarged. There is a convex right heart border. And here what we see, because of the cardiac size is enlarged with right heart border enlargement, we can see the retrosternal filling and more increased contact with the sternum. So this is the right ventricle, enlarged right ventricle. This is the right atrium. The left atrium is also enlarged because we can see the left bronchus is displaced posteriorly. So there is dilated left atrium and also the dilated right heart chamber. Talking of PDA, the persistence of patency of the ductus results in varied manifestation, be in isolation or in association with VSD or coarctation of aorta. Now, what is this PDA? It is a short conical tubular connection without valves linking the concavity of the aortic arch immediately below the origin of the left subclavian artery to the upper aspect of the main pulmonary artery at its bifurcation. The radiographic features are there is filling of the normal angle between the aortic arch and the main pulmonary artery. The central pulmonary artery and the lobar arteries enlarges, but the segmental arteries are not as large as in ASD. So we can see a vivid pulmonary plethora, the enlarged lung, and the dilated left main pulmonary artery, which is forming the bay, pulmonary bay. Here it should be concavity, but we can see a prominent pulmonary bay. So it speaks of dilated main pulmonary trunk. Pulmonary valvular stenosis, right ventricular hypertrophy, consistent with the degrees of stenosis. Right ventricular dilatation does not occur until the right ventricular failure develops. To note, post-stenotic dilatation of the main pulmonary trunk usually extend into the left pulmonary artery, but not into the right pulmonary artery. The radiographic features are large left hilum, smaller than normal right hilum, mildly enlarged heart with RV apex configuration, a flattened apex raised above the diaphragm. Right atrium may cause prominent convex right heart border. A right-sided aortic arch in pulmonary venous stenosis usually implies an associated VSD. So we can see the heart here is not that enlarged, but there is dilated main pulmonary trunk, but here it is not extending to the left main pulmonary artery. Rather, the lungs are mildly oligemic. It is because here Eisenmenger's reaction has already taken in, and there is reversal of the sun from the left to right, from right to left. So the heart is not that enlarged, oligemia has sets in, but the main pulmonary trunk is still dilated because of post-stenotic dilatation. Talking of coarctation of aorta, it is an abnormality of aortic media presence as in this discrete folding in the posterolateral wall of the aorta at the level of the ligamentum or ductus arteriosus. The resultant crescent-shaped membrane causes obstruction to the flow, forward flow, just distal to the ductus, appropriately termed as postductal or adult coarctation. When the membrane is proximal to the ductus in early life, it is known as preductal or infantile coarctation. The post-coarctation dilatation of the proximal descending aorta, significant coarctation impairs blood flow into the descending thoracic aorta, necessitating the presence of collaterals to re-establish the blood flow. The intercostal arteries play a major collateral role, resulting in rib notching in the inferior margin of the posterior ribs, extending from 3rd to 8th rib in untreated patients, usually by 8 to 10 years of age. So we will see a high aortic arch indentation in the left border of the posterior proximal descending thoracic aorta, giving rise to a sinus 3 and rib notching, inferior aspect, unilateral or bilateral, as the case may be. As the case may be suggests, if there is an aberrant right subclavian artery, so it will act as a collateral, and if it inserts distal to the coarctation, and in that case, the rib notching will be on the left side. If a left subclavian artery inserts distal to the coarctation, it may well serve as a collaterals. Then in that case, there will be only left-sided rib notching. So here we can see a frontal chest radiograph with high aortic arch with indentation or induration and aortic media induration here, and there is a post-stenotic aortic dilatation giving rise to a sinus 3. We can also see the subtle rib notching here in the posterior ribs inferior margin, and the collaterals, pulsatile and the engorged collaterals are responsible for this. The collaterals which participates in this rib notching are the anterior spinal, lateral thoracic, internal mammary, epigastric arteries. So this is an MR angiogram, sagittal section showing the coarctation, and internal mammary arteries are serving as collaterals. Tetralogy of Fallot, a major cause of cyanotic heart disease. Maldevelopment of the conotruncal septum is responsible for the development of the 4 cardinal features. That is the right ventricular hypertrophy, a large subaortic VSD, a overwriting of the aortic margin over the VSD, and pulmonary valvular stenosis. If the VSD is absent, the overriding is also usually absent, with a 5th entity coming into play, that is the ASD, and that time it is known as the trilogy of Fallot. If all these 4 cardinal features are present, along with ASD, it is known as pentalogy of Fallot. So the classic boot shape, that is the Coron Sebo silhouette, is attributed to the deep concavity pulmonary bay and elevation from the diaphragm of a well-rounded cardiac apex. So we can see here the right-sided aortic arch, there is cardiomegaly, there is deep concave pulmonary bay, there is an elevated upturned cardiac apex, and oligemic lung fields, giving rise to a Coron Sebo or a boot-shaped heart, the signatory of tetralogy of Fallot. This is a cardiac MR oblique short axis view showing the right ventricular hypertrophy, and you can see aorta overriding both the right ventricular outflow tract as well as the left ventricular outflow tract. A large subaortic VSD is also vivid here. CT angiogram shows a classic pulmonary valvular stenosis with post-stenotic dilatation of the right pulmonary artery and the left pulmonary artery. Trachea atresia. Right heart border tends to be flat rather than convex, heart lying slightly more than towards the midline than normal. The pulmonary blade is markedly concave. Main pulmonary trunk and the hilar artery are much smaller than normal, yielding pulmonary oligemia. So we can see a flat right heart border, which is caused by the right atrium, but the right atrium is larger in size. But it is not vivid here because it goes to take the place of a small right ventricle. So it is pushed medially, and hence the flattening of the right heart border. There is cardiomegaly, and there is oligemic lung fills, virtually a classic of tricuspid atresia. Now we'll talk of isomerase reaction, pulmonary arterial obstruction. It's an important hemodynamic response to a large left to right shunt that I've already talked to you in pulmonary venous stenosis, fortunately becoming much less frequent due to great success in surgical closure of the cardiac and aortic shunts. So what we are seeing here, we are seeing dilated central pulmonary arterioles, the main pulmonary trunk, the central pulmonary arteries, and also the lobar and the segmental arteries, but the peripheral arterioles are not that dilated. That is because the reactive pulmonary arteriosclerosis has sets in, and the shunt is reduced, that is the left to right shunt is reduced, and ultimately it is reversed, and the heart size comes to normal. Now we'll talk of total anomalous pulmonary venous drainage. The more frequent variant of complete mixing of the systemic and pulmonary venous return to heart when all the pulmonary veins drain directly or indirectly to the right atrium. Supracardiac drainage of the pulmonary veins is the most commonest frequent pattern of total anomalous pulmonary venous drainage, draining into the left innominate vein. Enlarged supracardiac veins alongside with the enlarged pulmonary artery are contributed to the altered cardiac silhouette and pulmonary plethora. Enlarged heart is due to enlarged right atrium and ventricle, along with the bilateral convexity of the enlarged superior mediastinal silhouette, giving rise to snowman's, figure of 8, or cottage loaf of bread heart, which Dr. Jain has already shown you. So we'll see the same X-ray, giving rise to a figure of 8 appearance of the heart. Cardiomegaly is there, but a concurrent pulmonary venous stenosis is also occurring here, yielding a pulmonary oligemia. So what happens is this: the right and the left pulmonary vein, they join behind the left atrium, form an anomalous vertical vein, which traverses and takes the left superior mediastinal silhouette, joins underneath the left innominate vein, which in turn drain into the superior vena cava. The superior vena cava is dilated and engorged, which in turn drains into the right atrium, causing a dilated right superior mediastinal silhouette. The right atrium gets engorged and dilated, which in turn drains into the right ventricle. So the resultant picture, you're getting an enlarged superior mediastinal silhouette on either side, one due to the pulmonary and anomalous vein, another secondary to the engorged and dilated superior vena cava. Here, there is again dominated contour because of the right atrium enlargement, giving rise to a typically snowman appearance or a figure of heart appearance. Talking of persistent common truncus arteriosus, a common truncus arteriosus arises collecting the total outflow from both the ventricles. An invariable association is high VSD, above which the truncus arises. The intercardiac mixing of the blood flow results in cyanosis. Enlarged heart with biventricular enlargement is the feature. Deep concave pulmonary bay with small hilar, a rounded cardiac apex, and elevated well above the diaphragm, giving rise to a sitting duck appearance. So in persistent common truncus arteriosus, what we see an enlarged heart with a deep concave pulmonary bay, a rounded elevated apex, small hilar, and the truncal arch is on the right side. A concurrent pulmonary venous stenosis is also occurring here, giving rise to oligemic lung fills, and ultimately the feature is this sitting duck appearance, which is signatory of the persistent common truncus arteriosus. Uncorrected transposition of great arteries. Here there is biventricular ventricular arterial discordance, meaning right ventricle giving rise to aorta and left ventricle giving rise to pulmonary artery. Rest, the systemic veins, the pulmonary veins, the right and the right ventricle and the right atrium, left atrium and the left ventricle appears normal. That is veno-atrial concordance and atrioventricular concordance. This hemodynamic situation is not at all compatible with postnatal life, as no oxygen will reach the aorta and the neonate will die immediately after birth. So shunt has to be established from right to left and left to right, and should be established at equal volume and in all levels. That is, this is the normal circulation, where the vena cava comes from the reaches the right atrium. Blood from the right atrium goes to right ventricle to the pulmonary circuit. Comes oxygenated blood to the pulmonary veins. From the left atrium to the left ventricle, ultimately makes its way to the aorta to systemic circulation. What happens in this uncorrected position, since the right ventricle gives rise to the aorta, so the oxygenated blood never reaches the aorta. While here, the pulmonary veins reaches the left atrium, goes to the left ventricle, and goes to the pulmonary circuit again. It is not compatible with life. So shunt has to be established either at the ductal level or at the ventricular level or at the atrial level, and they should be equal and opposite. The right heart border is usually more convex and prominent than the normal due to enlargement of the right atrium. This produces an on frontal projection, a globular heart likened to an egg on its side or egg on string appearance. The superior mediastinum is narrow in frontal projection and wide on lateral view, as both the ascending aorta anteriorly and the pulmonary artery posteriorly tend to lie on the same midline. The pulmonary trunk here arises from the left ventricle and takes origin in the midline behind the ascending aorta and within the concavity of the aortic arch. So it does not participate in border forming, and so the hilum are hidden in the mediastinum instead of contributing prominent to the hilum as in normal anatomy. So here in frontal radiograph, we see a lobulated ovoid heart with enlarged lobulated contour of the right heart border secondary to enlarged right atrium. We can also see the narrowing of the superior mediastinum, and we can see a bit oligamic lung fields likened to a egg on string or a egg lying on its side heart. Talking of corrected transposition of great arteries, the abnormal circulation of uncorrected transposition of great arteries, that is ventriculo-arterial discordance, is corrected by a second development anomaly, atrioventricular discordance. The atrioventricular discordance is due to displacement of the right ventricle to the left ventricle. This coronal malposition of two ventricles is termed as inversion of the ventricles. So what happens here? From the blood from the vena cava reaches the right atrium of deoxygenated blood. It goes to the left ventricle. From there, it goes to the pulmonary artery. The pulmonary veins reaches the left atrium. From there, it goes to the right ventricle and it goes to the aorta. So purpose of life is established and it is compatible with life because oxygenated blood reaches the systemic circulation. Position of the ascending aorta is the take-home message here, forming the slightly convex right border of the superior mediastinum, forming a long convexity along the upper portion of the left cardiac border to reach the aortic arch, which lies to the left of the trachea in normals. Lungs usually plethoric. So you can see the cardiomegaly here in this frontal radiograph. We can appreciate also a long convex border in the upper cardiac border formed by the ascending arch, which is arising here, and it goes to meet the aortic arch, which lies left of the trachea, forming a classic appearance of a corrected transposition of the great arteries. Talking of Epstein's anomaly, the septal and the posterior leaflets of the tricuspid valve are attached to the wall of the middle of the right ventricular chamber instead of the tricuspid ring at the atrioventricular junction. Hence, the proximal portion of the right cavity is atrialized. So what happens here? We are seeing an enlarged globular heart with narrow vascular pedicle and pulmonary oligamy. High curved left heart border and squared apex is the hallmark of this condition, producing a box-shaped or a squared heart. In lateral projection, there will be increased contact with the sternum and a very sharply defined, almost edged cardiac outline due to reduced cardiac pulsation is the feature. So we can see typically a box-shaped heart, globular heart with sharp edged margin due to reduced cardiac pulsation. And since there is atrialization of the proximal right ventricle, so only the distal right ventricle only can contract. And since there is impeded ventricular contraction, there is stasis here, giving rise to a box-shaped heart, and there is narrow vascular pedicle as well. Talking of acquired heart valvular disease, that's a rheumatic mitral valvular disease, is the commonest. There is selective left atrial enlargement with particular affection of the left atrial appendage. The chronology of events here, the simple straightening of the left heart border to very bulge in the characteristic site of the left atrial appendage to enlargement of the left atrium to the right. So what we see in this frontal radiograph, we can see the left atrial appendage there is enlargement. There is a double contour of the heart, right heart, because of the left atrial chamber has dilated or enlarged to the right. There is this playing of the carina. And if you see nicely, there is upper lobar venous diversion, which is the hallmark of rheumatic mitral valvular disease. Yet in this another patient, this is a post-operative case, so where it speaks of volume overload. Because of this hydrostatic pulmonary edema, there is confluent acinar shadowing in both lungs, and also along with this, there is the prominence of the left atrial appendage, which speaks of rheumatic valvular disease. So do we have time for the spotters? Hello? Hello?
Yes, sir.
Yeah, can we go to the spotters?
Yes, sir.
Yeah. So spotter number 1. So I want to revise a bit. This, you can see a frontal radiograph. Here you are seeing something. Any takers for this case? I have purposely taken the images from my collection only. You can post in Q&A. So we can see a dilated pulmonary bed, that is the main pulmonary trunk is dilated, but it is not extending to the left main pulmonary artery. There is subtle pulmonary oligemia, and the heart size is normal, speaks of pulmonary valve stenosis. The second case is a lateral radiograph. Any taker? Yes. So there is enlarged right heart, and you can see the retrosternal filling here. So the right heart chambers are enlarged, right ventricle and the right atrium has enlarged. The left atrium has also enlarged, pushing the left bronchus to the posteriorly. So this is a case of VSD. So case number 3, spotter number 3. So we are seeing here dilated pulmonary arteries, central pulmonary arteries, but not so dilated peripheral pulmonary arteries. The heart size is essentially normal. This is an Eisenmenger's reaction, as there is reversal of the shunt from right to left, and this is pulmonary arterial obstruction Eisenmenger's reaction. A companion case to this is Eisenmenger's reaction to PDA, patent ductus arteriosus, where there is calcification of the central pulmonary artery as well as there is ductal calcification as well. Spotter number 4. Here we can see any takers for this case. Yes. So this is, you're seeing a figure of 8 appearance of the heart. So this is total anomalous pulmonary venous drainage, supracardiac types. So there are 3 types of total anomalous pulmonary venous drainage. One is the supracardiac type, one is the cardiac type, one is the infradiaphragmatic type. So this is the supracardiac type. A companion case can be, this is of infradiaphragmatic type, where if the pulmonary veins is forming a common anomalous pulmonary vein, goes through directly vertical down. In a supracardiac type, we have seen a vertical up. This goes through the vertical down through the esophageal hiatus and gets inserted and confluent into the portal venous system. So this is cardiac angiogram in venous phase. So you can see the confluence of the right and the left pulmonary vein going directly below through the anomalous pulmonary venous drainage and going to the portal venous circuit. This is the spotter number 5. We can see a high convexity of the ascending arch, ascending aorta, which is going into the arch of aorta, which lies in the left of the trachea. And this is the corrected transposition of the great arteries. Thank you. Thank you.
Thank you so much, sir. This wonderful talk. So there are a couple of questions
Yeah.
So, just one second. So someone wants to know how to explain. Someone wants you to explain again how gooseneck deformity occurs.
What deformity?
Gooseneck deformity.
Yeah. Yeah. So before we talk of atrial septal defect, we have to understand the ostium primum defect. The ostium primum defect is the second type of ASD, which is quite below the atrial septum, and it is because of the misplaced mitral valve. The mitral valve is positioned here, and the anterior leaflet goes on to attach the crista of the interventricular septum and forming the upper right border of the left ventricular outline. So as a result, since the anterior leaflet of the mitral valve, instead of attaching to the bicuspid ring, it goes on to attach to the crista of the interventricular septum. Here, the right border of the left ventricle is deformed. And if we do left ventricular angiogram, we'll see the resultant flow going from the left ventricle to the right atrium and not to the left atrium. So this is the classic chamber. This is the classic gooseneck deformity of the left ventricle and going to the right atrium and enlarging all the chambers of the heart. Yeah.
Thank you so much, sir. The next question is how to differentiate Epstein anomaly from pericardial effusion.
Yeah. Yeah. See, in pericardial effusion, what happens is this: you will not see a sharply defined etched margin. Here, because of the cardiac pulsation, you can see it is so vivid here. So this is one of the hallmarks of the Epstein's anomaly. Since there is atrialization of the proximal ventricle, so heart barely contracts, the right chamber barely contracts, and the stasis is this. And here also, while in pericardial effusion, it will not be a globular or box-shaped heart, rather it will be a flux-shaped heart. Flux-shaped heart means this: you are seeing not only the right chambers has enlarged, the right ventricular outflow tract is also enlarged, which is forming the left upper border also. So this is how you differentiate, because the convexity has started right from here. While in pericardial effusion, it will not be so globular actually, not so box-shaped. And the squared apex is also another take-home message for this Epstein's anomaly.
The next question is, can you please explain the changes of Eisenmengerization, the radiological changes?
Yeah. So Eisenmengerization is this: it is a protective phenomena of nature when a shunt, there is a large shunt from the left to right. What happens is this: the cardiac chambers enlarges. Lot of blood enters the pulmonary circulation, but the pulmonary circulation is not in a position to accept infinite amount of blood. So what happens is this: there is vasoconstriction of the peripheral arterial system. As the disease progresses, there is a protective, reactive pulmonary arterial sclerosis. And when it becomes more severe, there is calcification that I have seen in my spotter as well. So that was a ductal calcification and Eisenmenger's reaction to PDA. So when there is left to right shunt is more, the pulmonary circulation develops a protective phenomena to limit that shunt. And as a result, as it comes from the periphery to center, the reactive pulmonary arterial sclerosis, so the shunt is reduced and ultimately the shunt is reversed and the cardiomegaly reduces in size. And because of the large shunt from the left to right, what happens is the right chambers enlarges and the cardiac twist to the left. As Eisenmenger's reaction starts And as there is reactive pulmonary arteriosclerosis, and as the shunt is reversed, again the cardiac comes back to the normal position. I think I'm clear. It can be secondary to ASD, it can be secondary to VSD, it can be secondary to PDA. So this was a classic case of a severe isometric reaction to PDA.
Okay. Someone has a query. What are the chest X-ray findings in PDA?
Yeah. So PDA, what will have? It will have the same findings. Like we'll have a dilated. Yeah, I'll go back to the PDA. Yeah. In PDA, what happens is this. So the main pulmonary artery will enlarge. The main pulmonary trunk forms the floor of the pulmonary bay. So as a result of which, you will have a convexity at the region of pulmonary bay just below the aortic arch. And there will be plethora. Since there is dilatation of the central pulmonary arterioles, as well as the lobar and segmental arterioles, there will be a plethora of lung, along with cardiomegaly.
Okay. And the last question, someone wants to understand ostium primum and types of ASD in short. Once again.
Types of VSD.
ASD, atrial septal defect.
Okay, okay.
And ostium primum.
Okay, okay. Yeah. So atrial septal defect is the types of it is the commonest is the ostium secundum defect and also known as the fossa ovalis defect. The second type is the endocardial cushion defect. The endocardial cushion defect is again divided into the ostium primum defect and your persistent atrioventricular canal defect, which is a more severe type. The third type is the sinus venosus defect. So in sinus venosus defect, what we have? We have having aberrant pulmonary veins entering into the sinus venosus. While in sinus venosus defect, all in ostium secundum defect, which is the commonest of this thing. So it is much in the upper part of the atrial septum. And as a result of this ostium secundum and the fossa ovalis defect, so there will be enlargement of the chambers. While in ostium primum defect, which is the relatively milder type, here you will have, which is much down in the atrial septum, will have this type of gooseneck deformity. In the persistent atrioventricular defect, will have regurgitation of the blood coming from the left ventricle to the right atrium because the right interventricular septum is to the right of the intraatrial septum. So there is an endocardial cushion defect. So allows the blood from the left ventricle to the right atrium. So this is the whole scenario.
Thank you so much, sir. I think all the questions are answered. I once again thank you for this wonderful in-depth presentation. I'm sure everybody has their concepts cleared now.
Thank you.
Most welcome, sir. Next, I will like to call upon Dr. Sanjay Jain. So I would like to call upon Dr. Sanjay Jain, who will be talking on chest radiographs, mainly ICU radiographic tubes and lines. Dr. Sanjay Jain is the head of the department, radiology department at Prince Ali Khan Hospital, Mumbai. He is the member of the Indian Advisory Board, and he has been the ex-editor-in-chief for Indian Journal of Radiology. Thank you so much, sir. We are all delighted to listen from you. Over to you, sir.
How do where is the screen sharing?
So it will be at the bottom in
there.
green
There.
color.
Got it. Yeah, thank you.
Welcome, sir.
For the next 30 odd minutes, I'll be focusing on lines and tubes in ICU radiology. The best report that I've come in my life is lines and tubes are noted as shown. Honestly speaking, that is one of the wonderful reports. And I think many of us come across such reports. They keep on happening every day, whether we like it or not. But that's not the point of this lecture. The idea of telling residents is to look for each and every line and tube which is commonly used in day-to-day practice. See where it is supposed to be. Does it cause any harm to the patient? And if there is potential harm, whether it's significant or not significant, and accordingly take immediate action. According to ACR category 2000 appropriate criteria, only initial radiographs are needed to be taken at the time, just immediately after the time of insertion. Okay. Otherwise, daily X-rays are just reserved for patients who are on mechanical ventilation. Bakemeyer found almost 27% of newly placed catheters or tubes which were improperly positioned, and 6% of them resulted in a radiographically visible complication. I think that's really important for us to look at these tubes. This is the X-ray that we face every day, and especially a tertiary care hospital would surely have, such X-rays coming up. And as I earlier said, we need to understand which is where. Remember, all catheters, irrespective of whether it is X or Y or Z, run the risk of coiling, misplacement, knotting, and fracture, leading to embolism. Nasogastric tube, 10 centimeters of the tube should lie within the stomach, distal to the GE junction. That's important. Nasoduodenal tube should be at least 10 to 12 centimeters, preferably beyond the ligament of Treats. We can use it. We can guide it on fluoroscopy. And you need to be very particular about the tip, because if you have an endotracheal tube along with it, there's a good chance of aspiration up to the region of the amount of 75%. You must confirm the location and then use. That's the classical positioning of nasogastric tube, the nasoduodenal tube. This is around the fourth part. A little further is the ligament of Treats. If a nasogastric tube goes across the midline to the right, and if there is evidence of recent thoracic surgery, there are skin staples, don't worry, this is absolutely normal. This is a gastric pull through which has been done. No need for concern. Coming to malpositions, this is a nasogastric tube which is looped in the proximal esophagus. That's the tip. You can imagine if you start feeding such a person. That's again the nasogastric tube which is coiled in the mid-esophagus, a good chance of aspiration. That's a tube in the anesthesia. It came from the patient still was just under anesthesia and they were not getting the right. They felt the anesthetist came down with the X-ray. Now this tube has gone in the left bronchus intermedius and gone finally into the right bronchus intermedius. Remember, if anesthetists or cardiac surgeons chase you, there is something really wrong. They were not able to cannulate the esophagus properly. So that's the issue. Here we have any takers for this. Where is the tip of the tube? Chaitali, we have any mechanism to have somebody writing something?
Yes, sir. So they'll be
Anybody
answering.
quickly. We are running a little behind the clock, I believe. This was unfortunately, or fortunately, this came to me and I had no choice but to call up. But by that time, they had already, put the tube and started feeding. Were they right? Were they wrong?
So you'll get the answers in the chat section.
Okay. No, there is nothing. Okay, you think they will answer?
Sir, they have answered. So people have said left below diaphragm.
Okay. I couldn't
left
see
lower
them.
lobe tube.
Wow.
Left main bronchus.
Left bronchus intermedius has gone way down in the left lower lobe, and they have already started the feed. That's what I meant, that I really couldn't do anything. That's aspiration basically, and that's pretty catastrophic. So this is to be avoided. If you find something like this, you have to immediately call up and tell them to withdraw the tube. Endotracheal tubes typically in adults 4 to 7 centimeters, and with the positioning it can vary a little, about 2 centimeters caudal or cephalate with neck flexion and extension. Remember, The ET tube does not move by itself, okay? But the relationship of the larynx with the trachea changes, inflection and extension. So that's the significance. Nevertheless, if you find an endotracheal tube in the right main bronchus, you need to immediately call up the respective service department. That's just a schematic representation to show the tube in flexion, then in neutral position, and in extension. An important point is the rule of the thumb, which I always advocate in adult radiology, is at the medial ends of the clavicle. If you have the ET and tip of the endotracheal tube at the medial end of the clavicle, be assured everything is absolutely fine. Of course, you need to look at the other tubes that I will show you as we go on. Armored endotracheal tubes are a little different. They serve the same purpose, but they are used intraoperatively, especially for head and neck and neurosurgeries. Here we have an endotracheal tube which is way up. What I have said, it should be at the level of the medial ends of the clavicle. This is highly positioned. You can tell the clinician to push it down. That's what your interpretation would help. Then we have the endotracheal tube in the right main bronchus. It's caused a distinct collapse of the left lung, but predominantly it's affected the left lobe, left lower lobe. And immediately I called upon and look at the repositioning. It's just pulled up a bit and the left lung has re-expanded. Any takers on this? This was an urgent intervention done in the night, and endotracheal had to be put. The patient had stroke. Anything of any concern? Any any takers on this chat box? Chaitali, you could enlighten me. Anybody, quickly. We don't have time. It's just
No, but
stat. Nobody.
pneumomediastinum, left retrocardiac opacity.
Okay. Wow. Very interesting. I was awakened in the night just for interpreting this X-ray. While the tube was being inserted, the endotracheal tube, one of the incisors got dislodged and it went and lodged into the right main bronchus. They were wondering, still the patient was coughing. Then later on it went in the left main bronchus and in the just close to the bronchus intermedius. So you see, immediately the patient had to be taken for bronchoscopy, and that's the end of the story. So that's very important. You as radiologist, you need to be looking at all these things, and you don't lead. And of course, when I asked the person who intubated, sir, yes, the incisor had got dislodged, but we don't know where it is. That's a standard question, and I mean that's the standard answer that we get. Okay. This I have shown you. It shouldn't be difficult. Esophageal intubation, you see a lot of gastric dilatation. Remember, the endotracheal tube cuff is something which we never look at. But I have brought it to the notice of many clinician and intensivists. Remember, the cuff should not cause any change in the tracheal contour. Okay, there should be no focal bulge. If there is a bulge, that means the cuff pressures are high. They know the guidelines for cuff pressures. That's not the point, but you have all kinds of new people coming, and at times we have significant bulges like this is atrocious. If you see something like this, there will be chances of tracheal stenosis later on. So if you something like that, this is a point of which you should always look at. Apart from the tip that I have shown you, you should also look at the cuff, and which should not produce any contour change. Complications are many. I'll show you most of them. Here we have the endotracheal tube. You see pneumomediastinum and surgical emphysema. That's the complication. This is part of the intubation process. So that's one. Then tracheal stenosis can be a late complication. It goes a lot to say about the ICU care. If you see tracheal stenosis too often in one center, there is something wrong with the ICU care. That's the way I go about interpreting. Tracheostomies typically should lie between the stoma and the carina, which is what I would say middle third of the carina. And that's where the position should be. it should always go along the tracheal contour. Okay, that's something you need to remember. Look at the tracheostomy tube, of course, and look at the trachea, how it is going. It should be in sync with them. However, now look at this radiology picture. We have the tracheostomy tube going across the middle, in the horizontal, near horizontal plane on the right side. That's definitely not acceptable. All that I had to tell them, the surgeons, please reposition it. And once they repositioned it, it was properly in the trachea. One more Q&A, if anybody can pick up. This was a tracheostomy tube. The position is pretty fine, but there is something else to it. Apart from the lung infiltrate, is there anything else that anybody can see? Any Q&As? I mean, any question, any answers? Anybody?
Everybody's answering.
Okay.
Aortic calcification.
Okay, that's over.
Teeth. Everybody's answering a tooth in bronchus. Yeah.
Wow.
Tooth in bronchus.
Superb. I'm glad that now we are going to start looking at teeth carefully on chest radiographs. Okay, especially the adult ones. That's where we come into contact with teeth. So that's definitely a molar in the right bronchus intermedius. And this was a tracheostomy tube. But all kinds of things are possible. This may have been there much before when the ET was considered. And then they had to, put in a tracheostomy for long-term ventilation. Then we have tracheostomy tubes giving rise to pretty disastrous complications like tension pneumothorax, pneumomediastinum, extensive surgical emphysema. This was unfortunate, a young male who had undergone an emergency tracheostomy. He was breathless. God knows what the reason was. Was it the cause or the effect? He had severe bilateral pneumothorax, which turned out to be a fatal event. They were trying to save him, and they created significant bilateral pneumothorax, and the patient collapsed on the table. So we kind of see all kinds of things. As I always tell you, look at the tracheal contour. Look at the trachea. Okay, this tracheostomy tube is going in the other direction. So this is definitely not acceptable. Here the tube was communicating with the esophagus. You see a lot of consolidation, which is nothing but aspiration pneumonia. So that's something which you need to remember always. Pleural and mediastinal drainage tubes, they look apart. Only thing is positioning. It's cephalad for pneumothorax, caudate for effusion. For us, no side hole should lie outside the chest. That's important. This is a patient with polytrauma, multiple rib fractures, scapular fractures. You see, these are the side holes that I'm talking about. They all need to be in the chest wall. Okay, there is a lot of subcutaneous emphysema. We see, the ICD tubes bilaterally. This is unfortunate. You see this side hole outside in the chest wall, giving rise to subcutaneous emphysema. This is a side hole on the left side, very small amount of subcutaneous emphysema. And this is way down. The pleural effusion is here. They should be talking about drainage here, way down. This needs to be repositioned. Here, there is a moderate pleural effusion, but the tube is in the chest wall, out much far away from the chest wall, not acceptable. So you must be conscious about all this. Here we have a hydropneumothorax, that is the air, and the tube is inferiorly placed. Just had to tell them to push it up, and all the hydropneumothorax disappeared. And this, any Q&As, Chaitali? This is a pneumothorax. We have put in an intercostal drainage tube. You think this is okay? Okay, not okay. If not okay, where is the tube?
No answers yet.
Okay.
Not okay.
Not okay. Fantastic. I'm glad.
Pericardium.
Absolutely right. This is abutting the pericardium. This is malposition. We had a CT done for the same, not acceptable. Actually, it's seen on the radiograph itself. It's surely not acceptable. It needs to be pulled out and repositioned into the pleural cavity. This was repositioned and it did its job. What about this? Is the tube okay? There's a good amount of effusion. We have loculations up, down. Is the tube okay? This is the side hole that I always keep on talking about. This is well within the chest wall. Any Q&As? Anything coming up?
Fissural. The tube is in the fissure.
Okay. You think still it is in the fissure?
People are just saying it's not okay.
It's not. Sure, it's not okay. It's not in the fissure either. So it's definitely in the lung. We see
Parenchyma.
yes, lung parenchyma, and definitely it's not okay. And it needs to be repositioned here in the, they need to just put it this way so that this can drain off, and they might need an additional tube to take care of the upper zone localization. Central venous lines, very important. Some keynotes I will explain to you. The tip of catheter should be along the inner aspect of the first strips because the distal valves lie there. And anything beyond that towards the SVC is absolutely fine. It may be in the left brachiocephalic, the right brachiocephalic, no issues. The SVC is where you would want. Very ideally, the tube should be at the cavoatrial junction where the SVC crosses the bronchus intermedius. That is the desired position of any tube. But as long as you put it, distal to these first strips, inner first strips, it's absolutely okay. Then we can have left-sided cannulations due to persistent left SVC. That is an example of showing the left SVC. The golden rules are the tip should be in the SVC. It should lie in a parallel course with the lateral wall of SVC. The rule of the thumb, one vertebral body caudate to the adjacent carina. It should not be directed laterally against the SVC fall. If you fail cannulation, don't worry, repeat a chest X-ray and then go on the opposite side. Okay, this is a very nicely positioned right jugular catheter, central venous line right at the cavoatrial junction. This is a desired position. Then we have port cats, the HD cats. Remember, HD cats invariably, I have seen they are in the right atrium. That's okay because they do a low puncture of the internal jugular. Complications, right heart position may cause arrhythmias, may expose the heart to undiluted toxic drugs. Aberrant or abnormal courses, pneumothorax is definitely seen in more than 5%. It's more common with subclavian than internal jugular cannulations. You may see venous perforation and cardiac perforation. That's an example of a right internal jugular cannulation with a pneumothorax on the right side. This is a subclavian cannulation which shows pneumothorax on the left side. Any takers on this quickly? This is an endotracheal tube. The child, there is an opaque right hemithorax, but the catheter is a little beyond what I would say is the projected SVC. That is where I would expect the SVC, the catheter to go. Quick, anybody? Chaitali, any answers
Within
we
the
have?
parenchyma.
Before the parenchyma, there is something else, the pleura. Okay, so this is actually, they have been feeding the right pleural cavity with intravenous fluids. While cannulation, they punctured the IJV and it entered the apical pleura, and that's how it's landed up with in the pleural cavity, and all the IV fluids have gone in the pleural space. Okay, and be wary of something like this. This is something which is seen clinically, but as radiologists, can you pick up any Q&As? Quick. What do you think about this? There is a right subclavian double lumen catheter, well neatly positioned. Any complication that you see? Quick.
No answer yet.
Okay. Look at the trachea carefully. That's the right border. It's going a little like this. You see a large soft tissue. The nephrologist had punctured the internal jugular. He couldn't, so he created a big hematoma here. See, anything displacing the trachea in ICU is usually a hematoma. Okay, that's the commonest thing that we see. So But intraoperatively, you can have right superior mediastinal hematomas also during, this was a Swan-Ganz cannulation. I'll come to that cannulation later. Then we have situations in which you can have the step which is directed at the lateral wall of the SVC. I always tell them to withdraw the catheter, but for God knows what reason they still keep it. But when I personally talk to them, I tell them at least withdraw a little by few centimeters so that it's okay if it lies in the brachiocephalic. And then you have all these abnormal courses, left jugular going into the right subclavian. This is having a seesaw mechanism. The jugular again going into the subclavian, and the right PICC going into the right internal jugular. You will come across all kinds of situations. Here it is right in the ventricle. Port cath, I had to call the surgeon, tell him to withdraw it. That's not an acceptable position. And any takers on this? This is day 2 PDA operated, and something which made, remember, if a cardiac surgeon or an anesthetist calls us, they are in deep trouble. So this was the case. It was a situation in which I was called just to interpret. Anybody, you can see anything?
No,
Q&As, Q&As. This is a nice case. You will see it maybe once in few years. I don't know. Anyone? It's
broken
difficult.
fragment catheter in the heart.
Oh, wow. So that's pretty nice. This patient was a PDA. Dr. Datta showed very nice cases of PDA. This is an intercostal drainage tube, well positioned. This catheter tip couldn't be ascertained clinically. They were wondering where the catheter is. Okay. And unfortunately, the catheter broke and it migrated into the SVC. This patient immediately went for an exploration, and they nicked the SVC and removed the catheter. So this is fracture of a central venous catheter. Okay. What about takers for this? Remember what I said, what the course of the central venous line should be. Is this the way I have taught, or it's something funny? Anyone? This was done at another hospital. This patient had acute MI. There was a junior registrar who wanted to have an intravenous access. And this X-ray was shot to me. I mean, it was sent to me for interpretation. I said, look, there's something else to it. Anyone?
People are
Q&As?
saying catheter in mediastinum, medial wall of SVC, too medially directed, intra-arterial,
Perfect.
subclavian to IGB.
Fine, absolutely. The central venous catheter course should be like this. I'm drawing it. Okay, it should be going this way. Okay, it's far too medial. And whenever you see far too medial, it's an arterial cannulation. This was in the artery, no question. Patient developed a massive neck hematoma and patient collapsed. So this is definitely this something which you need to remember. Medial, course, it is usually an arterial cannulation. Okay. Then we had another case in which the catheter went across the midline to the left side. This patient had interstitial edema, known case of renal failure. This patient was indeed, this is of course an intra-arterial cannulation, and patient developed a large pseudoaneurysm in the neck, and this was stented later on, and the patient is doing just pretty well now, no issues. This is venous congestion now. What about this? Where do you think this catheter is? This is a double lumen catheter put in by a nephrologist. Anybody? Where do you think this is? I showed you the course of left SVC, but this is left SVC or something else?
People are saying left SVC.
So did I, but I deferred because left SVC, if you see, it just goes till here. That's it. Okay, this was a CT was done. In fact, nobody could make out where is this vessel going. Even a DSA has been done, and it is, I think, just one of these anomalous vessels, pericardiophrenik vein, or one of those. which was responsible. Anyway, they removed the catheter since we were not sure where the catheter is, and they did a different cannulation altogether. In doing so, in putting in the port catheters, this is a patient of CA breast. We see left mastectomy. People forget guide wires. Okay, this is a port which has been put, but they forget to remove guide wires. So anyway, our interventional team removed it, and God bless the patient. So we tend to have all kinds of things. Another patient with retained guide wire, and in fact, that we don't see any catheter, but just the guide wire has been left. Now, these are situations which are commonly seen, and you need to be pretty careful about interpreting. Swan-Ganz catheter, I don't know how many of you all would have seen it being used and actually come to a reporting table. The rule of the thumb is basically it should not be more than a centimeter lateral to the mediastinum, basically in the left pulmonary artery or the right pulmonary artery. That's where it should be. The balloon is typically inflated only during wedge pressure measurements. And the idea of using a Swan-Ganz is basically measuring the left heart pressures by cannulation of the right side. Okay, that's the basic rule about Swan-Ganz. So that's the ideal position of a Swan-Ganz. Shouldn't go beyond this. Anything more than that is pretty not acceptable. This is in the right main pulmonary artery. It's like a central venous line, but a loop which goes down, 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 and comes up like this. So that is a Swan-Ganz catheter. Okay. The complications are like any central venous lines. I have a few of them. Here it is knotted in the right pulmonary artery. Here it is knotted in the pulmonary outflow tract. And this has gone far more deeper in the interlobar artery, not acceptable. Bring it out. Here it has gone in the right low lobe artery, not acceptable. We would expect it just over the hilum. That's it. Here, there was no tracing coming. The intensivist called to me. The Swan-Ganz had actually gone into the IVC. Okay, we see all kinds of things happening. Here, the clinical manifestation was hemoptysis, massive hemoptysis. As when we took the X-ray, we saw a large area of consolidation around the catheter. And this is nothing but pulmonary infarction. Okay. Pulmonary infarction takes about few weeks to evolve, to subside completely radiologically, but the clinical presentation is very important. Hemoptysis, so that is nothing but infarction. Venous pacemakers look for four things: location, exit of pacer wires, alignment of various portions of the leads, and destination. Where in temporary or permanent, the tip, if it's a single lead pacemaker, the tip should be at the apex of the right ventricle. If it is double, the other tip should be in the right atrial appendage, in which case you see a bit of looping happening. If you see looping, it's perfectly fine. That's what is the correct position of the atrial lead. These are dual chamber. This is a single chamber permanent pacemaker. And then we have biventricular pacemakers in which the other lead paces the left ventricle and its tip lies in the coronary sinus. Okay, so we have seen examples, but you might come across chest x-rays, abdominal x-rays in which the pacemakers are positioned in the left upper quadrant of abdomen, which is absolutely fine. They suffer from all different kinds of congenital diseases in which they have conduction problems. And the left upper quadrant, I'm told by cardiac surgeons, is pretty much a convenient place for the pacemaker to not get dislodged. Coming to complications, fractures, perforation are the two very important things that I would focus at. Perforation, cardiac perforation, when the tip is within 3 millimeters of the edge of the heart or epicardial fat. That's very important. Here we have the temporary pacemaker in the right atrium. We expected it to go here. This has gone, it should be at the apex of the right ventricle. It's gone in the pulmonary outflow tract. One of the the atrial lead has gone into the internal jugular vein, not acceptable. Here we are seeing recoil of the ventricular lead in the right atrium, not acceptable. And this was an unusual case. It just came to me recently. Anybody, any takers for this? It's something which is very simple, nothing much to it. Anybody, any Q&As?
Yes, sir.
This would be very interesting if you could just tell me something which is funnily happening to these pacemakers. Something very simple.
Twiddler.
Sorry,
Somebody has said twiddler.
twiddler. I'll show you what a twiddler looks like. See, please note there is so much of a dangle of wires here next to the generator box. This is definitely not acceptable. But the problem is on the right side as well. So we have a situation in which both the pacemakers are, erroneously placed because of whatever reason. They tend to loosen up and things like that. They might have to do some major intervention and put. Now this is not twiddler. I'll show you what a twiddler is. This is a malpositioned left ventricular lead. It should be in the coronary sinus that I would expect it here. The right atrial lead is proper. The ventricular lead is proper. And this is Twiddler's syndrome. You see the entire dangle of wires around the generator box, and the tip has virtually come at the, the cavoatrial junction. Not at all acceptable. This is Twiddler's syndrome. This had to be recannulated, and they, put a new pacemaker. And then you have to look carefully for fractures. Okay, this is an atrial lead fracture on the right side. Anybody? Quick Q&As. We see
No answers yet.
Okay. Should I wait?
Fracture.
Wow, wonderful, wonderful. I'm glad we are looking at pacemaker leads carefully. That's a fracture there. No question about it. This was an interesting case, patient with chronic congestive heart failure, right pleural effusion, who had a biventricular pacemaker. That's the coronary sinus lead well positioned, the right ventricular lead well positioned, the right atrial lead well positioned. After a month, the patient came back, and we couldn't, in fact, the patient came to the casualty, the X-ray was sent to me. The coronary sinus lead, unfortunately, has migrated. That's the position. I'll show it to you, through the pericardium and into the liver. This proved to be a terminal event. She died immediately after this. So this is basically perforation of the pericardium, okay, and transdiaphragmatic migration. You see all kinds of things in pacemakers. AICDs are simply pacemakers which with defibrillators capability as well. So it has an inbuilt pacemaker. The way to identify an AICD is, you have short, wider electrodes and a coiled spring appearance. One is in the right atrium and the other one is in the right ventricle. You can have single chamber AICD leads. Again, the apex has to be at the apex of the tip has to be at the apex of the right ventricle. Whenever you see these broad bands, think that we are dealing with AICDs. Usually, by and large, that's the way we distinguish. Not that it is imperative for you to always write on paper that this is an AICD. Even if you mention it as pacemaker, it is absolutely fine. Nobody's going to catch you. But for better comprehension and understanding as to what the clinical scenario would be. Now, this was a very interesting X-ray. This is a well-positioned right atrial lead, well-positioned right ventricular lead at the cardiac apex. Everything is fine, but this is a properly positioned pacemaker device. Complications are, AICD device. Let's look at this broadband here that we are seeing. And complications are similar to transvenous pacemakers. This is one patient. This is a large emphysematous bulla. Don't bother about it. The AICD has been put. There is a broadband down. The right atrial lead, the ventricular lead is absolutely fine. No problem. But 24 hours later, the pacing had stopped. And you see this cardiac apex. And the tip had actually reached the cardiac apex. Just the difference is it was a few millimeters. Frankly, I suspected that has the catheter migrated, they did an echo, they did an angio again. They felt it had actually gone across the myocardium and about to go out. So they withdrew it and transfixed it where it should be. That is the final position, the atrial and the ventricular lead. So that was withdrawn and transfixed in the right ventricular apex. So this is where radiology comes really into picture. Here we have a biventricular AICD. Unfortunately, the coronary sinus lead has migrated into the right ventricle. I would expect it to go like this. And any takers on this quickly? This is an AICD with a complication. The usual AICD, right atrial, right ventricular. Some complication is there. Anybody? Quick. Any takers for this?
Fracture of the lead, atrial lead malposition.
Okay. See, this is okay for an AICD as long as it paces, they are not bothered. But this is definitely fracture. You need to pick this up. Okay, that's something which is the job of a radiologist. This should be the last one. Intra-aortic balloon pumps, they increase coronary blood flow and decrease myocardial oxygen consumption. It's identified by a rectangular marker, and the tip should lie distal to left subclavian artery above the lineal arteries. And the rule of the thumb is it should be slightly cephalic to the adjacent carina. Okay, so we have learned carina as a landmark. One vertebral body below the carina is where we would expect the tip of a central venous catheter, and slightly above it, we expect the tip of the intra-aortic balloon pump. Okay, it inflates during diastole and deflates during systole because coronary filling is maximum at that point in time. And it works by a cardiac counter pulsation technique. That's the identification of an intra-aortic balloon pump. It's perfectly positioned, and this is all that you are going to see in an intra-aortic balloon pump, nothing else. That's an ET well placed, right central venous catheter well placed. Then we have, the tip of the intra-aortic balloon pump going much beyond. In fact, it's gone into the aortic arch. The subclavian artery should be here, and it's gone into the arch. Not acceptable. You need to bring it down, withdraw immediately. This is a low positioned intra-aortic balloon pump. It should lie a little above the adjacent carina. And this is again a low position intra-aortic balloon pump. This is where ideally you would expect it, slightly cephalic to the carina. And at times, if you're fortunate, you might see the inflated balloon. Okay, that is once in a while, once in few hundreds, you might see it. What did we learn? We learned various lines and tubes. Where do they end? Is the desired tip all right? Any complications? This is a published article, and in IJRI, whenever they are porting, you want to read this article, you can read this. And thank you very much for your patience.
Thank you so much, sir, for this wonderful lecture on the lines and tubes. Up till now, we just have one question.
Tell me.
Does a chest tube lying in a fissure have to be repositioned?
Very ideally, yes. Very ideally, yes, because there is a good chance of, we have seen pneumothorax and all that happening. So ideally speaking, yes, but some clinicians differ, and they just let it be there.
Okay.
Yeah.
I don't see any more questions till now. If anybody has any queries, please type them immediately in the chat box.
Or you leave it, I'll answer them in just before my next lecture.
Sure, we'll do that,
Okay.
sir. Yep.
Okay. Thank you.
Thank you, sir.
Bye.
So now we'll be starting with the ortho session. That is the musculoskeletal session. And the first speaker for the musculoskeletal session is Dr. Srijita Ghosh. She is a senior consultant radiologist at Apollo Hospital, Kolkata, Vice President, IRIA West Bengal chapter. She has multiple presentations in national conferences a popular faculty for IRIA, IREP online resident lectures, as well as in Indian Radiologist YouTube teaching videos. She's also the co-editor of the popular radiology national magazine RadBuzz, and she has authored 2 chapters on the MSK volume of upcoming IRIA textbook. Hi, Shuchita ma'am.
Yeah, am I
And-
audible?
Yes, ma'am,
Certainly.
you are.
Thank you for the introduction.
Most welcome, ma'am. And before I hand over to you, I would say that she is a mentor to me, but in addition, I really look up to her as a friend. So thank you so much, ma'am, for always being there.
Yeah. And please help me screen share. I don't know what's happening.
Yeah. So, ma'am, now you can just go at the bottom and there'll be a share screen option, which will be green in color.
Where is it?
The bottom of your screen, the bottom of the YouTube, the Zoom webinar screen. Okay, you have those options of mute and stop video.
Yeah, I
on
just
the
did,
left
so now I
corner.
can't find any of those.
Just press escape so you'll come out of the full screen.
I've come out.
Okay. So now on the bottom there'll be mute and stop video.
Wait, this is, I'm not being able to screen share. Zoom. Zoom. Yes, okay. Screen share.
Yeah.
Is it coming?
Not
Screen
yet.
share.
You'll have to select
Share.
the, yeah.
Now is my
Yes.
screen?
Yes, your screen is visible.
My screen is visible.
Yes, we can see the PPT.
Okay.
Yeah.
Is this okay?
Yes, your video is off. That's up to you, ma'am. You want to keep it on or off?
Wait, how to put on the video? Video.
That's okay. I think we can just, after screen sharing, it would be a bit difficult. You'll have to escape out the whole thing. So that's okay, ma'am. We can just
It's
continue.
okay?
It's okay.
Just cut the video, okay?
Yes.
Thank you, Chaitali.
Welcome. ma'am.
And I begin. Oops. Okay. Okay. So hereby I begin the ortho series of the Masterclass CME Back to Basics. And I'm very sorry to all of you because you are having to skip your lunch break. You all must be hungry, but please bear with me. We have some few very exciting lectures coming up one after the other. Now, I begin the ortho series. I'm Dr. Srijita from Kolkata. And my topic is basically a very, very basic topic. I am not going to show you a series of, various entities. It's not about entities. It's not about spotters. It's all about an approach on how to read a bone radiograph. Now, a bone radiograph is all about black and white and various shades of gray. It's pretty dull colors, but that's why I'm trying to make this session a bit colorful, a bit different, and this background of my introductory slides suggests that. I'll try to give you an approach. Students, let me tell you, whatever you're reporting, whether it's a CT, whether it's an MR, if you have an algorithm in your mind, if you have an approach in your mind, if you follow certain steps mentally before putting it into writing, you will produce a report which is way far different from any of your colleagues. And my idea about this session is on how you should approach. What are the questions that should come into mind when a bone radiograph is kept in front of you, whether for your viva, whether for your day-to-day practice, before you write something clinically pertinent, so that the clinician who has asked you to report it always has a tendency of reading what you've written, other than, just ignoring a report, say, this is all absolutely, nonsense. And I just believe on my interpretation. Why should it be that? Your writing should be such that it should be clinically pertinent. So I have divided my lecture by answering 6 questions. The questions are, number 1, what is the density pattern of structures that we see in a bone radiograph? What parts of a bone can we study in a bone radiograph? Target the things written in red. Those are the things which should be finally imprinted in your mind at the end of the lecture. Whose bone am I seeing? Is it a pediatric patient, an adult patient, and a geriatric patient? Why? Because it's the same mechanism of injury or whatever, same mechanism and etiology will produce a different picture in children versus adults versus elderly. Next, which bone am I seeing? Are these bones a part of a joint? If so, whether they are a part of small joint or large joint? The most important question, question number 5. Why have I been asked to study this radiograph? What is the clinical suspicion? Is my report going to answer that suspicion? Is it going to narrow down the DD, or is it going to further confuse the clinician? And lastly, have I just looked at the bones and finished interpretation, or have I looked at the nook and corner of the radiograph, looking outside the bones, and completed my study? Before I begin, I just want to tell you, all exam going students, if you are kept, if an X-ray radiograph is kept in front of you, don't just say X-ray shoulder. The thing is, we are not dealing with an X-ray, we are dealing with a radiograph or an X-ray film. So the terminology of X-ray film or radiograph sounds better than this is an X-ray of a humerus. X-ray is something, an ionizing radiation just passing through our body. So just keep it in mind. If you can use the term radiograph, X-ray film, it is better. Coming to number 1, what is the density pattern in a bone radiograph? Density pattern of structures in a bone radiograph. Andrew felt sorry for cursing mammography. Air, fat, soft tissue, calcium, metal. On one end is air and one end is metal. So things which, like if the attenuation is completely black, it's all about radiograph is a map of X-rays, which are traversing through the body. So when it completely passes through a structure, it is black. On the other hand, if it is completely passing, it is not passing at all, it is metal. Whereas different structures, they attenuate the X-rays to a different amount, while bone attenuates to a higher amount, soft tissue and fat attenuates to a lesser amount, because of which we get these various shades of gray. And it is because of the poor difference in density that the soft tissue resolution is a little poor in X-rays of fat and soft tissue. Let's see with an example. This is a radiograph of the shoulder, which is showing the fat over here, the soft tissue over here, the bones over here. Out of the bone, this is the cortex, and this is the medullary region, which again shows a difference in density. But since this is a radiograph which is covering a part of the chest, we can see the black structure that is air. And on this hand, this is a prosthesis. So we get all the densities that we are seeing in a radiograph in this one slide. So these are the all the structures, all the densities which will be coming across in a radiograph. Question number 2. What parts of a bone can we study in a radiograph? For that matter, you need to know that bones is a part of the musculoskeletal system. But is it the only part? No. There are ligaments, tendons, muscles, cartilage, synovium, nerves, and blood vessels. But are everything going to be seen in a radiograph? No. Radiograph is meant for bones. For ligaments, tendons, muscles, cartilage, synovium, other things, we need to have an MRI. Let's see it with an example. And before that, I will tell you that out of the bones, again, there are specific parts which the radiograph can show, and there are specific parts that the radiograph cannot show. For that, we need to know the parts of a tubular bone. Now, the outermost covering is called the periosteum, which is a fibrocollagenous structure tightly around the bone. Then comes the bone. The outermost part is the compact or cortical bone. Why is it called compact? Because the osteocytes are tightly packed with very few small lacunes. Next comes the medullary bone, cancellous bone, or the spongy bone, which forms the bone matrix and supports the bone marrow. Is radiograph going to show abnormalities of all these 4 structures? No. Yes, it will show the periosteum. Yes, it will show the cortical bone patterns. The cancellous bone, yes, but bone marrow, I am sorry, no. Let's see with an example. The patient with acute pain after an injury has come with this radiograph. It is quite unremarkable on the X-ray, but the MRI of this PD fat-sat image of the same patient shows significant edema, which the bone X-ray or X-ray radiograph has missed out. So bone marrow the X-ray is not the modality of choice for bone marrow edema and proper evaluation of the bone marrow. This is just to show you an example. Now coming to the other structures one by one. Periosteum tightly covers the bone, but can we see a normal periosteum in an X-ray? No, we can't. When there is a bone inside, and then within 10 to 21 days, a periosteal reaction occurs. This reaction elevates the periosteum from the underlying bone, and it is at that time when we can visualize the periosteum. Periosteum is important for blood supply and plays a role in bone healing. On the right-hand side, this periosteal elevation is kind of smooth, lamellated, which gives us an idea that probably we are dealing with a less aggressive lesion. Mind it, in my lecture, I am not going to speak about entity. I am just going to speak about patterns. So on this side, this is a periosteal elevation, a regular lamellated periosteal reaction. On the right side, the periosteal reaction looks aggressive, sunburst, and we are dealing with something aggressive and sinister. Coming to cortical bone, that is the dense bone, forming the major part of the long bones. The basic radiographic patterns are as follows. The commonest cortical bone radiographic problem that we see is cortical bone break, that is fracture. This is on the left-hand side, we see fracture in two views where there is cortical bone break. And on the right side, there is evidence of the cortex, they are kind of opposed and they are being there's an union going on between the fractured ends by osteoid tissue callus, which is nothing but highly vascular connective tissue with gradually osteoid tissue also coming in, trying to heal the fracture. Now we come to what is a cortical-based lesion. As I said, I am not going to speak about the diagnosis. I am going to speak about the pattern. So this is a cortical bone-based lesion. See the cortex over here, intact cortex and the expanded cortex with this lucency within. So this is just to give you an example what is a cortical-based lesion. This is an example where we see a lesion abutting the cortex. So this is a juxtacortical lesion. In this, the medulla is intact. So this is just to tell you what is a cortical-based lesion and what is a juxtacortical lesion. Now coming to medullary bone or cancellous bone. Now, medullary bone lies in between the compact bone and the bone matrix. In fact, the terms medullary bone and bone matrix can be interchangeably used. What we see in a normal radiograph is a adequately mineralized matrix. This radiodensity of the medullary bone is because of adequate mineralization. So what is inadequate mineralization? Coming to the right, we have generalized lucency, thinning of cortex. This is an example of under-mineralized matrix, which is relatively soft, prone to be bent. And this is exactly what we are seeing, an under-mineralized matrix, which has bent. In many cases, in many conditions, we can see, for example, in osteomalacia. I had shown you just a while back what is a cortical-based lesion. Now what we see is a medullary-based lesion. In this bone, these are the cortex. These are not involved. What is involved? This is a well-defined sclerotic kind of a lesion involving the medulla. So this is the medullary-based lesion. This is the medullary-based lesion, which is sclerotic. This lytic lesion again is involving the medullary bone and not the cortex. So I just wanted to tell you what is the difference between a cortical-based lesion and a medullary-based lesion. As I have already talked to you about the matrix, a little more, what are the varied type of matrix that we see? If we see bony tissue within the matrix, like osteoid matrix, this is a sinister looking lesion with osteoid matrix. Whereas this rings and arcs pattern gives us an idea about a chondroid matrix. So this is probably we are dealing with a cartilaginous bone tumor or whatever it is. I am again not going to tell you about the entity. I am just showing you an example of osteoid matrix, chondroid matrix. I've showed you a normal matrix. I've showed you a poorly mineralized matrix. Now, before I go on to the next question, just one word about cartilage. Cartilage is a very important component of the musculoskeletal system. It can be hyaline cartilage or fibrocartilage, but very sorry to say, none of these cartilaginous things can be seen on a bone radiograph. On my left is a condition called synovial chondromatosis, which is actually cartilaginous loose bodies. But you know why we are seeing these? Because they have been ossified. There is an element of calcification and ossification because of these loose bodies are seen in a radiograph. If they would have been purely cartilaginous, we wouldn't have seen it. Similarly, on the right-hand side, I have put this example to show you the effect that we see when there is cartilage loss. When there is cartilage loss, the bones get fused with loss of joint space. Then only we can understand that, yes, there is a cartilage loss going on inside. So this is just about it. The cartilage imaging, it's mainly a role of MRI, not of radiograph. We just see the after effects after getting calcified or when there's cartilage loss. Next, question number 3, very important. Whose bone am I seeing? There is a difference, anatomic difference, and some physiological differences between a child's bone and adult bone. While a child's bone, the diaphysis is developing from the primary ossification center. The epiphysis, that is the end of the bone, is developing from the secondary ossification center. Both are clearly divided by the cartilaginous growth plate, which appears as a distinct lucency in a bone radiograph. And the flared end of the diaphysis is what is called a metaphysis. But once this cartilage plate is, the growth plate fuses, all these three merge together. At that time, we just have a metaphysis, a flared end, the diaphysis, the flared end metaphysis, and the epiphyseal ends. The growth of the bone has stopped. We don't find the lucency separating the two. Let's see the example. So this is the diaphysis. This is the flared end, which is the metaphysis. This is the lucency, which is the transverse cartilaginous growth plate. And this is the ossiphysis, clearly separate from the diaphysis. But see over here, they have all fused. So we see the diaphysis, the metaphyseal end, and this is the epiphyseal part. None of these can be any more differentiated. Coming to this radiograph, I have taken this particularly for a reason. This is a radiograph of the wrist. This is an adult radiograph. All the epiphyseal centers have fused. The carpal bones have appeared. But once we see this exactly on this side, we know that this wrist belongs to someone younger than this, because over here, the distal end of the radius and the fibula, we see the growth plate still existing with the epiphysis still not formed. I mean, the epiphysis still not fused. Let me tell you, students, we will be often asked to read about read a radiograph of a young patient to calculate the bone age. For that matter, you have to remember that out of all the bones, the capitate comes first around 1 to 3 months, followed by the lunate, which comes 2 to 4 months. Hamate, which comes to capitate, followed by the hamate, which comes within 2 to 4 months, followed by the triquetrum, which comes around 2 to 3 years, then the lunate, which comes around 2 to 4 years, after which the scaphoid, trapezium, trapezoid, more or less, they come all around 4 to 6 years, and the last bone to come is 8 to 12 years. So starting from the capitate, if we go in an anti-clockwise manner, taking into consideration the volar surface of the right carpus, they go like this. So you just have to remember that the capitate and hamate are the first bones to appear, and the pisiform is the last bone to appear. This is something very, very important. If you want to read about the details, go to Grulich and Pyle or the Sutton Volume 2 Appendix, because yes, you will be asked to read bone radiographs of children to find out the bone age. What are the physiologic differences between child and adult? The osteoid has a lower density in children. They can be bent to a greater extent due to excessive collagen. The outer covering is strong but loosely attached, and the muscles directly arise from the periosteum. Let us see some examples where the same mechanism is producing a different picture in pediatric versus adult versus geriatric. While a trauma to the skull in a pediatric patient produces a diastatic fracture, which is traveling along the suture line, just causing widening of the suture. The same trauma may not produce that, will produce a line just not conforming to the sutures. So a trauma to the skull produces diastatic fractures in pediatric patients, whereas it does not follow the suture line in adults. Trauma to the forearm, usually in pediatrics, because as I said, because of high collagen content, they cause bending of the bone with one cortex intact and one cortex partially broken. This is called a green stick fracture. Whereas the same trauma will cause a through and through fracture through the much more brittle bones of adults. While a generalized osteopenic bone with a trivial trauma will cause a fracture like this, in an adult patient, a same fracture over here in a focal lucency like this in a young age will give us an idea that this is a focal lucency. So this is a pathological fracture because of some lytic lesion over here. I have taken this example just to show you generalized lucency with a fracture with a trivial injury, focal lucency in a pediatric patient with hardly any injury and a pathological fracture. Similarly, vertebral fracture in adults where all the bones are adequately mineralized, they are of same height, and the fracture line traverses through this. This is a collapse fracture in an osteoporotic geriatric spine because of bone softening. Varied degree of collapse of the bones have occurred. And look at the density pattern, look at the density difference, look at the collapse, look at the other vertebra, look at the generalized vertebral body height reduction to see the differentiate between an adult versus a geriatric patient vertebral fracture. This is, again, as we see, unfused epiphysis, a sinister looking lesion over here with lamellated periosteal reaction will first give you will make you think that probably we are dealing with an Ewing sarcoma. Whereas in a young adult with fused epiphysis, such a sinister looking lesion with osteoid matrix, with periosteal reaction, which is not very sinister, will make us think that yes, probably we are dealing with a kind of osteosarcoma. So the same neoplastic process in a pediatrics versus adult patient will give differential diagnosis will be different in our minds. Another example, we find a lytic lesion over here eccentrically located in the epiphysis and the metaphysis with a thin sclerotic lesion in an unfused epiphysis. We will be first thinking of chondroblastoma, whereas a similar lesion where there is fusion of epiphysis, subarticular, no thin sclerosis over here, the first thing which will come into our mind is a giant cell tumor. So my idea is to tell you, when we find a lesion, if we see the age group, the differentials will be different in our mind. And we have to know about this. Question number 4. So I have completed with why we need to check the age of the patient before we start writing our report. Number 4, which bone am I seeing? Are these bones a part of a joint? If so, are they a small joint, larger joint, or a small joint? Let's see. So what are the 5 types of bones that we will come across when we are asked to read a radiograph of a bone? They are either long bones, say the humerus, radius ulna, femur, tibia fibula. They may be flat bones like that of the calvarium. They may be irregular bones, that is the vertebra. They may be short bones like the metatarsals and the metacarpals, and they may be sesamoid bones. So more the number of bones, our eyes have to traverse more along the more surfaces to look for hairline fractures. So we have to exert more compared to the longer and the bigger bones. Coming to the joints, they can be either a part of large joint like the elbow joint or the shoulder joint, or they can be a part of the big joints of the lower limb, that's the knee joint, hip joint, or they can be small joints like carpal joints, tarsal joints, tarsometatarsal, interphalangeal joints, etc. So these are the things we have to look when we are looking at we have to look at the surfaces of all the bones. Question number 5, and the most important, students, please listen to what I'm saying. Why have I been asked to study the particular radiograph? What is the clinical suspicion? Many a times you will be asked to read a radiograph with no clinical history, and you will just write NAD. That is not acceptable in today's day. You have to find out the prescription. If it is an inpatient, you have to take out the file if the history is not provided. History is a must. You all have to be clinical radiologists and not just describe whatever you're seeing in black and white in front of you in the view backs. No, 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 that is not acceptable. See the prescription. It will clearly tell you why the doctor, the clinician has asked for the radiograph. And there are few things that you have to remember in the mind, the conditions that you have to see. Now, this mnemonic is quite helpful. CITINO, C, congenital, T, traumatic, I, infective, I, inflammatory, neoplastic, and others. So these are the conditions anyway, which you have to describe in your radiograph. So after you have seen the prescription, then you will come to your next step, that is find out what you're dealing with. So number 1, congenital. Now, congenital bone defect can be either in the form of supernumerary number of bones. There's extra bone where it's not supposed to be, a deficient bone where it's not supposed to be, or abnormal shape of the bone. So if while reporting a radiograph, you see these extra bones over here, the cervical ribs, you have to know one thing. Whenever you're seeing congenital defects, you have to know when to call the patient back to image certain other parts of the bone, and when just to leave it and give the report. So over here, you can say bilateral cervical ribs, but if you are a little more interested, you can call the patient up and find out whether he has numbness and tingling sensation. So that will, give you an edge above others. Yes, this is a symptomatic cervical rib. On the other hand, if you come across a radiograph when you are just seeing bifid ribs like this is not a condition where you have to call the patient and image any other body part. On the other hand, if you, while imaging, you get a patient, a young patient with absent patella, and that patient has only come for the knee joint radiograph, call the patient and image the pelvis as well as the elbow. If you find that these iliac horns over here and hyperplastic radial head, so you can all together make it into one syndrome. We are dealing with nail patella syndrome. So students, you have to know the multifocal, multifocal congenital abnormalities, where the congenital abnormalities appear, so that you can exactly target those areas, get the patient and take radiographs of those. For that, you have to read a textbook rather than basing your studies only on net. Similarly, if we have a radiograph which is showing a bent radius like this, immediately you will know this, we are dealing with a mid-lung deformity. So what is mid-lung deformity? The ulna keeps on growing and the radius just stops growing and becomes bent. Students, exam-going students, the book Chapman should be in your tips, fingertips. They will be at the tip of your tongue. You see this, and you say, what are the conditions that you were associated with mid-lung? Hit talk, Hurler's, infection, traumatic, dyschondrosteosis, multiple osteochondriomatosis, and last C, congenital Turner's. So any radiograph which is kept in your Viva, and you have to immediately come up with the DDs. For example, Erlenmeyer flask, mid-lungs. So be prepared to have your knowledge in such a way that they are just coming out in your, they're at your fingertips. Absolutely. Chapman is a must for exam going students. Similarly, if you see this radiograph, the scapula is in normal place, but here there's a high riding scapula with a bony projection which is connecting it to the spine. This is called an omovertebral body. And immediately you know that this falls under the category where you have to image other parts of the bone. You have to image the spine. There is spina bifida, blocked vertebra. This is maybe we are dealing with Klippel-Feil syndrome. So in congenital, what I wanted to tell you is you have to know when to call the patient to image, when to call the patient to find out about further history and whether there is any symptoms, and thereby help your clinician. Next, traumatic. Since I've shown you most of the images in traumatic, I'll be quickly going through this section. If the prescription suggests trauma and you're dealing with a pediatric patient, look at the cortex. There may be a subtle buckling, and you're dealing with a torus fracture where there is axial loading causing bending of the cortex with no actual break. And again, as I've already spoken before, there may be a green stick fracture in children because of excessive collagen. One cortex intact, another cortex half broken, or a through and through fracture against a through and through fracture in adults. Again, a trivial trauma patient in a generalized osteoporotic bone, a pathological fracture where there is no actual history of trauma, but we see a cortical break because of a lucency, focal lucency, because of a tumor. Any fracture imaging description, if you have just one view, refrain from reporting that. See, the marker should be there, and two or basic orthogonal planes have to be there for characterization of the comminution and displacement. If by chance one of the films is not present and you are being forced to report it, don't. It is going to be absolutely horrible reporting on one orthogonal planes to describe the comminution. And after that, if you feel that there's a different kind of fracture, there are stress views, angulation views, which you can call the patient later to give a more descriptive and more perfect report. But the basic two views, orthogonal views, will help you characterize a dislocation and fracture fully before putting your report into writing. Traumatic versus non-traumatic vertebral fracture, I've already talked. Traumatic fracture, the vertebra otherwise are all okay in alignment, in density. We are seeing the fracture line. And non-traumatic vertebral collapse fracture will have varied softening of bone related deformity of the bones because fish vertebra plana because of osteoporotic soft bone. Now coming to the three important entities, we have completed CTIINO, CT over. IIN, I for infection, I for inflammation, and N for neoplasia. Let me tell you one thing. Here, history is of utmost importance. Not only that, lab parameters is also of very great importance to put a clinically excellent and pertinent report, helping your clinician immensely. If the patient has high fever, more systemic manifestations, increased neutrophilic count, raised ESR, CRP, pain stiffness occurring early, and if you can get the patient and see the swelling, redness, and ask him that this has developed over very few days, yes, probably we are dealing with infection. How many of you actually go through the lab parameters before reporting? I don't think so. From today, try it. Life will be very, very interesting. You will feel that, yes, we are clinical radiologists, not just writing in words what we are seeing in the, we are clinical radiologists. If it comes to inflammatory pathology, low-grade fever, less systemic manifestations, slightly increased neutrophilic count, but in comparison to infective, markedly raised DSR, CRP, and there are other inflammatory markers. Pain stiffness is there, gradually appearing. Swelling comes early and deformity comes later. Whereas in a neoplastic case, rest pain is common. It is more of an indolent, silent presentation. Lab parameters are quite unremarkable. If you get the patient in front of you, skin changes are common, and the patient often presents for the first time with a pathological fracture. In all these cases, if you have a habit of asking for the previous film to see whether the entity existed before or not, it helps, makes life a lot better, believe me. Now let's come to one by one, each of them. So when it's infective, as I said, I am not going to any particular entity. I'm talking of the patterns. Earliest infection can present just by soft tissue swelling, but if you match it with the lab parameters and the clinical parameters, you can stamp it, yes, we're dealing with infection. Gradually, a lucency appears or a sclerosis, and the periosteal insult produces a periosteal reaction like this. Gradually, as the infection progresses, the sclerosis of the cortical bone increases markedly as in comparison to acute. So chronic inflammation, the amount of sclerosis of the bone increases. Often we can see something like this, a lucency with a sclerotic center, that is the necrotic sequestered bone within the lucency, all surrounded by the reactive involucrum. So by seeing the density of the cortex, density of the lesion only, we can say, yes, we are dealing with an acute versus chronic infection. But of course, after coupling it with your knowledge about the lab parameters and if possible, examining the patient as well as old reports, if any. Coming to inflammatory, what are the radiological markers? First is joint swelling, which can be due to joint fluid or synovial hypertrophy. There is periarticular osteopenia. Already in the background, you have a knowledge that probably you're dealing with inflammatory by seeing the clinical findings and the lab parameters. Now, if we see erosions like this, which may be central, paracentral, or marginal, classic of rheumatoid arthritis, we know we are dealing with rheumatoid arthritis. On the other hand, as I've shown you before, cartilage loss and gradual joint space reduction, there is joint space loss gradually. And in the more marked cases, there's ill-defined margins of the bones. See the carpus bones, we can't understand. It's all so fuzzy. And finally, in the late stages, deformities appear. So joint swelling, periarticular osteopenia, erosions, joint space loss, ill-defined margin of bones, and deformities are all radiographic pointers towards an inflammatory bone disease. Coming to neoplastic, there is an extensive lecture coming up on bone tumors, and I am not going to any details in this. I just wanted to point out some things. Listen to what I'm saying. Many a times, bone tumor and bone infection mimic each other. Here, the clinicals matter. The lab parameters matter. Previous X-ray matters. What are the things that a radiologist is expected to find out? If the tumor, whether it is cortical best or medullary, which I've already shown you, whether it is affecting children, adults, or elderly, I have already shown you, whether it is aggressive versus non-aggressive, whether there is a pathological fracture, if it is possible to tell on a radiograph if there is a soft tissue extension, and next will be what will be the next modality of choice. So while I am again not going to details, just 1 minute, if it's a poorly demarcated wide zone of transition, poor marginated osteolysis, interrupted cortex, irregular periosteal reaction, rapid rate of change, we are dealing with an aggressive lesion. On the other hand, it's a well demarcated narrow zone of transition. Cortex is thinned out and not broken. We are dealing with a non-aggressive. So this is a pediatric bone, an expansor lytic lesion over here with a very narrow zone of transition, thinned out cortex, no soft tissue extension. We are dealing with a non-aggressive case. Whereas the sinister looking thing over here, which cannot be differentiated from the rest of the normal bone, there seems to be extensive soft tissue extension and periosteal reaction. We are dealing with aggressive. We have an entire lecture on bone tumors. I am not going to details. Others, when the prescription suggests none of this CTIIN, what can they be asking us for a radiograph? One of them is foreign bodies. We have to remember a patient has come with a prescription and a radiograph looking for foreign body. Not all foreign bodies can be seen on a radiograph. If it's a metallic foreign body, animal bone foreign body, glass, yes, we can see. But if we are not finding anything, we cannot write just finish your work and say, sorry, there's no foreign body. No, call the patient. Ask the patient what was the foreign body. If it was wood, plastic, I'm sorry, you will not see it in a radiograph. Take the patient up to the scanning room, ultrasound, and try to localize it. If it's a wooden foreign body, yes, it will be localized, not on radiograph, but on sonology. So you have to know which foreign body can be seen by which modality. Number 6, and the penultimate question to be answered, have I overlooked anything in the penumbra region? Penumbra means the outside of the shadow. We have finished with the center, that is, we've dealt with the bones. But don't just leave at this. See the external. If we see these radiolucencies over here in the soft tissue, this gives us an idea that probably we are dealing with an infection which is a gas forming organism. We are dealing with an infective pathology. If we see dense vascular calcification, don't ignore it. Please mention it. If possible, suggest a Doppler ultrasound. You may be reporting a radiograph for a patient who is going for a knee replacement surgery, and there is this dense vascular calcification. If you specify on this and the doctor undergoes an ultrasound, the outcome of the patient after the replacement may change. Other than a thrombus which is existing may dislodge, and there'll be a black toe at the end of the replacement. So you can save it by your observations of the penumbra region. A patient with shoulder pain, over here, the bones that are commonly looked at are normal, but we see the calcific density over here, which is in the tendon, gives us an idea of calcific tendinitis. This is a bone radiograph, knee joint, but we see the normal fibrocartilage, which we are not supposed to see. We are seeing calcification over here. So probably we are dealing with ochronosis where there is calcification of the fibrocartilage. Here are examples where penumbra region shows calcified lymph nodes, and this is venous phlebolysis, and this is the post-knee replacement case with osteoid tissue over here, myositis ossificans. So I have come to the end of my lecture. To recapitulate, now this is the same background, the colorful one I had started with. I really don't know whether you're feeling colorful or sleepy at the end of my lecture, but I have put a relatively practical background this time of the radiograph, all gray, and how it's supposed to be. Let us recapitulate each of these points before I end. What are the densities in a bone radiograph? Done. What parts of the bone can we interpret so that we know what is the next modality of choice we will suggest? Have we seen the age of the patient before putting a clinically pertinent report? What are the types of bones that we are supposed to see? The most important, have we gone through the prescription? If the prescription is not there, have we talked to the clinician? Have we brought the patient in front of us to get the exact clinical picture? And have we seen the radiograph from nook and corner? Have we missed out on the soft tissue pathology or around the bones? So if we have answered these questions mentally, now write a beautiful clinically pertinent report, which is going to stand apart from the rest of your colleagues. Just my last two slides to end, to give you an example how the algorithm that I said helps. This was one of my final FRCR cases. I'm sorry for the quality of the picture. The picture that was given to me in my examination was much more brighter. And in these exams, you're just given the radiograph and asked to speak, and you just have to go on speaking. So what are the bones that we are seeing? This is not exactly bones. This is a chest radiograph. We are seeing the chest, the bones. We see the spine. We see the clavicle. We see the ribs. We see the bones over here. On question number 1, yes, we see unfused epiphysis. We are dealing with a child. Now, next, I asked, what is the clinical issue? Why are we doing this? Why are we being asked to read the radiograph? This patient is a known patient of lymphoma, has come with severe cough and high fever and generalized body pain. Are we seeing any lung parenchymal lesion to explain the fever? No. Everything looks quite okay. The bones also, when I saw intricately in details, no, I'm not finding anything very remarkable. Go to the penumbra. It will give you just an example. Go to the penumbra, look at the axilla, See the soft tissue swelling over here. Do we expect it in a normal patient? No, these are the enlarged nodes, just to show you that yes, this is a lymphoma patient with bilateral axillary lymphadenopathy, who really does not have anything in the rest of the radiograph to explain the features. This is an example just to tell you that before you stop reading the radiograph in front of your examiner, don't forget to look at the penumbra, because then you have something to speak rather than telling the examiner, sorry, this is nothing, this is completely NAD. No, it is not NAD. There is something. My last case, this is a patient who had come from Odisha with acute joint pain after an injury. We see the knee joint over here. It's quite okay. The joint spaces are fine. But again, when we see the penumbra region, we see these calcified densities. These are rice body densities, calcific densities. We call the patient. Yes, the patient was working in a pig farm. And this is just to show you a picture where we are seeing some muscle cysticercosis. It was just an incidental finding, but I just kept this radiograph to tell you how important the penumbra region is before we go on to finish writing our report. So most of my images are there from my hospital, but just to make it an approach-based report, I have referred a lot of images from Google and Radiopedia. Thank you very much, Team Indian Radiologists. Thank you, AGFA. Thank you, all my viewers, for listening to me 30 minutes, without having lunch. Thank you very much. I hope that you are a part of our family. I hope to see all of you in our masterclass series, our YouTube tutorials, our Buzz series, and see you all for the MRI update. Thank you very, very much. Chaitali, it's already running late. If anybody has any questions, please can you give them my WhatsApp answer? And I just hand over the virtual dais to you for the next scintillating lecture by one of my favorite teachers, my favorite colleagues. Chaitali, over to you.
Thank you so much, ma'am. There are a couple of questions.
Please, can you tell them, give my phone number, WhatsApp number, I'll answer each of them. We are running late. You please take over the dais.
I'll do that. Thank you so much, ma'am, for this wonderful lecture.
Now tell me how to stop sharing screen. I'm a completely, what to do.
Okay. So, ma'am, there will be an option of stop screen share at the top,
Okay.
which will be in
Stop
red
share.
color.
Done,
Yes,
done.
it's done.
Okay.
Thank you so much, ma'am, for this wonderful lecture. You made my job really easy now.
Okay. Bye.
Bye,
all of
ma'am.
you. Bye.
Okay. So, just screen share. So, the next lecture is by me. I'll just introduce myself in short. I'm Dr. Chaitali Parekh. I'm a consultant musculoskeletal radiologist practicing in a couple of centers in Mumbai. And with this short intro, we'll start directly with the presentation. I'll stop my video for the time being so that you guys can actually just concentrate on the PPT. Just one sec. Yeah. Just if anyone can type in the chat box that can you see my screen? Is my presentation visible?
Yeah, Chaitali, we can see it.
Thank you. Thank you so much, sir. Okay. So the topic that we're going to discuss about is knee internal derangement and arthritis. The basic question is, are X-rays really useful? And I hope by the end of this session, you guys yourself will be able to answer this question. Okay, so first let us understand what is the A, B, C, D, E, F of knee radiographs. So the first thing is, the things that you need to look in a knee radiograph is arthritis, the bone density, fractures and internal derangements, destruction of the bone, which could be secondary to erosions, osteomyelitis, neoplastic etiology, tissues, and foreign bodies. Now, of this very long list, most of the how to approach a radiograph has already been discussed by Shujita ma'am. So for this session, we'll be concentrating on arthritis and fractures and internal derangements. Now, before we start the session, I just want all of you to just look at this particular X-ray and just answer this question. Let me see what answers come out. So can everybody just type in the chat box? Anybody with the answers? What do you think? What are the soft tissue structures which are injured in this particular patient? Okay. Okay. Right. So I've got a lot many answers. Now, the magic is I will not be giving you the answer right now. Let's go through the entire presentation and then let's see if you get the answer right again. Okay. So for the time being, let's concentrate on the presentation, and you guys have to find out the answer through this presentation. So whenever you're discussing about fractures and internal derangements, or for any knee radiograph for that matter, the views that you take is a AP radiograph and a lateral radiograph. And the third one is the skyline view. So in the AP radiograph, obviously you look at the femorotibial compartments, you look at the condyles of the femur, the distal femoral shaft, condyles of the tibia, the distal tibial shaft, fibula, patella. Similarly, look on the same bones. In the lateral view, you particularly look at the effusion, if there is any suprapatellar effusion or not. And the skyline view is mainly for the patellofemoral compartment. So these are the common radiographs that you take for any knee joint. And whenever you get a knee radiograph, this is what you tend to look at. So you'll obviously have a quick look for any obvious fractures. You'll see whether the joint space is normal or not. Is there any effusion? And the problem is that we all are in a hurry while reporting the radiographs because we want to report a bunch of radiographs in a short period of time. So we just, look at all the structures hurriedly, and then we say, Eureka, it's normal and my job is done. And then a small voice will come from behind. Are you really sure that this is normal? So today, we will create a pattern of how to look at this radiograph so that two things, you will have a speed in reporting these radiographs, plus you will not miss on anything. Okay, so for that purpose, you need to have a list of the review areas which you need to look at before you give the report as normal. Now, what are these review areas? So in the medial femorotibial compartment, particularly look at this region because this is where the medial collateral ligament goes and attaches to the femur. And there can be osseous avulsions or there can be calcifications within the ligament and chronic ligament injuries. So this is one review area. Second is look carefully at the medial femoral condyle to look if there is any osteochondral defect, which can happen in osteochondritis dissecans. Third, this is a very tricky one, and don't over-report this, but look in this region for any radiolucent line or any sclerosis, which could be indicative of a medial tibial stress fracture. Then we come to the lateral femorotibial compartment. Have a quick look at the lateral tibial plateau. Usually, lateral tibial plateau fractures are obvious, but sometimes they are subtle. They're just very subtle radiolucent lines. And if you don't carefully look at this region, you will miss the particular fracture. Look at this portion of anterolateral tibia where avulsion fractures are common. Look at the fibula styloid or the head of the fibula, again for avulsion fractures. Then look at the central part, which is the intercondylar eminence. So carefully look at this region again for avulsion fractures. And lastly, before you say that the AP view is normal, please generally look at all the soft tissue, see if there is any small osseous fragment that is displaced somewhere, and which will be indicative of some patellar instability or a OCD, which has resulted into a displaced osteochondral fragment, or there can be some osseous or chondral bodies secondary to arthritis. Then you move on to your lateral radiograph. Again, you have a pattern to look at the review areas. So first is the femorotibial compartment. And the area that I want you to particularly concentrate on is this particular zone. So this part of anterolateral femur. Now, on an MRI, this is nothing but the sulcus terminalis. So what is sulcus terminalis? It is that part of the anterolateral femur, which is just anterior to the anterior horn of lateral meniscus. So assuming that this is my lateral meniscus, just anterior to the anterior horn, this zone is called as sulcus terminalis. And particularly look at this area for injuries or impaction fractures or depression. Next is look at the central intercondylar eminence. So anteriorly, you look for anterior intercondylar eminence fractures, which will be due to ACL avulsion. Posteriorly, it will be due to PCL or posterior cruciate ligament avulsions. Next, look at the patellofemoral compartment. So particularly look at this area where the quadriceps comes and attaches to the superior pole of patella for quadriceps avulsions. You can also appreciate the tendon on this X-ray. Similarly, inferiorly, this is your patellar tendon and it goes and attaches to the inferior pole of patella, and there can be avulsions of the patella at this level. And lastly, look at the tibial tuberosity region, particularly in young adults and in children. to rule out any Osgood-Schlatter disease. Again, look for any displaced osseous fragments. Please remember, these osseous fragments can be very thin and very small, so you need to really have a good eye to pick them up. And obviously, you look at the suprapatellar region for an effusion. So once you have looked at all the review areas, that's when you can say, yes, now my X-ray is surely normal, and you can go to the next X-ray for reporting. So look at the obvious findings, any obvious fracture, any obvious arthritis, then nothing is there. Look at the review areas and then report your X-ray as normal. Now, before we go on to looking at the X-rays, these are just some descriptors of how to describe a fracture. So whenever there is a fracture, you need to mention the line of the fracture, whether it is a transverse, oblique, or vertical, whether it's a fragmented or a comminuted fracture, whether it is a displaced or a non-displaced fracture. And in case if it's a displaced fracture, you need to give some idea to the orthopod of how much is the displacement. So ideally, just try to describe the fracture in a way that if someone reads your report, the opposite person can actually build an image in his mind of what the fracture is looking like. So in terms of displacement, just assume that if this is my bone, a long shaft, okay, this is the fracture, and this is the other fracture end. So what you can say is that this fracture is displaced, assume this is lateral. So this fracture is displaced, the distal fragment is displaced laterally by half shaft width. So that is what I mean in describing the fracture in terms of shaft width. So this is nothing but half shaft width. Similarly, if this is my another bone, sorry for the crude drawing. Okay, this is my fracture and this is my other bone, other fracture end. And again, assuming that this is lateral, so just say that the distal fracture fragment is displaced laterally by one shaft width. So this gives a very good idea to the orthopod whether the fracture needs fixation and how much he actually has to translate the bone back to fix it back in place. Second thing is you need to really, that is important, is to mention whether it is reaching up to the articular surface. And whenever a fracture is reaching up to the articular surface, you need to mention if there is any articular surface step off or gap. Now, what do I mean by that? So just assume this is my lateral tibial plateau. There is a depressed fracture fragment. And again, this is like this. So this is how my lateral tibial plateau is. And this is a depressed fracture. So this is your step off. Okay, so there is an articular step now you can see. But it's like this, right? But there is no gap. So the bones, there is no gap between the bones, but there is a step. So this is called as the step off. On the other hand, if you have a fracture, something like this, okay, and this, there is a gap in between. So this entire thing is a gap. So this is what is the articular surface gap, and this is what is the articular surface step off. And lastly, you need to explain is the apex angulation at the fracture site. Now, angulation is whenever this particular fracture is not angulated. But when you have a fracture like this, okay, so this particular fracture is not only displaced, but also angulated. And when you draw angles along the shaft, this is the angle, which is the angle of angulation for this particular fracture at the fracture site. So always describe, you don't have to give the exact angle on a radiograph, but what you need to mention is on which side is the angulation. So how do you do that? Just say the apex. So the apex of the fracture, just assume that this is again lateral. So you can say that the apex of the fracture is angulated laterally. So this is how, when you put all these things in your report, the orthopod gets a clear-cut idea of how the fracture is, even without seeing a radiograph, right? And just remember to mention the displacement, the articular surface extension, the articular surface step off or gap. All these three are really important in further management of the patient. So please make sure you don't miss on any of these points. And the last thing I want to concentrate or tell you is one view is no view. Okay, so as you can see here, there is a lion who is holding a, who is actually, it looks like she's eating a cub. But when you see the other view, you realize that she is just holding a cub and walking. So just remember, if you see only one view, you may find that the fracture is not displaced. And when you see the other view, you realize that the fracture is completely displaced. So please don't look at only one view. Make sure to look at least 2 views. Okay. So now what we are going to do is, I want all of you, so that it's a kind of an interactive session. I'll be giving you about 10 seconds. I can't give you more because we're running short on time, but I'll be giving you about 10 seconds. There'll be a particular format on which you'll have to look at the radiograph and give me the answer, right? So you don't have to type the answers. Please don't bother about it. Just be true to yourself, and once just keep in your mind what you think is the diagnosis, and then I'll show you the diagnosis. So this is a trial run. So here you can see this is the AP and lateral radiograph of the knee, and this is the particular format you're going to look at. So medial femorotibial compartment looks normal. Lateral, you can see that there is some osseous fragment, so there is a fracture. The fracture is extending up to the articular surface. There is some articular surface depression. Okay, patellofemoral compartment looks normal. Central, I don't see any avulsion fractures of the intercondylar eminence. Displaced, yes, this does look out of place. So there is some mild displacement of the fracture fragment. Effusion, yes, there is a small effusion that is present. So this is the particular format. When you look at every X-ray in this format, you will not miss on any of the findings. And this particular format is predominantly, for now, we are going to only report fractures and injuries. Arthritis we'll be discussing later. So just concentrate on fractures and injuries. If you see joint space narrowing, for now, just ignore it. Okay. So this was a very obvious finding. This was a lateral femoral condyle fracture and also called as the Hoffa's fracture. Okay. So I give you 10 seconds. Just have a look at it. Make up a diagnosis in your mind. Okay. Medial compartment looks normal. Lateral, yes, you see a fracture. You see that there is a line over here, and this is a lateral tibial plateau fracture. Now, this lateral tibial plateau fracture has a gap also. It is reaching up to the articular surface. This is my articular surface gap. Also, if you see, this is how your tibial plateau should have been. So there is some articular surface depression or step off as well. You cannot see a patellofemoral compartment on the AP view, so that's not applicable. Central, normal. Displaced, no, but depressed, yes. So it is a depressed lateral tibial plateau fracture with an articular surface gap. Effusion, you cannot comment on the AP view. So again, this was an obvious finding. This was a lateral tibial plateau fracture, which is also called as a Schatzker fracture. This is another example of a very obvious Schatzker fracture, and which is in fact Schatzker type 5, where even there is a dissociation between the tibial metaphysis and the tibial diaphysis. Whereas here, if you'll see, this is a very subtle Schatzker fracture. So if you are just, if you look at this X-ray hurriedly, I bet on it that you will miss the fracture. But when you have a particular format of how to look at the X-ray, you will pick up that this is the fracture. It is not so well seen on the lateral radiograph, but on the AP radiograph, you can appreciate that there is a lateral tibial plateau fracture, not much of an articular surface step off or gap. Next case, you have 10 seconds. Okay. So again, grossly, I don't see anything, no big fractures, no joint space narrowing, nothing. Medially, this side, really nothing. Laterally, you can see this small osseous flake over here. This could be a fracture, or this can be a calcification in the left knee joint, okay, which is where the medial collateral ligament goes and attaches. So I told you this is one of the review areas. Again, lateral normal, patellofemoral normal. Sorry, this is by mistake. Central is normal. Displaced, no, this fragment is not displaced. Effusion, you cannot comment on an AP view. So this is your medial collateral ligament. And here you will see that this fracture fragment is in place of the medial collateral ligament. So this is not so obvious finding. You'll have to actually look for it. And this is a Pellegrini striatal lesion. Pellegrini striatal lesion is nothing. It can be a avulsion fracture from the medial femoral condyle, or in chronic MCL injuries, calcification can develop towards the femoral attachment, and it can give this appearance. Next is again an AP and a lateral radiograph, 10 seconds. Get the diagnosis in your mind, follow the format. Okay, medial looks okay. Lateral, looks okay. Patellofemoral, I don't see anything. Now, next is central, and you can see that there is a fracture over here. Okay. Now you can see that now if you closely see, because you've seen the fracture over here, lateral, if you've not seen this lateral, you may actually miss this fracture because of the overlap. But you'll see this is your fracture fragment, right? And this fracture fragment has surely displaced superiorly. So there is some mild displacement, mild superior displacement of the fracture fragment. Effusion, yes, you have a small effusion over here. So this, if you'll see, fracture fragment is along the tibial attachment of anterior cruciate ligament. So that is the femoral attachment. This is your tibial attachment, and this tibial attachment fibers has avulsed off a bone piece in this patient. And so if you correlate with the MR, that's your ACL, and that is the avulsed bone piece. Similarly, here is the avulsed bone piece, and you can see that there is a lot of marrow edema. So this is not an obvious finding. You'll have to actually look for it. And this is an anterior tibial intercondylar eminence fracture, which is nothing but an anterior tibial avulsion fracture. Again, in this patient, you cannot see anything on the AP view, but when you see on the lateral view, you can clearly appreciate that this is your fracture fragment, and it is slightly shifted superiorly. So this is another patient with an ACL avulsion fracture. Okay, again, the same format, 10 seconds. All right. So same thing, medial normal, lateral normal, patellofemoral normal. What is important is central. Now, again, here you don't see anything, but in this particular case, you can see that there is a fracture over here. It's a very subtle fracture. It's not displaced. So unless you actually look at this region, you're going to miss this fracture. Displaced? No, there is no displacement of the osseous fragment. And yes, there is an effusion over here. So please make sure that you follow this format so that you don't miss any of the fractures. Now, this particular osseous fragment is along the attachment of the posterior cruciate ligament fibers. So this is your femoral attachment, and this is how the PCL comes and attaches to the tibia posteriorly. And this is where it has avulsed off a bone from the tibial plateau or the intercondylar eminence. And this is the MRI image of the patient, where you can see that the PCL is good, but it has avulsed off a bone from the underlying tibia. So this is a PCL tibial attachment avulsion fracture. Another thing, just a lateral view. Again, if I would just see this X-ray in a hurry without using my review areas, I'm going to miss the fracture. But if I start looking at the review areas, this is your fracture. So there is actually a lot of overlap from other bones. So unless you look for it, you're going to miss it. The key important thing to mention in this report is that there is a superior displacement of the osseous fragment. Also on the MR, you can see that this osseous fragment is displaced superiorly by almost 9 millimeters. And why this is important? Be it a ACL or a PCL avulsion fractures, if the displacement is more than 5 millimeters, they usually go and fix back the bone piece. And that needs to be done immediately or on an urgent basis. You cannot do it after months later, because if the bone piece is not fixed back immediately, the bone will undergo osseous remodeling. And once it undergoes osseous remodeling, this bone will not fix back into the defect in the bone. So this is like a jigsaw puzzle, and it won't fix back in the jigsaw puzzle. So therefore, it is very important that you pick up these avulsion fractures. And if they are superiorly displaced, you need to mention that so that the orthopod knows what he needs to do next for the patient. Another case, 10 seconds. Okay, for all of you who has picked up this fracture, pat yourself, pat your back, because you've really done a very good job, because this is actually a very subtle finding. So grossly, I don't see anything. Medial compartment looks okay. Lateral compartment, actually here there's nothing, but if you closely observe, there is a small osseous flake which is there in this region. Okay, so there is a small fracture from the anterolateral tibial plateau, which I have already told you is a review area. So this, and in fact, on a lateral view, you will never see this fracture because of the overlap. Rest everything is normal, except that yes, it is mildly displaced. Effusion, you have an effusion over here. So this is actually along the attachment of the anterolateral ligament, and this is your anterolateral. It's a very thin ligament. So this is a normal MR image of the ligament. If you'll see, this is your anterolateral ligament. Okay, this is where it goes and attaches to the tibia, and this is its femoral attachment. So it's a very thin, slender ligament, and often with ACL injuries, anterolateral ligament can avulse off a bone from the anterolateral tibial plateau, and this is nothing but a Segon's fracture. Here you can see that this ligament also doesn't look that healthy, it's injured, and you can see that it has avulsed off a bone from here. Now, why is this important? Segon's fracture is one of those 100% signs. So if a Segon fracture is present, there are 100% chances that patient has a ACL tear. So on a radiograph, if you pick up a Segon fracture, then it's actually a eureka moment for you, because now you can actually call your orthopod and say that, boss, there is a Segon fracture. There are chances that he has a ACL injury, underlying ACL injury, and your orthopod will be completely impressed with you. He will say, yes, my Lachman test is also positive. I'll send the patient for an MRI to confirm if there is any other findings in the scan. So this is how your report will start to make a difference, and you will start to gain recognition. Another thing which is important is, if you get an MRI to report, often these fractures are so small, okay, that always remember, whenever there is a ACL injury on an MRI, look at the anterolateral tibial plateau to pick up a fracture. But often, again, in a hurry, you may forget to see this review area on the MRI. And during that time, the X-ray will be your savior. So even if you miss the Segon's fracture on the MRI, because it's very small, if you look at the X-ray, you will get your answer that yes, he has a Segon fracture. Now, why it is important? ACL injury is there. We know that from the MRI now. So why do we need to know if that there is a Segon fracture? Because if there is a Segon fracture, it needs to be repaired. Otherwise, the graft of the ACL can fail. So if the Segon fracture is not addressed to, the patient can land up into an ACL graft failure, and the patient will require a resurgery. And when that happens, remember that you are going to go down in the eyes of the orthopods. Second important thing is, whether you have seen the X-ray or not, 95% of the times your orthopod is going to see the X-ray and he is going to pick up this fracture. So please don't miss this fracture, be it on an X-ray, and please don't miss this fracture even if you are reporting an MRI. So even if you're reporting an MRI, make sure to look at the X-ray to find such subtle fractures. So this is another patient where you can see that there is a Segon's fracture. This is another patient. So this Segon's fracture is displaced, whereas this is an essentially non-displaced Segon's fracture. So again, it's a subtle finding, but if you report it on an X-ray, it's an indirect indicator of ACL injury. Okay, another X-ray, 10 seconds, go. Okay, this is also a very subtle finding, just like a Segon's fracture. And on the lateral compartment, the femorotibial is okay, but here you can see that there is a small osseous bone which has been chipped off from the fibular styloid or the fibular head. Okay, and the rest, everything is normal. It's essentially non-displaced, and obviously you cannot comment on the effusion on an APP. So what is this fracture? Now here, something called as the posterolateral corner goes and attaches to the fibular head, which is comprising of multiple structures, the important ones being popliteal fibular ligament, arcuate ligament, and your biceps femoris tendon and lateral collateral ligament. So whenever there is an ACL injury, it is often associated with posterolateral corner injury. And so whenever you see this fracture, again, it is an indirect indicator of a cruciate ligament injury. Posterolateral corner injury can happen with both ACL and PCL injuries. So, but if there is this fracture, you know that patient has some cruciate ligament is injured, either of the two. And why it is important, again, when the patient has an ACL tear, the patient goes for ACL graft reconstruction. If this thing is not identified, okay, on the X-ray and on the MR. Now, MRI, if you see, this is the MRI of the patient and the fracture is so small. you will surely miss this fracture on an MRI. I myself didn't pick up the fracture on the MRI, but before dispatching the report, I did see the X-ray, I saw this fracture and I reported on an MRI. So if you miss this fracture, again, if this situation is not addressed in the patient will result into ACL graft failure and a second surgery will be needed. So it is very important to pick up posterolateral corner injuries, just like it is important to pick up second fractures. So it's an arcuate fracture or a posterolateral corner fracture. And again, it is an indirect indicator of cruciate ligament injury. Next is, I have given you a history that the patient has a history of twisting injury. And this is a very subtle finding. Only those who are aware of such a finding will be able to guess this. Okay, so I have given you two knees for comparison. Now, medially, just remember on a lateral radiograph, the bone that is posterior and inferior is the medial condyle. Okay, the bone which is superior is your lateral condyle. So medially, there is nothing much, but laterally, I've already told you this particular area is your sulcus terminalis. Okay, and here you can see that there is a depression in the sulcus terminalis. Okay, so this depression is nothing but it is again an indirect indicator of anterior cruciate ligament injury. Rest, everything is normal. Okay, now why is the sulcus terminalis, or why does this happen in the first place? So whenever there is a twisting injury, the tibia, and there is a resultant ACL tear, the tibia will translate anteriorly. The posterolateral tibia impacts against the anterolateral femur in the region of the sulcus terminalis. And that, as a result of which you get this depression. So here on the MRI also, you can appreciate that there is a depression and there is a lot of marrow edema in this region. So on the MRI, it doesn't matter because you can see the ACL, whether there is sulcus terminalis depression or not, it has no prognostic value. But if you get an X-ray for reporting and you see this finding, again, you can put in the report that there is sulcus terminalis depression and clinical correlation for anterior cruciate ligament insufficiency is requested. So at least the orthopod knows that this patient could be having an anterior ligament laxity. Sulcus terminalis depression can be in acute injury or it can be in a chronic injury. So you don't know whether the ACL injury is acute or chronic. If you have a clinical history, that's great. If you don't, then you don't know whether it's an acute or chronic. But you surely know that some point in time, this patient did have an ACL injury. So that's how you can correlate your X-ray findings to report soft tissue injuries, which are not seen on the X-rays. So again, it's a subtle finding and it's an indirect indicator of ACL injury. Okay, this is a very subtle finding, sudden onset of medial pain, no trauma. Okay, a word of caution before we go ahead, don't over-report these X-rays, okay? Unless you have a classical history and the finding is really obvious, then you put it on paper. Otherwise, do not over-report this X-ray. So medial femorotibial compartment, what this patient has is this line of sclerosis. Again, I told you that this is your review area. And you can see this line of sclerosis over here. It's very subtle. If you are not confident, it's okay. You may not report it. If you're confident about it, you have a history that the patient has pain in the medial tibial condyle region, you can raise a suspicion. Okay. The rest, everything is normal. And what this is a proximal medial tibial stress fracture. And this was the MRI of the patient, where you can see that this was the hypointense signal with a lot of marrow edema. So if you're not confident, you can actually not put it in the report. You can just call up the orthopod and tell him that this is what I feel. It may or may not be, but an MRI would be a good option to confirm if the patient is having a stress fracture or not. Next case, 10 seconds. This is a very important case with two findings. I've given you a hint, there are two findings. And arthritis is not one of the findings. Okay. So medially, you can see that there is a irregularity, right? And there is a medial femoral cortical irregularity. Lateral looks normal, patellofemoral looks normal, central looks normal. So what is the second finding? So now the second finding is this. You can see this small osseous bone, this osseous chip. So this could be a displaced osseous fragment. Okay, there is some amount of effusion. So medial femoral cortical irregularity with a displaced osseous fragment. This is a case of osteochondritis dissecans with a displaced osteochondral fragment in the suprapatellar region. Okay, so this was what it was. So please just remember that you can have very subtle slender osseous fragments and don't miss them on the x-rays. And this was the MR of the patient, where you can see that there was this irregularity. There is small amount of osteochondral fragment which is seen in this region, but if you see, this particular osseous fragment is missing. So there is a small fragment in situ, but the other fragment is missing. And when you look at the MR, here you can see that here you can see this is your osseous fragment, which is correlating with this particular X-ray. So this was the osteochondral fragment which was displaced in the suprapatellar region, which could have been easily picked up on the X-ray as well. So these are some more examples of osteochondritis dissecans. Sometimes it can be where you can see the osteochondral fragment, which looks pretty much stable, but again, you cannot be 100% sure if it is stable or not. That is more of an MRI thing. Here you can be 100% sure that this is an unstable fragment because you can see that there is a fracture and it is actually detached off from the parent bone. Again, here you can see that there is a gap, a bigger radiolucent gap. So this was also an unstable osteochondritis dissecans. None of these to the extent that you can visualize have a displaced osseous fragment. Next case, very obvious finding. Sorry, I don't have the AP view of this patient. Okay, so medial normal, lateral normal, patella, there is a fracture. This was a very obvious thing. The important thing is the fracture was not displaced. This is something that you really need to mention. Effusion, yes, there is effusion present. So it's an obvious finding, patella fracture. You need to differentiate it from the normal variant bipartite patella. So here also, if you will see, there is a radiolucent line. This is a skyline view, and you can see radiolucent line, and it looks like a fracture. Then what is bipartite patella? Now, bipartite patella usually happens at the superolateral corner. So this is your fibula. So that's the superolateral corner. That's the one thing. Second thing, the radiolucent line is very wide. So if you go back and see, this fracture line is very ragged and a thin radiolucent line. Okay. Whereas this is a smooth radiolucent line and it is pretty wide. So that is a second way of how to differentiate a bipartite patella from a patella fracture. Third thing is the osseous fragment is very round. So it will have smooth edges. It will not have ragged edges. So that's how you differentiate between the normal variant and the actual patella fracture. And this was the MR in the patient, where you can see that this is a very round bone at the superolateral aspect of patella. This was bipartite patella. Okay, so next case, all of you, 10 seconds. This is also not a very obvious finding. Okay, first thing, what you can see is that this is the immature skeleton, right? So you can see the physes and they're very well seen. So let's take the compartment approach. The medial is normal, lateral is normal. Patellofemoral, you can see this slender fracture over here, right? So there is a small fracture at the inferior pole of patella. Rest everything is normal. There is no displaced osseous fragment. This fragment is also not displaced. Okay, and you don't see much of an effusion, at least on this radiograph. So it's a patellar sleeve avulsion fracture. Now, what is a patellar sleeve avulsion fracture? It is first of all, you need to understand that in an immature skeleton or in children who have a growing skeleton, the bones are relatively weaker than the ligaments and the tendons. Okay, so in them, the ligaments and tendons are stronger. The bones are still in the phase of ossification, so they are not as strong. As a result, you get avulsion fractures more commonly in children as compared to the adults. So all of these ACL avulsion, PCL avulsion, they can happen in adults, but they are very much common in children. Similarly, this periosteal sleeve avulsion usually happens in children where it is nothing but it is a avulsion of the periosteum, and along with that it avulses of the articular cartilage from the inferior pole of patella at the patellar tendon attachment. Similar thing can also happen superiorly at the quadriceps tendon attachment. So this is nothing but a patellar sleeve avulsion fracture. And what is important is sometimes it is only the cartilage that has been avulsed off. The osseous fragment is not avulsed off. And in such cases, you will not be able to pick up this particular injury on a radiograph. And that's when ultrasound will be really helpful to identify the chondral fragment. Secondly, like this, usually these fractures are displaced and they require internal open reduction and internal fixation. You need to fix this back. Okay. But in fractures like this, which is not displaced, the patient can actually undergo a dynamic ultrasound where you can just see whether this fracture fragment is moving or not with flexion and extension. So if the fracture fragment is moving, the orthopod may consider a surgical intervention. If the fracture fragment is not moving, he may think to conserve the patient. Again, it's not a hard and fast rule, but it's just that it gives further information to the orthopod to take a decision. Next, again, this is a very subtle finding, but with a very big diagnosis. Okay, so grossly don't see anything. Medial is normal, lateral is normal, central is normal. Patellofemoral, what you see is that the bones are okay, but there is another extra bone lying over here, right? So you can see this osseous piece which is sitting over here. Rest everything okay. Obviously, this is a displaced osseous fragment. You do not have any extra piece of bone lying in the Hoffa's fat pad region. So it's a displaced osseous fragment and there is an effusion associated with it. A young patient, displaced osseous fragment, you can think of two things. One is osteochondritis dissecans. So when you see this fragment, go back, you see that the medial femur is actually looking very good. The second thing could be a patellar instability. Again, with this X-ray, you cannot be 100% sure whether it is OCD or it's a patellar instability, but likely chances that it's patellar instability because the medial femur looks very good. Okay, so you can just call up the orthopod and say that I am seeing a patellar, I'm seeing an osseous fragment displaced in the joint. Are you suspecting any patellar instability in the patient? And the orthopod will give you the answer that yes, this patient had a recent patellar dislocation, or on clinical examination, I feel that there is a patellar instability. If you cannot reach out to the orthopod, call up the patient, ask for the history. The patient may give you a history that I had a trauma and I just felt that my kneecap dislocated and came back. So all of this will help you to come to a diagnosis. Okay, so once you get this history of patellar dislocation, you have your answer that this was nothing but a patellar dislocation with a displaced osteochondral fragment. So this was the MRI picture where this was your osteochondral fragment. Okay, you can see this is your osteochondral fragment. The patient had a large lithoheme arthrosis as well. And on the eggshell image, if you see from the patella, the osteochondral fragment is missing. And this was your osteochondral fragment lying in the joint recess. So this is how you can just add up 1 + 1 and come to a relevant diagnosis even on an X-ray. You do not always need, obviously the patient will require an MR imaging, but you are directing the orthopod in the right direction by suggesting him that this could be the diagnosis. Okay, next is where you can see that, okay, first just 10 seconds and have a look at the X-ray. It's an obvious finding if you know the pathology. Okay, so the finding is pretty obvious. You can see that there is an irregularity of the tibial tuberosity. And if you see that even the soft tissue meaning the soft tissue appearance of the patella, so this looks thickened. The patellar tendon looks thickened, right? So we just follow the protocol and we find that the patellofemoral compartment, there is an abnormality. There is no displaced osseous fragment. There is not much of an effusion as well. So this is nothing but a Osgood-Schlatter disease. If you know this, you will not miss it. Okay, this was the MRI appearance of the Osgood-Schlatter disease, where you can see that the patella also has signal within it. There is an additional ossification or a calcification adjacent to the tibial tuberosity. The tibial tuberosity is very much irregular. and there is edema within it. So all of this just adds together to Osgood-Schlatter disease. So we've discussed of all the different kinds of pathologies that you may get on a X-ray radiograph as far as fracture and internal derangement is concerned. And we come back to the same X-ray, okay? And now I want all of you to please answer the question again. Now, what do you think are the soft tissue structures which are injured? Okay, I need more answers. Come on. Okay, a hint. There are two soft tissue structures which are injured. And most of you are getting one right. The other one. Okay, quadriceps is not injured. You cannot see, there is no osseous avulsion at the superior pole of patella. So obviously, I cannot say if the quadriceps is injured, like if the tendon itself is injured. There is surely no osseous avulsion. You cannot see medial meniscus. Okay, so most of you are getting one thing right, and that is the ACL. Now, I suppose you are telling me ACL injury because you can see the sulcus terminalis depression, which is very, oh, great. Okay, I don't know the name, Mr. Mohan and someone MIA2. Congratulations, you've got the answer right. So yes, ACL everybody has picked up, which is probably secondary to sulcus terminalis depression. But the other thing was this. This is your small Segon's fracture. So even if I would not have given a lateral radiograph, still with this particular finding, you can say that the patient has an ACL injury or had an ACL injury in the past, right? So at least I hope you guys now have a format in your mind how to go through these injuries before and how to report them. So this was the answer. Okay, now just a quick short run about arthritis. I'll be just discussing some salient points because arthritis in itself is a huge topic. So just how to approach an X-ray when you get an X-ray of arthritis, a knee X-ray of arthritis particularly. So the radiograph that you take in a knee arthritis is AP view. Obviously, that's the most common view. Standing or supine. Standing or a weight bearing has more importance in arthritis because you can actually judge the joint space narrowing when the patient is standing. Lateral view, skyline view is not always taken, but if you want to see the patellofemoral compartment, that's when you can see. Rosenberg view. Now, this is a weight bearing or a standing radiograph, which is done with 40-degree flexion of the knee. And this is particularly important to diagnose early OA because you can see the joint space very nicely. So even mild narrowing in the joint space can be really picked up well on a Rosenberg view. And the last thing is a scanogram, which we'll be discussing about a bit later. Okay. Sorry. So what is the importance of an obliquity of the X-ray? Now, normally, whenever you take an AP view, the central beam is actually placed about 1.5 centimeter below the apex of the patella. So just assume this is the apex of the patella and about approximately 1.5 centimeter below is where you put your central beam. Now, if obviously you don't get the ideal X-rays every time, and this is what happens when you don't get an ideal X-ray. So this is a patient. Both the patients are normal, but here you'll see that here the medial femorotibial space is very well visualized. The lateral is also very well visualized. In this patient, the lateral femorotibial space is good, but the medial femorotibial space is narrow. So this is how it is. So this is a nice big space, and this is where you'll see that someone may just reported that it's a moderate medial femorotibial joint space narrowing, right? Now, why this is happening? So if you see here that the medial tibial plateau is in profile, whereas here I can actually appreciate the entire medial tibial plateau like this. So because of the obliquity of the medial tibial plateau, you have a false appearance of the narrowed joint space. So whenever you see such radiographs with the obliquity, be sure before you report them as osteoarthrosis or a reduced joint space, because often it won't be. So you can just take a clue. This is a very crude way, but this is your medial femur, and this is which is your anterior margin of the medial femur, and this is the anterior margin of the medial tibia. And this distance is actually maintained. So when you get such oblique X-rays, make sure that you have a look at them properly before you report a joint space narrow. Okay. What are the X-ray findings of osteoarthrosis? And you can remember them by the term loss. So L stands for reduced joint space. Here you can see there is no obliquity and actually the joint space is very chinked. O is for osteophytes. So just remember, osteophytes does not mean that that particular compartment has cartilage loss. The two don't go hand in hand. Here, this patient has medial femorotibial osteophytes, but this patient also has lateral femorotibial osteophytes. That does not mean that the patient has lateral femorotibial compartment cartilage loss. Subchondral sclerosis and subchondral cyst. Now, of these, loss of joint space is an indicator of some form of cartilage loss, and subchondral cyst is also an indicator of some form of cartilage loss because they usually develop after a cartilage wear has happened. So, osteophytes does not indicate cartilage loss in that particular compartment, whereas subchondral cyst and loss of joint space do indicate cartilage loss in that compartment. Now, whenever you get an X-ray, the first thing that should come to your mind is this a typical degenerative osteoarthrosis, or is this an atypical osteoarthrosis which is developed because of some other reason? Now, it could be an early onset osteoarthrosis or anything of that sort. So what are the things that should run in your mind whenever you see an X-ray? Is this a common age for OA? So if I see a patient having OA in 60 plus, yes, this is a common age for OA. If I see an X-ray of a 30-year-old with OA, no, that's not a common age for OA. So your antenna should go up that why there is OA. Second, is this a common joint for OA? Now, normally your hip and knee joints are your weight-bearing joints and they are commonly associated with OA. But if you get OA in a shoulder and an elbow joint, that's not common. They are not weight-bearing. So it is secondary to probably a rotator cuff tear in the shoulder or a posterolateral instability in the elbow. Again, for the knee, is this a common compartment to get OA? Now, normally because our knee is slightly, the way a mechanical axis runs, a medial femorotibial compartment takes more load as compared to the lateral. And as a result, medial femorotibial compartment OAs happen in a primary degenerative OA. But if you get a primarily lateral compartment OA, then you need to think of some cause for it. And there are other features which go against a primary OA, like there are erosions, or if there is symmetrical tricompartmental joint space narrowing and no osteophytes, no subchondral cyst, then that is when you need to think of some other pathology. And other additional features which will be indicative of an early onset or a secondary OA, like signs of ligamentous insufficiency. So by now you know the signs of ligamentous insufficiency. If you see a sulcus terminalis depression, if you see a Segon's fracture, and you see lateral compartment OA, you know that it is ACL insufficiency that is causing the lateral compartment OA. If you see healed lateral tibial plateau fractures, then obviously the articular surface is uneven and such a patient will go into lateral compartment OA. So just whenever you get an X-ray, run these 5 points in your mind and you will come to a conclusion whether it's a primary degenerative OA or whether it is an atypical OA. So here, 65-year-old female, knee pain on the medial aspect, looks like a primary OA to me. You have osteophytes, you have everything, and the age matches, the compartment matches, the joint matches. In this particular case, a 35-year-old male with knee pain and swelling. Now, if you see, first of all, 35 is a young age to develop OA. Second thing, this patient has a uniform joint space or a symmetric joint space narrowing involving medial and lateral femorotibial compartments. Third thing to note is there is a lot of soft tissue density. So here you'll see there is a lot of soft tissue density. There is a large effusion. Okay, so there is a large density here as well. So this patient is probably having something else than just a primary OA. It's a secondary OA, which could be secondary to some inflammatory or infective pathology. This was the MR of the patient, where you can see that medial compartment cartilage loss was there and the lateral compartment cartilage is intact. So again, what I told you before, presence of osteophytes does not mean that there is a cartilage loss in that particular compartment. This patient had lateral femorotibial osteophytes, but the lateral cartilage was good. So those two don't correlate. And here in this patient, you can see that there is diffuse narrowing. Okay, there is really no significant meniscus that's left, and there is a lot of synovial thickening. So this patient was actually an advanced inflammatory arthropathy with advanced secondary osteoarthrosis. Okay, 40-year-old female with knee pain laterally. So you can see that there is a lateral compartment OA, but the medial compartment is good. So this is obviously obliquity. Okay, here you can see that if I'll say this is my tibial plateau, But if I'll see the anterior margin of the tibia and the anterior margin of femur, the space is very good, right? So this is a predominantly lateral compartment OA. Now, as I told you, lateral compartment OAs are not common because normally the weight bearing is the medial compartment. So when you get such x-rays, call up the patient and get some more information, get more history, because normally you don't get histories for x-rays and you just tend to report and send them off. And as Shijika ma'am said, you have to be a clinical radiologist. So call up these patients and get a good history. And what the patient gave the history was, there was a history of partial lateral meniscectomy. Okay, so what happens is, whenever there is a partial lateral meniscectomy, menisci act as shock absorbers for the cartilage. Once you remove the meniscus, there is increased chances of cartilage wear. And therefore, this patient, though she was young, she was only 40, she landed up into lateral compartment OA. So here you can see this was the MR of the patient. You can see that there is cartilage loss here, there is cartilage loss here. The medial compartment cartilage is good. You cannot see any lateral meniscus. You cannot see any lateral meniscus here also, and there is a cartilage loss. So secondary to partial lateral meniscectomy, the patient had landed up into an early lateral compartment OA. So what are the causes of isolated lateral compartment OA? ACL deficiency, lateral meniscectomy, prior trauma, that is Schatzkopf fracture or lateral tibial plateau fracture, which may cause irregularity of the articular surface and hence resultant OA. What are the causes of OA in a young patient? Post-infective, post-inflammatory, post-traumatic. Post-traumatic can again be any of these three, right? So whenever you get something out of the normal, just run those 5 points in your mind of age, joint, compartment, any other features that you're seeing which is against a primary OA, any feature suggestive of a prior trauma. So just whenever you get something which doesn't fit into these 5, your antenna should go up and you should start looking for the cause of OA. Now, what are the role of X-rays in the management of OAs? We've discussed about the diagnosis. Now, what about management? So, joint space narrowing, particularly when it is in terms of management, you want a weight-bearing X-ray, and weight-bearing MRI is not possible. So, obviously, the information you get from a weight-bearing X-ray. So, you can obviously subjectively classify the OA as mild, moderate, severe, depending upon the joint space narrowing. And second thing, the most important is to know the alignment of the knee, which is again not possible or an MRI because it is not a weight-bearing MRI. So you need weight-bearing scanograms for alignment of the knees. So this patient, again, this is a patient with very mild, see, there is no obliquity, but there is reduction in the joint space. There is a mild reduction in joint space. And if you see, there is tiny tibial intercondylar eminence osteophytes, tiny osteophyte here as well. So this was a patient with a mild or a early OA. This is a patient where there is moderate joint space narrowing, moderate osteophytes bilaterally, okay, meaning medial and lateral, and also added to that, you see subchondral sclerosis. And in this patient, besides all the findings, you also begin to see that there are subchondral cysts which have started to develop, right? So this was a very much advanced OA. Now coming to scanogram. Scanogram is mainly done to evaluate the alignment, whether a patient has a valgus or a varus malalignment or it's in neutral alignment. So varus is where the distal bone goes away from the midline. To be like in simple terms, it is nothing but bony. Okay, where you get a bowing of the knees. Valgus is where the distal bone comes away from the midline. And again, in simple terms, it is nothing but your knock knee. So knock knee is valgus, bow knee is your varus. This is how you take 3 X-rays and then you stitch them together to get this X-ray. Now, key thing to remember, and this is very, very, very important, your patella should be facing forwards whenever you take an X-ray. You need to tell this to your technician because if the patella is not facing forwards, you will not get the right values. A neutral alignment X-ray may appear like a malalignment and the patient will land up with a wrong surgery. Why wrong surgery? I'll let you know in the next few slides. So it is very important for the orthopod also that the patella are facing forwards. So this is a normal scanogram. Okay. Now, whenever you get a scanogram, what you need to understand is this is something called as the mechanical axis of the femur, or sorry, of the lower limb, going from the center of the femoral head up to the center of the medial malleolus of the tibia. Okay. So this is your mechanical axis, and normally the mechanical axis passes just lateral to the tibial spine. So that's why we have normally an individual has a slightly valgus knee. Okay, so it passes just lateral to the tibial spine, which is called as the Milkulich's point. In this other leg, if you'll see, the mechanical axis has shifted medial. So this patient, this knee, the right knee is going into varus. Again, some more examples. This is bow knees. You can classically appreciate the bowing, and this is nothing but varus malalignment. Whereas in this patient, you can see there is a valgus malalignment. So normally your line should have passed from here, just lateral to the tibial spine, but it is passing way too much lateral, and this is nothing but the valgus malalignment on a scanogram. There are some angles that you need to measure and put on the scanogram, but this is beyond today's session, so I'm not discussing them. You can read them up, so that's why I've just put it. You get it on the Google, what is an LDFA and MPTA angle and how to measure them. And now this is what you need to understand about the scanogram. So this is the management and why scanogram or X-rays is important. So here you can see that if the patient has a tri-compartmental OA, the patient will be going for a TKR. But what happens if the patient has only medial compartment OA on an X-ray? In such cases, patient goes for an MRI to assess the lateral and patellofemoral cartilage. If it is good, which means that patient has only unicompartment OA. Now, if the biological age, by biological age, obviously, I mean that if the patient is a runner, yet if the patient is 80 years old, but patient is a runner, then his biological age is less actually. So if the biological age is 55 to 60, then you do a scanogram. Okay, a less than 55, you do a scanogram to look for the alignment. If it's a neutral alignment and the ACL is intact, patient will go for a unicompartment replacement, which is nothing but the medial compartment replacement. But if the patient has a varus or a valgus malalignment, the patient will go for a HTO and DFO. So this is where we as radiologists play a role. This is where they get a scanogram done, and we need to inform the orthopods whether the patient has a malalignment or it's a neutral one. Whereas if the lateral or the patellofemoral compartment cartilage is bad, then the patient will land up into a TKR. So again, no more investigation. Such patients don't require a scanogram. But the gray zone is the biological age more than 60. Now, if the rest of the cartilage is good and the biological age is more than 60, some orthos prefer to do a unicompartment OA. Some orthos prefer to directly go for a total knee replacement. So it's a gray zone whether you want to do a unicompartment replacement or a total knee replacement for elderly patients with good lateral and patellofemoral cartilage. You don't have to remember this algorithm. The whole idea to show this algorithm was you need to start thinking when you're reporting an X-ray that what all stuff you need to put in the report. So whenever you get a scanogram, what all stuff you need to put in the report, whether there is a malalignment, which compartment is involved. Similarly, on a knee X-ray, MC medial compartment OA is there, great, but you need to see if there is a lateral compartment OA. You need to see if there is a patellofemoral OA, because that's when your management plan will change. So this is just to make you understand that what stuff needs to be put in the report. So take home points, have a format ready, have a format to read any radiograph. Look at the review areas before reporting a radiograph as normal. Avoid satisfaction of search. Most of you picked up sulcus terminalis depression and told me that there's an ACL injury and you just missed on the Segons fracture. So avoid satisfaction of search. In case of doubt, please call up the patient, call up the referring doctor and find out the clinical history. I'm telling you, your life will be very easy if you do that. Are the knee X-rays really useful? So by now, I hope you've understood that yes, knee X-rays are very useful in today's practice, even in today's practice when you have MRI. And that depends upon how well you understand these X-rays and how well you report them. And they surely have a role in the management of the patient. We've already seen the entire management plan. Don't miss the subtle fractures. Remember, more than 95% of the times, your orthopod is going to pick up that fracture. And if you miss, then your orthopod is not going to like it. And even while reporting an MRI, when in doubt of a small fracture, make sure you look at the X-ray before going for a CT. So most of us are doubtful whether there is a fracture or not. We just call up the technician, yaar ek CT cut le le, please. Don't do that. Just ask, is there an X-ray? Please get your hands on the X-ray. You will see that fracture on the X-ray. You do not have to radiate the patient further. Okay, so now time for some spotters. I want all of you to start writing your answers in the chat box. You have 20 seconds. Come on, fast, fast. What soft tissue structures were injured previously? Okay, hint, there are two soft tissue structures. Yes, okay, perfect. So now most of you are picking up both the soft tissue structures. I'm so happy. Yeah, so there is obviously an evidence of ACL reconstruction. So there was an ACL injury. And yes, if you see, here is your Pellegrini stiena lesion. So obviously there was an MCL injury as well in the past. Okay, next quarter, 20 seconds, quick. Just run you need your format, medial compartment, lateral compartment. Come on, start doing. Hint, the left knee is involved. So just start looking at the left knee. Come on, fast. Okay, nobody is getting the answer. Yes. Perfect, one person, come on. Congratulations, Prasad. No, that's not OA. Come on. I mean, it's obliquity. Yes, yes, yes. More people are answering. I'm so happy. Great. Yeah. So this is a subtle finding. This was a OCD, medial femoral condyle. You can see there is an osseous defect. I have not put the lateral view, and there was, believe me, there was no osseous fragment which I could identify on the X-rays, right? So it was a lateral femoral OCD. Next, what is the diagnosis? Again, this is a very subtle finding. If you go through your format, you'll find it. Very good, Radha. Proud of you. Mohan, MIA2, very good. Mohan and MIA2 are perfect in picking up this particular fracture. By now, I'm sure you're not going to miss this anyway. Okay, lateral tibial condyle fracture. Marisa, be specific. Okay, time's up. So this was a Secon's fracture, which means that this patient had or has a ACL injury, right? Okay, next, is this a primary or a secondary OA? Come on, this is very easy. Yeah. Okay. Okay, I'm proud. Nobody is telling it's a primary OA. Very good. Yeah. So first thing, you can see that there is physis. So obviously this is a child. Okay. Child having an OA primary is out of question. Secondly, you can see that there is a lot of irregularity, erosions, and blah, blah, blah. So this was nothing but a post-TB that child had landed up into OA. So it was a secondary OA. Next, this is again a very subtle finding. You need to run through your format to get this. Let's see who gets this first. Come on. Who gets this first right now? Yeah, avulsion fracture, yes. But what avulsion fracture? Okay, tibial spine is very broad. You have to be a bit specific. Anterior or posterior, utna to bata do. It's not Osgood-Schlatter. Okay, right. So it is an ACL avulsion fracture. You can see this is your ACL avulsion fracture. And this important thing is the fracture is displaced superiorly. You can see this superior displacement, which is very important to put in the report. Okay, because then the patient will be walked up ahead and he needs to fix the bone back. Sorry for the X-ray quality. This was the best I could get. Again, come on. What is the diagnosis? Very good, Mr. Sanjeev, Mr. Sanjay, everybody is answering perfectly. KK, Mohan, Arey, wow, I'm so proud of you. Yes, so this is a PCL avulsion fracture and this wasn't displaced. So I think everybody has got this answer right. Okay, what is the deformity? This is a very obvious thing. I'm just testing if somebody was sleeping in my lecture. Yes, yes, yes. This is not some rocket science. This is a valgus deformity. Very true. Okay, what is the diagnosis? Come on. No, it's not stress fracture. You don't get such big, horrid stress fractures. It's not stress fracture. No, it's not even a lateral femoral condyle fracture. It's not Hoffa's. Yes. Mohan is the first person to get it right. It's not Osgood-Schlatter. I don't see anything over here. Intraventricular medial condyle tibia. Okay, I think I'm confused. Yes, perfect, Shubham. So it is a intra-articular fracture. So this is nothing but a Schatzker fracture. Someone else also reported as a Schatzker fracture. And if you see, the fracture line is extending up to the medial condyle as well. And it is reaching here up to the articular surface. But there is no obvious articular surface step off or gap. It's not a post-osteotomy, Lakhan. It doesn't happen that way. Post-osteotomy, you'll see a radiolucent gap. So it's a Schatzker fracture. Last X-ray of the session, what is the diagnosis? The person who gets this right surely deserves a treat from me. It's that difficult. And you have 20 seconds. I won't be giving you more time. I'm sure nobody's going to report this X-ray. No, no, no. No, Mohan, no, Dr. Suchita, no, no, Prasad, it's not a fibula fracture. Everybody is going for a fibula fracture. I don't know where you guys are seeing the fracture also. Okay, yes, Shruti, you really deserve a treat from me. That's perfect. So this is a normal X-ray, guys. Please remember when you start to report in a routine day life, after out of 20 X-rays, or 18 X-rays are going to be normal. So just because you have a format, don't start looking for something. Okay, if it's normal, it's normal. Have confidence and give it normal. Okay, and please remember, you cannot get quadriceps rupture on a radiograph. Unless there is an osseous avulsion, you cannot diagnose quadriceps rupture. Many of you have been giving an answer as a quadriceps injury. Unless you see an avulsion at the superior pole of patella, I don't know if there is a quadriceps injury. It's as simple as that. I don't have MRI eyes in myself. Okay, so please don't report that. So this was a normal X-ray, and thank you so much.
Thank you very much, Chaitali. That was a fabulous display of radiographs.
Thank you.
Thoroughly enjoyed by everybody. We have time, maybe we are obviously running late, but we have time maybe for a couple of questions. You can, anybody wishes to put some questions can put it in the chat box, please. I think they're all catching their breath there. Okay. So before we'll hang on still, but I would like to welcome Dr. Ramesh Rajani. He's a senior general practitioner from Khar-Bandra area and very astute at reading X-rays as well, I must add. He is our MMC observer for today, and seeing the response with more than 300 people on at all time, he just said he would like to speak to us. So Dr. Rajani, the mic is yours. Please go ahead.
Good afternoon to everybody, organizers and all the delegates. It was a wonderful session since yesterday night and today morning. I have enjoyed, I learned a lot. At this age also I learned a lot. New things are coming in the field. Radiology, sonography, reading the X-rays. So I must congratulate the full team of organizing, Dr. Sanjeev Mani, and all the 300 people who are attending this session. And remember, next year in the month of March is again re-registration in MMC. 30 points you have to complete. Below 65, everybody above 65, you don't require points. Yaad kare, today you got all 4 points. Everybody has got 4 points. So remember, you have to collect the 30 points to register next year. And I'm so much happy and well-organized program. Congratulations to everybody. I always say that बचपन में खिलौनों को संभालो, बड़े हो जाओ तो किताबों को संभालो, उससे बड़े हो जाओ तो बीवी और बच्चों को संभालो, अगर जब बड़ी उम्र हो जाए तो हड्डियों को संभालो. हड्डियों को संभालना बहुत important to be mobile in the life, and you have covered up everything about the bones and bones and bones. Thank you very much. Much obliged. I am your MMC observer, Dr. Ramesh Rajani. Thank you, sir.
Thank you so much, sir. Thank you for being with us. Yes. We will move on, and I think we have Dr. Sanjay Jain who will come on next, and we are just searching for him on a panelist. So we just hang on for a minute while we get him online.
There is a question, sir. Should I answer?
Yeah, please go ahead. Yeah.
Okay. So I think someone has asked arcuate fracture. So arcuate fracture is nothing but it's a fracture of the tip of the fibular head, which is also called as fibula styloid.
Sorry. Okay. Yeah.
So,
I have deleted many.
Yeah. So that is what is an arcuate fracture, and why it is important is it is nothing but where your posterolateral corner ligaments attach. And whenever there is an outward fracture, it is an indirect indicator that there is a ACL or a PCL injury. And important is it needs to be picked up, because if your posterolateral corner is not repaired, or if the problem is not addressed, the patient will land up into the graft failure, and patient will require a resurgery or a second graft reconstruction, which, believe me, is a big trouble. So you need to pick up these fractures very well. Okay, I guess there are no more questions. या तो किसी को कुछ नहीं समझा या सबको सब कुछ समझ गया. Sir, you can take over.
Thank you, Chetali, for the wonderful session.
Thank you, sir.
Thank you, Srijita and everybody, Dr. Datta, Anbarsu, Lalendra, everyone. I had a great time. Coming to plain film evaluation of bone tumors, I think Srijita had solved a few of my problems. Nevertheless, I'll run through them. The most important aspect is the radiograph, as I would reiterate. You need to make up your mind on the radiograph, except in extremely rare situations where the radiograph is occult for a bone tumor, in which case, of course, an MR or a PET would pick it up and then you take it further by a biopsy. Otherwise, by and large, most of the bone tumors, they have some degree of periosteal reaction, bone formation, and bone mineralization. So based on this pattern, we can come to, a meaningful diagnosis. The benign lesion, probably benign lesion, or definite malignant lesion. Another question is primary versus a metastatic disease. That also you should be able to answer based on certain, take homes that I'll be showing you all. Coming to the basic bone structure, we have cortical bone and cancellous bone inside, and I think we did see a lot of stuff like that. Remember, for an osteolytic lesion to be seen on a radiograph, at least 30 to 50% of cancellous bone should be removed. Okay, that's something which we need to keep in mind. And I believe during some point in time, somebody had asked a question about which is physis and which is metaphysis. Typically, in a child, we do have after the physis, that is the gap that you see in the bone, about a centimeter odd is the metaphysis, and everything after that is the diaphysis. And in the adult skeleton, we just have a physeal scar, we have cortex and medulla. Coming to bone tumor analysis, there are 7 points that you need to remember: pattern of bone destruction, zone of transition, periosteal reaction, orientation or axis of the lesion, trabeculation, soft tissue extension, and history. The pattern of bone destruction is something which we have been following, and it was stated by Lodwig some decades ago. Type 1, type 2, type 3. There is a change in this. I will come to that very briefly. By and large, the thing remains the same. Type 1 is of 3 types, which is geographic bone destruction. You have lytic lesion with sclerotic border. You see this sclerotic border in a bone lesion. So this is a sclerotic. Of course, we have multiple trabeculations. Whatever the diagnosis may be, this is type 1A. And type 1A has many differentials, right from UBC, unicameral bone cyst, to MFH. Okay, there is a huge list. Then we have, on the other hand, type B, 1B, that is lytic with well-defined non-sclerotic margins. Okay, this is well-defined, pretty decently defined, but the margins are not sclerotic. The lesion is subarticular, multiple, trabeculations, and that's the schematic. Always look on that side because I have tried to show you. Amongst the highest is the GCT, and then you have various diseases which can just look like that. Then 1C is lytic with ill-defined margins. You don't really know where the normal bone is starting and where the abnormal bone is ending. So that is 1C. And amongst 1C, you have all kinds of high-grade tumors except infection. Okay, the lymphomas, chondrosarcomas, osteosarcomas, they all would fit in with this. Then we have type 2, which is lytic moth-eaten bone destruction. Typically, you see these central central dots within the medullary cavity. You're seeing all along in the acromion process, the humeral metaphysis and the diaphysis. You typically see in myeloma metastasis, of course, in infection and eosinophilic granuloma as well. You can see lymphoma, very important, and Ewing sarcoma or PNET. Then we have permeative, which is type 3. Permeative would just look like linear streaks with, a resorption of the cortex. And here we see a translucent band, very characteristic of one particular disease. Uh, Anyone, what do you think this is? We have a chat box. Chaitali, if you can see if anybody has answered anything. Or she's not there. Anyway, I think we are running a little short. I'll run through it, and maybe this is, leukemia. Then lytic permeative bone destruction, we have, various causes, Ewing's, right from Ewing's to osteosarcoma and neuroblastoma. Okay, and don't forget this entity whenever you are reporting pediatric X-rays. So basically, the pattern of bone destruction, you have, well-defined borders, moth-eaten, permeative. They tell us that there is a lot of aggression in growth. The growth of tumor cells is very rapid, and they are more malignant. However, modified Lodwick-Madewell grading system way back in 2016, they just upgraded that 1C, which we said they made it 2, and then 3A was some focal change in margin with progressive endosteal scalloping. Okay, that is the only difference. The moth-eaten and permeative, which is 2 and 3 of the earlier Lodwick, has been upgraded to 3B. And 3C, which is the most challenging, it is the radiographically occult lesion. Okay. In fact, the radiographs are nearly normal, and the lesion is seen on advanced imaging. Okay. This new grade, that is grade 3C, is indicative of the most aggressive pattern of growth in which tumor cells extend through bone more rapidly than host osteoclasts can produce recognizable osteolysis. Okay. This is something which you need to remember. So that sums up what the new modified system talks about. This is radiographically occult. I have an example. Okay, this was a classical example of the distal tibial lesion, absolutely normal, but MR shows, a lot of uh, mass infiltrating the marrow and encasing cancellous bone. This was proven to be a lymphoma. Zone of transition, very important, the border between lesion and normal bone. If you can draw with a pencil or a pen, where it becomes well-defined margin. Okay, if it is wide zone of transition, imperceptible margin, you cannot draw clearly. And these are typically seen with aggressive lesions. Remember, these apply to osteolytic lesions. And of course, infection and eosinophilic granulomas are the non-tumorous lesion, meaning the other kind of lesions which can exhibit, a wide zone of transition. Okay. Now, for example, here you see the tumor, sclerotic margin, end of the story. There is nothing beyond it. So this is narrow zone of transition. This is a lesion which ends here. Everything beyond it is normal. That's the lateral. So this is narrow zone of transition, and that's the end of the story. On the other hand, we have permeative bone pattern. Now we are not sure where the normal bone is starting and where the tumor has ended. Okay, so this is a wide zone of transition. As we go further, periosteal reaction. Lesions, benign lesions may have no periosteal reaction or solid periosteal reaction. Although on the other hand, more aggressive or malignant lesions would have varying kinds of lamellated onion skin, sunburst, Codman strangle. We'll come to that soon. So these are the types of periosteal reaction. Just remember few of these pictures. They would be helpful in your analysis of bone tumors. Now, what is Codman strangle? Basically, the advancing tumor margin destroys periosteal new bone before it ossifies. I've taken, osteosarcoma, and just try to show you the Codman's triangle. That's the Codman's triangle here, and we have it here. And then we have, this is a benign lesion with no periosteal reaction. Then we have, infection with lamellar periosteal reaction, what we call solid periosteal reaction. And then we have, this is a schematic representation of the same. Sorry, I'll go back. Yeah, that's the representation on the lateral side. And we have the onion peel appearance. This is classical for Ewing sarcoma. And then next we have a sunburst kind of an appearance of periosteal reaction. That is an osteogenic sarcoma. Coming to periosteal reactions, solid periosteal reactions are typically, less malignant or benign. And on the other hand, you might see sunburst and, Codman's triangle. They indicate more aggressive forms of bone tumors. Okay, this is again a lamellated periosteal reaction. A bony sclerotic lesion is seen in the scapula. Orientation or long axis of the lesion, it's a poor determinant of aggression of a lesion. It is said that if the tumor grows in long axis of bone, it is malignant. If in circular, it is benign. Honestly, it's really difficult at times. This is one picture which I would want you to remember always. And it does tell us everything right from down till the top, including epiphyseal lesions, predominantly such as chondroblastoma, GCT, and then moving forth the metaphyseal lesions, and then moving forth the diaphyseal lesions. Okay, so this is the gamut of all the lesions that I am trying to show on just one picture. And this would tell you all that you need to remember about these different lesions and their locations. Tumor matrix is the internal tissue of the tumor. Most often you see, if you have a lytic lesion, it will be radiolucent. If you see cartilage matrix, it could be calcified rings, arcs, or dots, what we call stippled calcification, commonly seen in chondroblastomas, chondrosarcomas, occasionally and chondromas. Ossified matrix is osteosarcoma, and ground glass is classically for fibrous dysplasias. Now, these are the various, pictures that I have to represent matrix, which is solid, cloud-like, ivory, so on and so forth. Okay, and this is something that you need to keep in mind. You see blastic matrix. This is typically seen in osteogenic sarcomas. Then we have cartilage tumors. You see this stippled calcification, these dots that you see. This is something that you have to look for. And this indicates we are dealing with a chondrosarcomatous lesion. And ground glass, there is a pathological fracture here. A ground glass like this is pretty much diagnostic of fibrous dysplasia. You really do not need any imaging to diagnose these conditions. Trabeculations, very important. They represent new bone formation evoked as a response to the nearby neoplasm. Okay, that's something which is important. The location and appearance of trabeculations gives some information about the nature of the tumor. Okay, for example, in GCT, we have delicate thin. In hemangiomas, typically the vertebral hemangiomas that we see, striated radiating, coarse, thick chondromyxoid fibroma, lobulated non-ossifying fibromas, delicately horizontally oriented ABCs. Now, anybody, can you tell me the diagnosis in this? This is a trabeculated tumor. Since we are talking about trabeculations, I found this from my collection some years ago. This is an expansile, markedly trabeculated lesion involving the middle phalanx of the second digit. Anybody? Anybody? I don't know who is comparing. Money?
Yeah,
Check.
I'm there, Sanjay.
Any? I can't see the.
People are saying enchondroma, brown tumor, ABC, GCT, ABC.
Okay, fantastic. I think brown tumors don't look like this. You need to have subperiosteal reaction. Of course, brown tumors would be like that, but brown tumors do not have trabeculations like this. This is classically a GCT. Okay, ABCs again, they really do not usually involve the phalanx. Unusual. They usually have, tubular long bones. That's the location. But expansile lesion like this was biopsy proven to be a GCT. GCT would be a very appropriate diagnosis. Okay, then just to show you, we have a subarticular lesion with trabeculations. Look at the horizontal trabeculations. Of course, few of them have vertical. This is GCT. Hemangiomas, you have vertical striations. In fact, you are seeing one more hemangioma here. So if you see something like this, you are pretty sure that we are dealing with hemangiomas. Soft tissue extension, something which I always look for. It's seen in malignant and benign lesions. And remember, if you see soft tissue at extension, it is more likely you are dealing with a primary bone tumor rather than metastatic deposit. Of course, there is another caveat. Unusual metastasis would give rise to unusual bone tumors. Okay, so in which case they may have a lot of soft tissue with it, but that is a latter part. That is less common. Okay. What I have seen in practice is malignant lesions tend to still respect fat planes around it, whereas infection tends to distort or obliterate adjacent soft tissue planes. Um, it's pretty working for me, not extremely reliable as far as literature is concerned, but by and large, for example, this we have a speculated, you see this sunburst, so-called sunburst lesion. You see this fat which is displaced anteriorly and this fat which is displaced posteriorly. The lesion has got osteoblastic matrix and there is a narrow zone of transition. You see subtle periosteal reaction, although there is a Codman's triangle here also. Of course, this is an osteogenic sarcoma, but the fat planes are displaced. You see this is important. Whereas on the other hand, we have an osteolytic lesion in the metaphysis here and the surrounding fat planes. This is the fat plane, which it's blurred. On the other hand, this is the normal fat plane we see on the other side. So that's something that you need to remember whenever you are looking at diseases. Multiple versus solitary, very important. Metastatic disease is multiple. You may have congenital fibrous dysplasias, Paget's disease, and you might have, metastasis and so on and so forth. History is extremely important. The duration, invariably, I have seen tumors having a history of trauma, and that's how they start working up on the plain film. And then finally, we tell them, okay, look, this is a tumor. This is not a fracture. So please go accordingly. If it's benign, you say it's benign. If it's malignant or likely malignant, commit yourself. There's nothing wrong with it. Likely malignant is perfectly fine. But you must make a point. You must describe it in the fashion that I have enumerated. And that will really be a check mechanism. This tells everything that I have been talking for the last 15 odd minutes, malignant versus benign lesion. This sums up actually everything. And it tells you well-defined sclerotic border. You may have indistinct border, but still it's well contained. You have solid periosteal reaction, no soft tissue mass, geographical bone destruction. Well, you are dealing with a benign lesion. You have wide zone of transition, moth-eaten permeative pattern, interrupted periosteal reactions, soft tissue mass. Well, you are dealing with a malignant lesion. I have some cases, Mani. I have time, right? Or how much time are you giving
Yes,
me?
we can go on, Sanjay.
Okay. Okay. After each case, I'll give you the history in brief. Then I'll show you the images. I want you to give me your diagnosis, okay, based on whatever you have seen so far. Don't worry if you're wrong. This is case one. They are two different individuals. This is primarily a metadiaphyseal lesion, and this is again another metadiaphyseal lesion. This is an immature skeleton. This is a little younger. I mean, little older fellow. This is younger. Anyway, any answers to this, Mani?
So we are getting ABC, SBC,
Okay,
and
great.
simple bone cyst with fracture for the right one, I guess.
Perfect. It makes sense. There is a pathological fracture here. Both are unicameral bone cysts or simple bone cysts. ABCs tend to be a little more expansile. Okay, that's something that you should remember. They involve more of the metaphysis. That is another aspect. And this is nothing but a simple bone cyst. In fact, there is a bit of an incomplete fracture as well here on the right side. No question, this is unicameral bone cyst or simple bone cyst. Absolutely correct. Okay, Case 2, we have a markedly expansile lesion involving the metaphysis of the fibula. This is, and there is a bit of an incomplete fracture. There is endosteal scalloping, again, which is a feature of this particular condition. Anyone young skeleton?
Yeah, we got more than 10 answers of GCT, couple of ABC.
Okay, I think whoever has said ABC is correct. Look at the epiphysis, it is still intact. Okay, so GCT is something which would be subarticular, meaning you will have articular, subarticular. So you would have GCT going this way, and there are not many trabeculations in this. So the GCT as a diagnosis is a little less likely. This was and this is the MR. I think with MR, you would not have any two diagnosis. You will yourself narrow it down. You are seeing fluid levels on axial T2. So this is nothing but an ABC. One important aspect about ABC, you need to remember, it is basically venous obstruction secondary to trauma. It can be secondary to many other primary tumors due to hemodynamic change. That is something you need to remember always, because pathologies, they tend to use these words. So these are the primary tumors: chondromyxoid fibroma, chondroblastoma, fibrous dysplasia, GCT, simple bone cyst, chondrosarcoma, osteosarcoma. These are all the tumors, you may have secondary ABC. Okay, so that's something that you need to keep in mind. We have a 13-year-old with knee pain. Anybody wants to make any diagnosis on plain film? Then of course I'll show you whatever is available with me. Anybody? I think you will.
Wide notch and hemophilic arthritis. Some have said scurvy, and Saukar has said chondroblastoma as well.
Wonderful. Whoever has said is chondroblastoma, look at this carefully. There is an osteolytic lesion here in the epiphysis. Okay. Now, this is just a view to, intercondylar view, just to show the lesion carefully. That's it, nothing else. There is no scurvy. The bone mineralization is absolutely normal. The metaphysis are absolutely normal. That's the MR. I think you guys are very familiar with MR. There is a T1 hypointense lesion in the tibial, in the, proximal tibia, the tibial epiphysis with adjacent marrow edema. Okay, this is classically a chondroblastoma. There's no periosteal reaction, there's no matrix, nothing. Another patient with similar findings. This is a slightly bigger lesion right in the midline. Okay, another patient. I think you all are so familiar with knee joint, you shouldn't have a problem answering this. Got it? I think everybody must be talking about chondroblastoma.
We've got one GCT, one chondroblastoma. Chondroblastoma mainly, yes.
Yeah. I think it is chondroblastoma. Look at the location. These are the CT findings. Actually, we did the CT first. It is way, just into the epiphysis. That these are the coronal sections. Not much surrounding sclerosis, not many trabeculations, and just few strands here and there. Okay, so this was a chondroblastoma, no question. We have a 35-year-old female with right hip pain. It shows a lesion in the right hip. We have an MR image. So have I given the diagnosis here only? No, not really. What do you think about this?
People are answering ABC, and we've got one chondroblastoma again.
Okay.
So GCT.
Chondroblastoma, remember, is a diagnosis before epiphyseal fusion, by and large. Okay. So if it's a 35-year-old, one doesn't really look at chondroblastoma as a diagnosis. It's adolescent disease. And then you have a little more of the epiphysis involved and the metaphysis. Okay. And this is classically a GCT, no question. This is a GCT indeed. This was biopsy proven to be GCT. Okay, we have another case. This is a left knee joint epilateral. Anybody has any diagnosis to offer? In fact, we are seeing few horizontal trabeculae. The lesion is epiphyseal, metaphyseal, no periosteal reaction, indistinct margins, yes, a narrow zone of transition. Matrix is pretty clean, just apart from few trabeculae. Yeah, anybody?
Most have
What is?
answered GCT.
Okay, perfect. They're absolutely right. That's the MR, which shows, there is a bit of cortical breach here, but this is GCT, no question. Case 5. What would you call this? A benign lesion or a malignant lesion? Just answer this question, then we'll go to the other X-rays. Anybody is answering?
Yeah, benign. At least about 15-20 have said benign.
So did I. Then the patient had, just wait. We are seeing thick periosteal reaction, metadiaphyseal lesion. Okay, geographical bone destruction, fair enough. Do a skeletal survey, moth-eaten appearance. I banged my head. We are dealing with something else. There is, cortical breach, endosteal scalloping, and you don't see the cortex at so many places. Now, do you want to change? A lytic lesion in the femur,
People going to
then something.
metastasis. There was a lesion in the tibia also, was there? I think.
No, that's just projectional. Okay, the best thing, if you have metastasis in mind, just do a simple skull X-ray. Now you want to change? People want to change?
We're getting multiple myeloma now.
Absolutely. These are well-defined, rounded, punched-out osteolytic lesions without any sclerosis. Myeloma who has undergone chemotherapy or radiotherapy for whatever reason, okay, that area, but by and large chemotherapy, they would have sclerotic borders. But to begin with, these deposits do not have sclerosis, and they are typically small, rounded, of almost the same size. Okay, not always, although. And as compared to metastatic disease in the skull, which may have a lot of variation in the sizes. So multiple small punched out lesions like this, more likely myeloma, and on the other hand, metastatic disease, lesions of various different sizes. Few may be 2 centimeters, some may be 5 centimeters. That is typical of metastasis. So this is multiple myeloma. So just don't go by one X-ray. Just see if the patient has pain elsewhere. And you need ideally in myeloma at our institute, we do skeletal screening. There's a huge list of X-rays which are done routinely for all myeloma patients so that we pick up the foci properly. This is a 14-year-old. This is case 6. But this diagnosis actually is very simple. Very simple. Anybody? I think I can't see the chat box.
Osteochondroma.
Yeah. Exhaustosis. Absolutely correct. We see a cortical projection from the posterior femoral diaphysis. No question. And most important thing, whenever you see exhaustosis or osteochondroma, you need to look at the cartilage cap. If there is everything fine, no soft tissue. And solitary lesions, the chances of chondrosarcomatous change are extremely rare. Unlike you have the other varieties of diaphyseal achalasia in which the chondrosarcomatous change increases dramatically. Okay, this is the MR showing the same. This was exhaustosis or an osteochondroma. Case 7, 25-year-old woman with knee pain. That's the frontal view. And I'll show you the lateral view as well. I think Chaitali has shown knee so extensively that even now I just keep on imagining knee X-rays so beautifully. Anyway, what is the diagnosis? This is a well-defined osteolytic lesion, few trabeculae, and narrow zone of transition, geographical distribution 1A. And
NOF.
absolutely correct. On dot. There's nothing more to it, nothing less to it. Case 8, 45-year-old with thigh pain. Please note this is 45-year-old. Okay, so it's not always that you see such a condition in adolescents. Anybody? Quickly. We are seeing something in the cortex, and we are seeing something in the a solid thick periosteal reaction.
All have answered osteoid.
Absolutely, no question. That's the nidus. Very simple. We are seeing the nidus very well. This is an osteoid, no question. There is a bit of calcification also. Case 9. I think it's an Aunt Mini diagnosis. You don't really need, I'll nevertheless show you whatever I have to show you. Case 9. This is an immature skeleton. The epiphyses have not fused. And this is the age group that you get to see such a lesion. I think it's pretty straightforward. Anybody?
Yeah, all with E-wings. Yeah.
Perfect, absolutely. The onion skin peel or onion skin appearance, whatever you want to call it, seen beautifully in the on the CT. You know, it's excellent. You see, there is no matrix, and this was a classical A-wings. Very important. The zone of transition is still questionable. It's narrow. There is classical onion skin appearance. Next, case 10, elderly gentleman about 20, no, not elderly. This is a young fellow actually, about 22, 23, with sunburst periosteal reaction, ossified matrix, and you see these speculations, and you see some solid periosteal reaction also way down. There is cortical breach. I think this should not be a problem at all.
All with osteosarcoma.
Absolutely. Yeah, that's the MR, which shows the whole tumor and edema in the marrow. That's an osteosarcoma, no question. Case 11, just minor pain in the proximal humerus. We see a sclerotic lesion in the proximal humerus. There is narrow zone of transition, no periosteal reaction. Simple, very simple diagnosis. What do you think?
We got enchondroma with one saying bone infarct.
Oh, go, not bad. So this is actually an enchondroma. Okay, and the guy who said bone infarct is right for this other X-ray. You see a sclerotic lesion, in the metaphysis going into the diaphysis, something like this. Such a huge thing is usually a bone infarction. Okay, so this is a bone infarction, and this is the earlier one. This is an enchondroma. So there is a distinct difference between the two of them. It's case 12, 38-year-old. Mani, you tell me when I have to stop. I'll stop.
Yeah.
There is an expansile trabeculated lesion arising from the left acromion process. The glenohumeral joint appears intact. There is slight widening of the acromioclavicular joint. I'll show you the CT. It has few trabeculations in the upper portion. There is a bit of endosteal scalloping at places. And I have an MR. These are the bone windows. Okay, and these are the MR images which show blooming consistent with hemorrhage, T1, T2. What do you think about the diagnosis? What do you think we are dealing with?
More than 90% have answered GCT.
Remember, again, this is not the site actually for a GCT. Acromion process should make you think that probably you're not dealing with GCT. It's a little unusual site. We don't get to see GCTs there. Okay, these are the coronal sections. You have hemorrhage, you have hypointense foci within. This is classically a chondroblastoma with secondary aneurysmal bone cyst. Okay, going back, chondroblastoma is a diagnosis. Epiphyseal involvement. This is 38-year-old. Yes, I agree. This is again not the age for a chondroblastoma, but this was proven by on biopsy. So that's just something that you need to remember. And remember one more thing: chondroblastomas may cross joints. They may cross joints. So this was proven to be chondroblastoma with secondary aneurysmal bone cyst. So that's the diagnosis. Case 13, 35-year-old male with painful right hip. In today's reporting, I think I don't know, we would have passed it off as normal also. money in an afternoon session, unless you know the history, you may say, I don't know what is this. Maybe just figure out. And my staff is always very much irritable when I ask them about history, because they really don't understand the implications behind it. But anyways, there is something here in the right acetabulum. Young fellow, I'll show you the CT. In fact, we do see some areas of calcification. CT shows an expansile lesion with chondroid matrix. Of course, I've given you the diagnosis, but you need to understand the reasons. These are the MR images as well. You see lobulated hypo and hyperintense areas. Coronal steer shows hyperintensity. I think I have one more image. I'm not sure. But if I go to the next, anyway, what is the diagnosis? What does everyone feel?
Chondrosarcoma.
Absolutely. These are the coronal ones. They are steer images, which are, the lesion is bright. There is edema in the right superior pubic ramus. So this is nothing but a chondrosarcoma with matrix, chondroid matrix calcification. You see this is on the plain film. It's very difficult, but then this what probably I felt on the x-ray. So we go on to the next. 30-year-old female with pain. On the plain film, I thought it looked pretty innocuous, but then something told me that this is not so innocuous as it is made to believe. We see an osteolytic lesion arising from the proximal metaphysis. It's basically metadiaphyseal lesion. The knee joints are absolutely fine. There's nothing wrong with it. No soft tissue, no periosteal reaction. There are multiple trabeculations within, narrow zone of transition. But the appearance, there are some, calcific dots within. So they put me a little towards a particular condition. I want people to answer. What do you think I must be thinking? Anyone? She's young.
People are putting, it's a mixture you got actually. CMF, ABC, and chondroma.
Okay, it's neither of them. I was
GCT also we got.
Okay, we saw GCT. It's pretty much bulbous. It's an expansile lesion. And there are certain features which I just didn't like, and that I thought was chondroid calcification. Okay. So anyway, I'm showing you the MR. The lesion appears T1 hypointense, T2 stir hyperintense. So you would know the diagnosis. Everybody is extremely familiar with MR. This is nothing but a chondrosarcoma. Okay. This turned out to be that. So something which looks pretty innocuous may not be innocuous. This is something which you need to remember. And another case 14, 17-year-old came with progressive arm pain, left arm pain, no history of trauma. We had these x-rays to begin with. Then a biopsy was done, which didn't show much. And later on, 1 month later, he, came with a solid, ossified lesion. There was periosteal reaction along the metadiaphysis of the humerus. Then these are the CT cuts of the same time. You see osteoid tissue around. And you see, of course, there is periosteal reaction also along the humerus. And there is a slight cleft between the bone and the lesion. This is MR. Since all of y'all are familiar with MR, I'm just showing it to you. And I think I have one more slice, or I don't want to risk it. Yeah, I have one more slice. There is heterogeneous signal intensity. So what do you think it is? Anybody?
Yeah. Many have answered myositis ossificans. Few have answered paraosteal OS.
Perfect. I think those who have answered myositis ossificans are almost correct. So did I think initially. I'm being very honest about it. Till the second X-ray came a month later. Even I had almost just reported it as myositis ossificans. You're absolutely right. And so did I report at this point in time. But when the patient came for a follow-up, I changed my mind. I said there's something funny about it. And that's why the further imaging. And first biopsy showed spindle cell sarcoma. Some vague diagnosis was given. But the second, as somebody said, an osteogenic sarcoma, osteogenic sarcoma. So this was finally an osteogenic sarcoma only and nothing else. In fact, to begin with also, it was just that. Okay, case 15, 55-year-old with back pain since about 11 months, 11 and a half. There was trauma 4 years ago. It showed a osteolytic lesion within this vertebra. Okay, there's a nice osteolytic lesion here. That's the MR showing T1, T2 hyperintense lesion. Anybody? What do you think this is? There's nothing else. This is it. There is no cord compression, nothing. The patient underwent a procedure. I can give you a clue now. Subsequent to this, a simple diagnosis, nothing much. Anybody? Money? Anybody is giving a
But
diagnosis?
Shivali Arya saying hemangioma.
There are no trabeculations, Shivali. There are no trabeculations. I have shown you how an hemangioma looks like. There is a bit of compression also. If you see the height on X-rays, you should be extremely particular about this. Always compare the height of vertebrae above and below. So if you have something like this, definitely it's abnormal. Again, the curvature posteriorly, very important. If you have some bulging curvatures, it usually tends to favor a malignant process. Okay, that's anyway, these are CT and these are corroborative findings with MR. But on plain X-rays of the spine, these are the things that to be looked at. Okay, CT, I'm showing you a CT now. Come on. Now at least. No. Anyway, this could be a little different.
We're getting few more answers. ABC, plasmacytoma, osteoblastoma.
Okay. Okay. Now, all of them could be potentially right. That is why we were wondering what is to be done. Now, see, all of these lesions, they need to be differentiated radiologically. At times, it is extremely difficult to distinguish them. Plasmacytoma, again, would have some expansions, some, some trabeculae. So would be an osteoblastoma, but such a big osteoblastoma is unusual. And this finally biopsy was done, and this was just a benign fibroosseous lesion, what is similar to a cyst, basically. Okay, this patient underwent a vertebroplasty, put in a cement, and now is still following up. It's almost a decade now, no issues at all. I think 16, pain in the foot, pain in the left iliac fossa. Okay, this is a young fellow. Anybody can pick up this lesion on Saturday. On afternoons. Usually, all these X-rays they put me a little out of focus. But anybody would pick up this lesion.
Yeah, I'm waiting for some answers. Okay, we're getting a lytic lesion seen at the iliac blade.
Perfect, absolutely. I'm glad you picked it up. There was a history.
Very good pickup.
This was picked up prospectively. I thought there is something there. We did a CT. There is a lesion, no question. There is no matrix and there are no trabeculae to it, no periosteal reaction. There's a simple lytic area there, just in the iliac bone. Just now, everything is MR, MR, and MR. So an MR was done, and it just really didn't throw much light. We had to ultimately do a biopsy. I did the biopsy, and it showed these are the hyperintense areas that you see in the lesion. It did show eosinophilic granuloma. Okay, so this was the diagnosis. And of course, I have mentioned all the classical features about the bone here in the description. So a lytic lesion, eosinophilic granulomas can occur in any age group. And I have seen till about 40s also eosinophilic granuloma, which was the case with this. A 16-year-old with progressive swelling right shoulder, mild fever, no trauma. Okay, this is the radiograph of the scapula. You see whatever you see. You tell me what do you think this is. You see the X-ray carefully first. Benign, malignant. If it's malignant, what do you think it must be? It's a flat bone. Young, remember the age. Remember, chondrosarcomas are all after the third decade onwards, 35 onwards. Okay, you don't really get chondrosarcomas in the younger age group. First decade, second decade, third decade. We really don't give a differential there of chondrosarcoma.
Most are giving a malignancy as a primary.
Perfect.
Ewing's versus OS.
I'm really happy. At least now we have reached a stage where we are able to analyze what is benign and what is malignant. We are seeing an expansile. This would be a kind of a permeative lesion, or you want to call it a moth-eaten. There are multiple trabeculations, and we have CT. You see it's a lot of cortical breaches there, and some trabeculae. You see few of the trabecular struts also. This was nothing but the PNET or an Ewing's tumor. This is malignant tumor, no question about it. And I'm really glad that you thought of that. There's no osteoid as such to call it, osteogenic sarcoma. So that was the only thing. I thought this is Ewing's only, or PNET as they call it now. Case 18, where is the lesion? It is just a twister, nothing else. I think Anbarso showed it yesterday, or no, today. Yesterday was abdomen, so he would have shown it today. Where do you think is the problem? The right shoulder and the left shoulder. What is the abnormality? Anybody? Quick. I think Arso showed X-ray chest beautifully.
People are saying left acromion missing.
Left acromion missing. Acromion is this, right? So what is missing? This is the acromion, right? So what is missing? So they want to say something else, but they feel it's the acromion, is it? Now look at this border of the scapula carefully, and look at the border of this scapula. Where is it? You are seeing some gaps.
Yeah.
You are seeing some gaps.
Okay. Radha Bavage has said left scapula, but just left scapula.
Absolutely, she's absolutely right. Second, very important, very subtle. Look at the soft tissue. Okay, there is a lot of soft tissue around it. So you see erosion of the scapula and a lot of soft tissue around it. That's the massive soft tissue, and there's a lytic lesion there in the scapula. No question. I'm really happy that she picked it up. We did a biopsy, and this turned out to be metastasis. This patient was already a keratinizing squamous cell carcinoma, and RT was given, and this just happened to have a metastatic disease there. I think these are the last ones, Manik. 919, 16-year-old, pain, heel. This is the right heel. This is the left heel. Okay, there is pain in the heel. Now you need to decide which heel. Okay, I have given, this is what history we get. I am really fortunate if a doctor writes some history at least. But some things like this just don't happen often in practice. We have to chase, for a history. Okay, left heel or right heel. Obviously, the left heel must be painful. Anybody in money? Anybody's writing anything?
People are writing apophysitis.
Okay, great, not bad. Looking at the X-ray, I felt there is an osteolytic lesion here. Okay, I'll remove it again, and I'll erase the ink. Now you see for yourself again. Okay, a lesion here. This is what you are supposed to pick up on a plain film. CT-MR is going to show you straight away, like CT. This showed a classical. This is now left, the opposite, and this is the right. Okay, it showed a nidus, which was calcified. And as you can see, a lot of sclerosis is there in the calcaneum. So this becomes an osteoma. Okay, so very, very important. See, there is no periosteal reaction. On the other hand, this is classically an osteoid osteoma. Sorry. On the other hand, what do you think about this? This was sclerosis involving the entire calcaneum, but there is subtle periosteal reaction. So whenever you see some irregular periosteal reaction, generalized sclerosis, okay, and you don't see any nidus. So this was something which came, immediately after this case. It always happens in crops. Some abnormality comes like embolism. We have 4 in a line and then nothing for 6 months. And certain diseases like this, like you see a nidus, you see an osteoid, 2, 3 come together, and then there's nothing for a year or two. So this was just uniform sclerosis, periosteal reaction. This is indicative of infection. Wide zone of transition, you don't know what's going on. So this was biopsy proven. Touch me not, very important. The fibrous lesions, non-ossifying fibromas, enchondromas, exostosis, unicameral bone cysts. You must be very confident in diagnosing these conditions. No biopsies are to be done for these. Just leave them alone. That's what you need to tell the orthopedic surgeons. One important thing that I would like to tell you, remember, orthopedic surgeons are excellent in picking up fractures, but when it comes to bone tumors, they are lost. Okay, they need a lot of support from us as radiologists, because invariably we'll end up doing a biopsy. And so that's where we really are essential. Okay, we are not too bad. We can carry ourselves well unless we decide to fall. And radiographs are, I would say, extremely vital to the diagnosis of bone lesions. You should make up your mind you are dealing with benign lesions, near benign, possible malignant or malignant. Then malignant is primary, secondary, so on and so forth. These age, location margins would help you a lot. Thank you very much for your patience.
Thank you, Sanjay. That was really a wonderful walk through the bone tumors and all focal bone lesions. And thank you very much for being there with us for AGFA Masterclass, the 4th one in a row.
Yeah.
Thanks very much.
Okay. Yeah.
And you can just switch off with slide share and we will now welcome Dr. Anand Hadgaonkar. Welcome, Anand, and thank you for standing by on Sunday afternoon. But we still have more than 225 people waiting to hear you. Dr. Anand is a consultant radiologist at the National Cancer Institute, Nagpur, and he's been ex-associate professor at GMC Nagpur, as well as BJ Medical College, Pune. I first heard this lecture, I think long ago. I think it was in Latur in 2014. And it was such an unusual lecture. I was just blown away by it. Was it 2014 or 16?
16, it was 2016.
16, yeah. And so I've kept it in mind. And I think we are very fortunate to have him back here and give us a really interesting lecture on the hand as a mirror of diseases. So Anand, you can just go ahead and share your screen, please. Yeah.
Thank you, Sanjeev. My topic is hand as a mirror to the diseases. The human hand is a fascinating subject, an actor of many roles and disguises. The man in miniature revealing its owner's story. So let's see whether really our hand is a man in miniature and can reveal the story of the owner. Palmistry as an art and science being used since years together.
Anand, sorry, are you going to share your screen now or later?
I have actually shared it.
So can we just go at the bottom and just click on the screen? Share screen.
I thought just a minute. Huh?
Yeah.
Is it visible?
No, not yet. You'll have to click on the button right down at the bottom, the green button. Yes, now it is.
Oh,
yes.
Okay.
Yeah.
Actually,
and just open from the beginning. Yeah. And we need full screen. Yeah.
Yes.
Yeah.
Yeah. Now I can.
It's fine.
Thank you.
Perfect.
Thank you, Sanjeev.
Yeah.
Actually, it is almost a repetition of the same. I say same talk with little addition. So, hand as a mirror to the diseases. Human hand is a fascinating subject, an actor of many roles and disguises the man in miniature, revealing its owner's story. So let's see whether really it reveals owner's story or not. Palmistry as an art and science being used to tell past, present, and future of the person since years together by the old age palmist, as one can see here, but new age palmist are these people with stetho and aprons, and they are also looking at different deformities of the hand and also discoloration, and likewise trying to predict about different diseases. The change came in on 8th of November 1890, when William Conrad Röntgen discovered X-ray, and incidentally, the first radiograph which was taken was also of a hand of his wife Anna Bertha Röntgen. As one can see here, incidentally, the first artifact which came along with this is a metallic artifact, and that too of a wedding ring of Anna Bertha Röntgen. What eyes don't see, mind does not believe is most dangerous. Same thing happened with radiation. X-rays were hazardous, and ultimately repeated exposure to the X-rays has led to a such type of mutilated appearance of the hand, and by early 90s, amputated fingers had almost become an unofficial badge of the X-ray worker. I just want to comment something about the Clarence Daly. Clarence Daly was associated of Thomas Alva Edison. Do you know any invention done by Thomas Alva Edison? Yes, Thomas Alva Edison is known for his invention of light bulb. But other than light bulb, he was also working with the fluoroscopic machine. And in fluoroscopic development of this fluoroscopic machine, Clarence Daly was his helper. He had a very miserable death with malignancy and multiple amputations, and he died in 1904. I will call him the first martyr who died of the X-ray hazard. So which X-ray is having least of the radiation exposure? Move to the X-ray, it is nothing but a X-ray of the hand. X-ray of the hand with less than 0.01 millisievert of the typical effective dose. So hand X-ray is the safest among all those X-rays and all the procedures related to the X-rays. So let's see whether hand radiograph can mimic different dysplasia, diseases, and disorders. So in next 20 minutes, we will go through different series of the hand radiograph and try to predict about the diseases. Sanjeev, can we make it interactive?
Yes.
Is it possible?
No problem. I'm here. Yeah.
So yes. Yeah, I'm just trying to make it a little interactive. At first, we'll start with the congenital disorder. So look at this radiograph carefully. Can you make out the abnormality? Just abnormality? Any answers? Try to measure. How many are the fingers? Fingers are 1, 2, 3, 4, 5, 6. So this is a case of a polydactyly. So whenever you are coming across a case of polydactyly, if it is on ulnar side, it is a postaxial. If it is on the radial side, then it is a preaxial polydactyly. Polydactyly is associated with plenty of syndromes and trisomies, but mostly it is a postaxial polydactyly which is having this association. This patient is Ellis-von-Crewald syndrome, that is a chondroectodermal dysplasia. Moving to the next, again another radiograph. Again we will start measuring digits or the fingers. What we see here are the 4 digits and also on the other side 4 digits. This is a case of thumboplasia, bilateral presentation with absent thumb, and if you can notice on left side there is also a absent radius. So this is a case of radial ray. Radial ray with presence of congenital heart disorder. This patient had a 3-chambered heart. This is the case of the Holt-Oram syndrome. So this one is a thumboplasia. Moving to the next radiograph. Look at this photograph. What one can see is fourth and ring finger and a little finger almost of the same length. But there is no problem with the phalanges. Problem is with that of the metacarpal. So metacarpal is short in length. Bilateral short metacarpals. There is something called metacarpal sign. Metacarpal sign is said to be positive if a line drawn from the 5th and the 4th metacarpal distal head passes through the 3rd. If it is not, then the metacarpal sign, if it is negative, if it passes through the head of the 3rd metacarpal, it is positive. If it is not passing through the head of the 3rd metacarpal. So here metacarpal sign is positive, and this is the case of Turner. Along with metacarpal sign, there is something called carpal sign. Carpal sign is said to be positive whenever there is a decreased angle between the lunate and the scaphoid. So scapholunate narrowed angle is seen mostly with the maid-lung deformity. So Turner syndrome, a patient with short metacarpal, short fourth metacarpal, and with that of a maid-lung deformity. Turner syndrome usually have a single X chromosome. Moving to the Dis disorder, yeah, something to do with the trident. Can you make out the diagnosis? Any answers, Sanju? This is a common spotter. Look at second, third, and
achondroplasia we're getting as a diagnosis.
Yes, they are perfectly right. So look at the second, third, and a fourth fingers. They are almost of equal length, and there is a splaying between the second and the third finger. So this is giving somewhat appearance like that of the trident of the Poseidon, or one can say Trishul of the Shankara. Along with that, one can see here metaphyseal flaring, and also all the metacarpals, they are of similar length. This is a case of achondroplasia. Here is another case. This is almost a classical appearance. So a typical deformity is there. If you look at them carefully, so try to make the diagnosis. Some sclerosis is there, sclerosing type of disorder.
We're getting a diagnosis.
Yes, sclerotome. And yes, it is malorostosis. Oh, already it is there. Sorry. So the deformity is the flowing candlebox deformity. What is seen here. So this one is a case of malorostosis. Another focal sclerosing dysplasia. If you can make it out, okay, it is really difficult to, because frequently this type of a focal sclerosing dysplasia we see in a radiograph of the pelvis with both hips. So it is periarticular something. So look at these small anastosis. These small bony islands or anastosis are there. Anybody had given answer?
Yeah, they've given more than 15 people have said osteoporosis.
Wow. So anastosis are there on either side. They are periarticular, bilateral, symmetrical. Nothing to do. This is just a normal appearance, but sometimes malorostosis, osteopoikilocytosis, and osteopathic striata, all these focal sclerosing dysplasias, they can be seen together. So this is, in such a patient, we call it mixed sclerosing dysplasia. So moving to the next one, moving to the metabolic disorder. This one is almost, I think, every alternate exam will have this radiograph of wrist. Easy to diagnose, metabolic disorder, something to do with calcium deposition. Answers are there.
Yeah. People are giving rickets, yes.
There is widening of the growth plate, flaying, cuppings. Once I say these words, widening, flaying, cupping of the metaphysis, answer is a ricket. As one can see here, widening of the growth plate. Most important thing is the widening of the growth plate one should look for, and first sign of recovery will be also a decrease in the distance between, decrease in the thickness of this growth plate. So this one is a case of ricket. Yeah, actually, I have seen one person, he is giving answer of the scurvy again and again. Scurvy is somewhat very difficult to find nowadays. So this one is borrowed case. What one can see here is the case of the scurvy. And there is, look at the growth plate is almost normal. And what one can see are the different changes like this. We are having different signs. Here is actually a defective cartilage formation, but calcium deposition is normal. So we are having white line of Frankel. Just before white line of Frankel, one can see this is a lucent zone of Trummerfield. One can even see a Wimberger sign with epiphyseal rim epiphysis. What one can see a lucent epiphysis, and subperiosteal hematomas are there. So all these findings one can see here. Here is the Wimberger sign. One can see here Pelkan spur, white line of Frankel, and a lucent zone of Trummerfield. So this one is a case of scurvy. Yes, again, this one is again a spotter, exam spotter. Whenever you come across inferiorly pointing metacarpals, they always points towards the some disorder. What is that disorder? In that disorder, if at all you are having X-ray spine, one can see a bullet-like, not exactly bullet, I should say. There is typical central beaking. One can see a posterior scalloping. Anybody who can make out the disorder? Short, stout, stubby, short stature babies.
People have said MPS and MOFUs.
Yes, it is MPS, and that too a type 4 MPS, which frequently presents with such type of skeletal deformities, and they are not mental retards. So this one is a Morpheus type 4 mucopolysaccharidosis. Moving to the endocrine cause, this one is difficult to make diagnosis. This is a giant hand. If I will say, it will be quite easy to diagnose. One should make a habit of looking at the tufts of the finger. So whenever you are looking at the tufts of the finger, how they are. If they are there or they are not there, everything is important. If not there, then it is acrosteolysis. If they are there and they are having such type of club-like appearance or a spade-like appearance in a patient with giant hand, with this spade phalanx and such type of appearance, diagnosis is acromegaly. So try to visit these patients and try to make the diagnosis. Here is another case. This one is a typical exam case, and almost every exam, the radiograph, if at all given of this disorder, will be of hand radiograph. This is the hand radiograph, almost showing all type of features. Try to make out the diagnosis. I will start telling you about the feature or different features which are seen in this radiograph. One can see osteopenia is there. There is subperiosteal tunneling, subperiosteal resorption is there. One can even make out acroosteolysis. Along with acroosteolysis, one of the phalanx is completely replaced by the soft tissue. A tumor may not be brown in color. Any diagnosis?
People have reported hyperparathyroidism.
Yeah, it is hyperparathyroidism. We are having primary, secondary, tertiary hyperparathyroidism. Look at this typical appearance of radiograph skull. It is salt and pepper type of the appearance, and spine is also a very typical. It is rugged justice spine, but mostly it is associated with the type 1. One has to go ahead further and take a CT scan. Here the CT scan showing a parathyroid adenoma, which is here posterior to the thyroid gland. Removal of the parathyroid adenoma can cure this disease. So this is a case of hyperparathyroidism, that to primary hyperparathyroidism. This one is very rare disorder, so I don't expect answer from you people, but such type of small bones are involved. Periosteal, such type of periosteal reaction is there with extensive swelling involving either both the hands and both the feet. In a patient, one can see here, this is a case of thyroid acropathy. So this is a case of thyroid acropathy. Although rare, you may come across, but that radiograph is very typical. This is thyroid acropathy. Moving to the hemopoietic disorders. Hemopoietic disorder, they are characterized by the medullary hematopoiesis. So whenever there is a medullary hematopoiesis, these hemopoietic disorders like sickle cell anemia and thalassemia, they will show a typical hand appearance. They will show tubular bone with medullary widening, cortical thinning, as one can see here. Here is another radiograph showing similar appearance. This one is thalassemia case, and here is a case of sickle cell anemia. Someone was telling about the bone infarct. Bone infarcts are frequently seen in sickle cell disease, and Sanjay sir had shown one of the radiographs showing the typical appearance of bone infarct. They are usually on the metaphyseal and typical appearance. Here I have shown a spine here. In sickle, there can be a stepping deformity at the end plate. It is because of the central collapse of the vertebra or S-shaped vertebrae. So just to show you S-shaped vertebrae. So this is the case of sickle cell disease. Diagnosis is of course by the pathologist. Moving to the connective tissue disorders. Connective tissue disorders, look at these hands. These are slender, long phalanges as well as slender, long metacarpals are there. They are giving somewhat a spider leg appearance or the spider-like appearance, few people may say. These people, they are having habit of making such type of magic tricks. They can even clench their fist and pass the thumb beyond the clenched fist, and they can even encircle their wrist with that of little finger and thumb. So try to make it out. If you can touch it, these people are having some disorder, which the great past president of America had, Abe Lincoln or Abraham Lincoln, and that is. Any answers?
Getting Marfan's.
This is a case of arachnodactyl. So this one is a Marfan syndrome. Moving to the next case, I always say look at the tufts of the finger. Look at the tip of the finger. So answer is there in a tip of the finger. So try to make it out. So one can see here a periarticular some osteopenia, but important thing is acro-osteolysis, as one can see here. Whenever you are looking at a patient with acro-osteolysis, and with acro-osteolysis, there are something like this. This is the case of calcinosis cutis. These calcifications are there within subcutaneous tissue. So calcinosis cutis with acro-osteolysis, diagnosis is scleroderma. Now a similar appearance. Patient might be having acro-osteolysis with such type of calcification. Calcification almost involving muscle, subcutaneous tissue, and everywhere. So we call it a calcinosis universalis. So calcinosis cutis, it is scleroderma. Calcinosis universalis is dermatomyositis. So again, another case of acro-osteolysis with calcification. Again, can you make out the abnormality? Look at the radiograph, the photograph. Photograph is showing typical drumstick-like appearance of the finger here, as one can see here. And there is again acro-osteolysis. So acro-osteolysis with swelling involving a tip of the finger. This is a case of hypertrophic pulmonary osteoarthropathy or pachydermoperiosteitis. Moving to the orthopathies. This is very common orthopathy, and you people, once you will look at the deformity, you can easily diagnose this case. I know this one is a very typical of. Frequently, this orthopathy involves metacarpophalangeal joint and proximal interphalangeal joint. Joints are mutilated, as one can see here, with different type of deformities, Schwann neck, or else a boutonniere type of deformity, Schwann neck, or else different abnormalities like ankylosis of the carpal bones, as one can see here. So all these deformities with ankylosis, but the hallmark of the disorder is the osteoporosis. To start with, an inflamed joint, it is periarticular, while it is somewhat a generalized sort of osteoporosis one can see in this case. So this is a case of course, rheumatoid arthritis. Another case, look at the involvement of joints. Joints are distal interphalangeal joints. So distal interphalangeal joint involvement. Look at the density, no osteopenia, no osteoporosis. You may come across acro-osteolytis in these cases. Acro-osteolysis, uniform swelling, as one can see here in the middle finger, giving sausage-like appearance of the digit. Even a thumbs are showing typical a sausage-like appearance, or sometimes a ape thumb appearance. And this is the case. Yes, anybody can make it out. Although findings are more commonly seen.
Yeah, people answer psoriatic arthritis.
Wow, this is really great, huh? So I really appreciate the answer. It is somewhat difficult. Now moving to this case, here periarticular osteopenia, one can see some swelling is there and a typical marginal erosions. In a case, these erosions are called rat bite erosions. Actually, gouty tophi word already there. So this one is a case of gout. But which is the common joint which is involved in gout? It is not the hand, it is the foot. So any answers?
Yeah, they've said first MCP, they've said. Metatarso.
No, I said foot.
Yeah. People have said MTP joint.
It is metatarso. Yes, that is correct. Metatarsophalangeal joint. First metatarsophalangeal joint is the most frequently involved joint. Moving to the infection. When I was moving to the infection, and if a hand radiograph mimicking some infection which is having systemic appearance or can mimic about something else, this thing came to my mind. This is a case of tubercular dactylitis or the spina ventosa. Very difficult to diagnose. Spina word is actually for small bones, and ventosa means air-filled or ballooned structure. So as one can see here, this a second metacarpal is somewhat ballooned up, and some sclerosis is there. It is a post-treatment sclerosis. So this radiograph came to me after diagnosis. So this one is a case of a tubercular dactylitis. This patient also had spine tuberculosis and pulmonary tuberculosis. So just I wanted to add to the previous my lecture. This one is a case of spina ventosa. Neoplasm already being extensively covered by Sanjay sir. So luckily, I don't have to tell much anything in detail about the bone tumors. So what one can see here is the most common tumor of the hand. Most common tumor of the hand or involving small bones is enchondroma. As one can see here, mild expansion, endosteal scalloping. Although typical chondroid is not seen in this particular radiograph, but enchondromas can be multiple. So multiple enchondromas as seen here is which disorder? Any syndrome? Here one can see the chondroid calcification very well. One can see endosteal scalloping.
People have answered all years.
Yes, it is all years. And this next radiograph with multiple phleboliths. So along with multiple enchondromas, if phleboliths are there, then this is which disorder?
Mafuchi's they've answered.
Yeah, this one is Mafuchi's disorder. This one is same. Actually, just before some time, Sanjay sir had shown one typical appearance of a hand radiograph he had shown, and he had shown such type of lesion. Okay, here it is in the proximal phalanx of little finger. Any diagnosis of this particular lesion? I will tell you more about the another lesion. Any diagnosis of this lesion?
People are
proximal
putting
phalangeal lesion.
GCT versus chondrosarcoma versus ABC versus METS.
Actually, this one is yes, this one is GCT. Sir had shown GCT. Another one here is a larger mass which is involving a fifth metacarpal. So this fifth metacarpal mass, as seen here on MRI, one can see multiple blood fluid levels. So this one was both were GCT. So almost 1% of the cases can have multiple GCT. And this GCT had undergone, like previously, sir had shown one chondrosarcoma had gone ABC transformation. This GCT has undergone ABC transformation. So sudden increase in size of this lesion was there. So in 1% of the cases, these GCTs are multiple. They are usually on the same side of the body. But as we all know, GCT also can metastasize. So just this case I have added before some time. About age determination, it is already covered in the first lecture. I think Dr.
Srijita.
Yes. From Calcutta.
Yes.
Srijita had already covered this topic. I will just show you hand radiograph is very useful radiograph, hand with a wrist radiograph for age determination right from birth up to the puberty. So she had already shown these carpal bones, their ossification timing, and last to ossify, although carpal bone, amongst carpal bone, pisiform is last to ossify, but here is a last to ossify bone is actually a sesamoid bone in relation to the first metacarpal, and it is at the puberty, so 16 years. just I'm ending this lecture on a lighter note. Just try to answer if yes or no. You have to just answer about yes or no. Any of the answer is yes, just write it. When you get a WhatsApp message, do you find it impossible not to answer back? And how many hours do you spend on your smartphone? Whether it is 4 or 6, that's all. So if answer to any of this question is yes or no, try to answer. If answer is yes, you are suffering from an uncurable, very dangerous disease. And this disease is known as WhatsAppitis. WhatsAppitis is the disorder which comes under repetitive strain injury. And these people, they are having pain along the thinner eminence of the pain involving the thumb and even restricted mobility. And they find it very difficult to move the fingers. And treatment is very difficult. So why it is here? So there are very important thing which is seen on hand radiograph. So on a hand radiograph, everything will be normal. So radiograph will be normal. All these findings will be there, and there is very difficult treatment for this disorder. That is a restriction from using WhatsApp. So that is not yet possible. So we will try it in future. This is a WhatsAppitis. Hence, at last, to conclude, we are having a multiple radiographic finds on hand radiograph. These may contribute to the diagnosis of different diseases and disorder as we have seen. Along with that, if findings are bilateral findings are more in favor of systemic disorders. So actually, I shouldn't answer it, and I expect answer from you people whether really human hand can mimic the changes of disease or the disorder. So whether new age radiologists can be a palmist. These are my references. Last but not least, this one is a spotter. Try to answer this. What is the prominent finding? What exactly is the finding or abnormality? And any one cause which is causing this abnormality. Sanjeev, answers are coming.
Yeah, we're having acro-osteolysis.
Yes, acro-osteolysis is there, and causes also coming. Actually, it is very easy to remember the causes. Just take a pinch and you will remember the causes. P stands for psoriasis, pycnodysostiosis. I is for injury like frostbite. N is for neuropathy. C is collagen vascular disorders. We had seen scleroderma, we had seen dermatomyositis. Then H stands for the hyperparathyroidism. So just pinch yourself and you can remember what are the causes of acro-osteolysis. Thank you.
Thank you, Anand. That was really wonderful. We really enjoyed so many wonderful images of X-ray hand, and it was a perfect mid-segment lecture for our ortho session. So thank you very much for being there with us, and we'll have you once again for the hopefully on-site AGFA Masterclass next year. So thank you very much.
Thank you, Sanjeev. Thank you, Sanjeev, for giving me this opportunity. And thanks. That's all.
Okay, bye-bye. You can just switch off your screen share, so I'll welcome the next speaker, please.
Thank you.
We now have Dr. Sonal Saran. This is the last lecture of the day, but I'm glad we have more than still 200 people on site. We are actually almost running an hour late. So hello, Sonal. Thank you for being here.
Hello, sir.
Yeah,
Thank you for inviting me.
I know your afternoon session has become an evening session, but let's go through it. It's mainly spotters, right? So it's going to be good.
Yeah.
And
I'm sharing my screen.
Yeah, Dr. Sonal is associate professor at AIIMS Rishikesh, and her specialty is musculoskeletal imaging. So these spotters are mainly on musculoskeletal imaging. Sonal, you can just go ahead.
So is my screen visible?
Yes, it's fine. You're clear. Yeah.
Okay, so
Audible, yes.
Okay. So I will try to make it more interactive. So will you let me know about the responses in the chat box?
Yeah, surely. No worries. Yeah.
Okay. So I will be showing approximately 20 spotters, mainly the conventional one. So starting with the first one, it's a bit easy. an infant with shortened right lower limb. I will try to cover all the entities and try to cover the untouched one mainly. So what is the diagnosis? And what is the Aitken class, and what is the most common associated anomaly?
So people have put proximal
Focal femoral.
Yes. Yeah.
Okay. Okay. Yeah. So this is proximal focal femoral deficiency. So what we are seeing here with the pelvic radiograph, left femur is completely normal, but on the right side there is shortening of the right femur and there is non-visualization of the upper end. So this is a case of PFFD. So what we have to look for when there is congenital lower limb shortening. So there are two most common causes that are PFFD and fibular hemimelia. And in 80% of cases, PFFD is associated with fibular hemimelia. And we can classify PFFD in 4 categories depending on the extent of involvement. So in the last category, there is almost complete involvement of the femur, only a remnant of the lower end is left, and there is involvement of acetabulum as well. Whereas when we talk about the fibular hemimelia, how do we take the length of fibula is like we draw a tangential line across the upper end of the epiphysis. It should cross the proximal tibial physis. Whereas when we draw tangential line across the distal fibular physis, it should cross the talar dome. And there is a classification for fibular hemimelia also. Then this is a companion case, another patient with fibular hemimelia. We can see a higher grade of fibular hemimelia and only a small remnant of lower end is left. And in association with fibular hemimelia, we see absence of 5th metatarsal and 5th digit. So coming back to this, this is an infant with shortened right lower limb. Diagnosis is PFFD. Classification, according to classification, class C, and most common associated anomaly is fibular hemimelia. Next case, 45-year-old male with back stiffness and pain in multiple large joints. What is the diagnosis and any striking radiographic sign?
People are answering the dagger sign of ankylosing spondylitis.
Yeah, right. So this is a case of ankylosing spondylitis and the sign is dagger sign. So what we are seeing here is a radiodense linear opacity in the midline in the expected location of the interspinous and supraspinous ligaments. So it is because of ossification of these ligaments in ankylosing spondylitis. There is a straightening of lumbar spine and there is bony ankylosis of bilateral sacroiliac joints. So this is a case of ankylosing spondylitis. Another companion case where we can see fine syndesmophytes bridging across the vertebral bodies. And in the same case, we can look for ankylosis of bilateral SI joint. And this is another patient. This is a case of degenerative spine disease. This I am showing to how to differentiate between an osteophyte and a syndesmophyte. So how does an osteophyte look like? It is thick and it is not exactly perpendicular, whereas syndesmophytes are fine and linear and they are perpendicular to the vertebral bodies. There's another case of skeletal hyperostosis. Again, we have to differentiate this from syndesmophytosis. So in hyperostosis, we can see thick ossification along the ALL. There's another case of advanced stage of ankylosing spondylitis where we can see severe kyphotic deformity of the thoracolumbar spine. And there is bilateral protrusio acetabuli. Dagger sign is also seen, and there is ankylosis of bilateral SI joint. This is another case of advanced stage of ankylosing spondylitis where we can see complete bony ankylosis of bilateral hip joint as well as SI joint. Another next spotter, a 25-year-old female with constitutional symptoms and backache.
Getting an answer of pot spine from 3-4 doctors. Yeah.
Okay. So Potts spine is the right answer. So what we are seeing here is there is a fusiform soft tissue opacity in the paraspinal region, and on lateral view we can see there is loss of disc height and there is continuous involvement of the vertebral bodies with destruction. So this is a case of Potts spine with paravertebral abscess in the thoracic spine, and the radiographic appearance is looking like a bird nest. So this is bird nest appearance. And next investigation, we have to go for MRI so that to look for the cord involvement. This is another case of Potts spine where we can see destruction of the vertebral bodies, loss of disc height. However, there is no obvious spinal abscess in this case. This is a case of heel Potts spine where we can see bony fusion of the vertebral bodies. Next is Potter. This is a tricky one. This is a 25-year-old young female with multiple bone pain and abdominal pain. Any response, sir?
Yeah, we're getting hyperparathyroidism.
Yeah, right. So what we are seeing here is a bubbly osteolytic lesion involving the fifth metacarpal. There is another osteolytic lesion here. However, we are not seeing classic appearance of hyperparathyroidism that we saw in the last lecture, like acrosteolysis and tunneling, periosteal absorption, that we are not seeing in this. There is some amount of osteolysis in the distal radial end in the stellate process also. And I have summed up this hand radiograph with the abdominal radiograph so that you get a hint. So there are multiple calculi in the left lumbar region, and we can see a osteolytic lesion in the right acetabulum also. So what we did, we performed a USG neck for this patient, and we found a well-defined lobulated hypoechoic lesion posterior to the right thyroid gland, and we gave a diagnosis of primary hyperparathyroidism. So hyperparathyroidism can be divided into three categories. Primary is most commonly because of single adenoma, like in our case. And in secondary, it is because of calcium loss, it may be because of CRF or chronic renal failure, or because of malnutrition, leads to increased secretion of the parathyroid hormone. And tertiary is because of hyperactive or long-standing secondary hyperparathyroidism. And the important thing is to differentiate the primary from secondary hyperparathyroidism on the basis of radiograph. So what we have to look for, brown tumors are more common in primary hyperparathyroidism, and we get to see more of osteopenia. Whereas in secondary hyperparathyroidism, we get to see more of extraosseous calcification. We see more of osteosclerosis, and we can see rugged jersey spine. So what is rugged jersey spine? Density, radio dense shadows across the end plates, and they give an appearance like a jersey. Next is spotter. A 15-year-old male with slowly progressive pain in right hip with limping. So the history in itself is saying it is slowly progressive. Any response?
Perthes versus TB.
No, not Perthes. Because there is involvement of the acetabulum and the right iliac blade also. So it is not Perthes. It is tuberculosis of the right hip joint. We are seeing a lot of osteosclerosis and osteolytic areas in the femoral head as well as in the acetabulum and adjacent iliac bone also. And there is widening of the joint space. So this is infective etiology. It is not malignancy. It is not because of any avascular necrosis. Because if there is any malignancy, it is not going to cross the joint and involve the opposite side of the joint. And what is Femister triad? It is described in cases of tubercular arthritis. It consists of periarticular osteoporosis, peripherally located bony erosions, and gradual diminution of the joint space. So what happens in tubercular arthritis? The Mycobacterium TB, it reaches the hip joint through hematogenous route. It can lodge in the acetabulum, or it can lodge in the epiphysis or metaphyseal region of the femur. It leads to destruction of the acetabulum, and it can lead to the various signs, like in this case, it is wandering acetabulum. There is subluxation or proximal subluxation of the femoral head, and because it forms a pseudojoint with the adjacent ilium. So this is wandering acetabulum. Then we can get a motor and pestle appearance when there is abnormally widened acetabulum which articulates with a small femoral head because of its destruction. So it gives an appearance of motor and pestle. Or we can have a protrusio acetabuli because of protrusion of femoral head into the pelvis. Or we can have dislocation of femur outside the joint. Next case. 1-year-old child, what is the diagnosis and what are the risk factors?
We're getting an answer of DDH. Yeah.
Okay. So before jumping to the pathological hip, let's first see how we approach a pediatric hip. So we draw multiple lines and angles to look whether the radiograph is normal or not. So first is the Hellgrenner line, which crosses across the unossified triradiate cartilage. Then we have Perkin line, which is actually perpendicular to the first line and it is tangential to the lateral acetabulum. It divides the hip into 4 quadrants, and the head of the femur should lie into the medial and inferior quadrant. Then we have Shenton line, and it should be intact. It should not be broken. Then we have acetabular angle. It should be less than 28 degrees. So what is happening in this case? The hip joint, the femur, head of femur is dislocated. It is not lying in the inferior medial quadrant, neither on right side nor on left side. And we can see broken Shenton line and widened acetabular angle. So this is a case of bilateral DDH. So it is present, it is on right side, it is more severe, and on left side, it is slightly less severe than the right one. And there are certain risk factors that we have to remember. First one, female child, family history, and because of breech presentation and oligohydramnios, there is abnormal positioning of the hip joint in utero, and it can lead to DDH. Next case, 8-year-old child with right hip pain and limp.
We are getting Perthes versus SCFE.
No, it is not SCFE, it is Perthes. So what we are seeing here is that the left hip joint is completely normal, but right hip joint, what we are seeing, there is widening and enlargement of the femoral head, there is flattening of the epiphysis. The physeal plate is irregular, there is radiolucency in the metaphyseal region. And so this is a case of leg cuff Perthes disease. And what happens here because of avascular necrosis, leg cuff Perthes disease is basically idiopathic osteonecrosis of the femoral epiphysis. It leads to joint distension because of some amount of effusion. It leads to increase in the medial joint space. Crescent sign is because of osteonecrosis of the epiphysis. And we can have metaphyseal lucency, widening of the physis. We can have a cystic lesion in the medial metaphysis, and we can have widening of the femoral neck. So it is mostly seen in age group 4 to 8 years, and boys are most commonly involved. Then it can be bilateral in 20% of cases, and in 80% cases, it will develop osteoarthritis in long run. And there are certain classification. First is the Catterall, which is most commonly used. And another one is the herring, which depends on the involvement of the lateral pillar height. So more the involvement, there are more chances of getting it collapsed. There is another staging system which stages the according to its involvement. First is the initial stage in which we can get sclerosis, then there is fragmentation, then there is reorganization, and finally healing. So in our case, it was more of a healing stage. There was deformity, there was widening of the femoral head, and there is flattening of the epiphysis. Next is spotter. 25-year-old female with left hip pain, a pelvic radiograph with a dedicated left hip radiograph. And another hand, I have a MRI also. Any diagnosis?
Yeah, we're getting a mix actually. We're getting septic arthritis, GCT, AVN, pathological fracture.
Yeah, there is definitely a pathological fracture, but there is well-defined osteolytic lesion. It has a sharp zone of transition. And we have ground glass matrix in the proximal intertrochanteric region and the proximal diaphysis. But what on MRI, what we are seeing is that there is presence of a lipomatous component, which is suppressed on the fat suppressed sequence. So diagnosis in this case is liposclerosing myxofibrous tumor. So it is a variant of a fibrous dysplasia only. And it is a rare benign tumor, but it has a striking predilection for the intertrochanteric region. And differentials are intraosseous lipoma and fibrous dysplasia. So this can come as a spotter in exams.
We got Akanksha who got that. Akanksha Agarwal. She answered that at the end. Yeah.
19-year-old short-statured male patient with complaint of low backache for 2 months, and there is weakness of bilateral lower limb, inability to walk unassisted for 1 month. So we have clinical photographs as well as spine radiograph and radiographs of multiple joint, and we also have a MRI of the spine. So what we are seeing here is that there is enlargement of the joints, elbow and bilateral knee joint. Any diagnosis, sir?
Yeah, we've got juvenile rheumatoid arthritis versus SED.
Okay, good. So what we are seeing in the radiograph, there is involvement of spine. There is flattening of the anterior half of the vertebral bodies, and there is eburnated bone formation involving the posterior half. So this does not go in line of juvenile rheumatoid arthritis. However, other joint involvement, what we are seeing here, you can give a differential of JRA. But because of spine involvement, and there is involvement of epiphysis of multiple large joints, enlargement of the epiphysis, secondary degenerative changes. So this is a case of spondyloepiphyseal dysplasia tarda. So SED tarda presents in the adolescent age group, unlike the congenital one, which presents in the neonatal form. And SED tarda presents with the mild short-term dwarfism that we had in our case. And JRA is an important clinical mimic, but we have to look for the inflammatory synovitis. It is absent in SED tarda, and there will be no response to the anti-rheumatoid treatment. Other differentials can be mucopolysaccharidosis type 4, multiple epiphyseal dysplasia, and pseudoachondroplasia. Next case.
One after the other.
Any diagnosis, sir?
People are giving osteogenesis imperfecta.
Okay, perfect.
And thanatophoric dysplasia.
Well,
OI
we
means.
can see, yeah, OI, it is osteogenesis imperfecta. We can see varus deformity of knee, bending of the bones, and multiple radiodense lines, which indicates healed fractures. So there are multiple, there we can see a fracture also. So there are fractures with different stages of healing, varus deformity of knee and valgus deformity of the hip. We can see Wormian bones in the skull radiograph. So this is a case of osteogenesis imperfecta type 3, which presents with progressive deformity. So this is a 40-year-old diabetic male who presented with swelling in the retrocalcaneal region. And this is the lateral radiograph of the foot.
Osteomyelitis,
Yeah.
Charcot's joint versus
Yeah.
gout.
So this is osteomyelitis of the calcaneum, and there is soft tissue overlying the calcaneum and in the retrocalcaneal soft tissue. We performed an ultrasound for this, and we found there is collection in posterior to the Achilles, anterior to the Achilles tendon, and there was destruction of the calcaneum. So this was a case of calcaneal osteomyelitis with retrocalcaneal abscess. Next case, a 19-year-old female with pain in the second metatarsophalangeal joint. I think it's an easy one.
People have answered Freeberg's.
Okay. Okay, we performed an ultrasound also for this patient and compared it with the contralateral metatarsophalangeal joint. We found that the epiphysis was completely normal in the normal side, but it was fragmented on the involved side. So this is a case of Freiberg disease. So what is Freiberg disease? It is osteochondrosis of the head of metatarsal. It can involve, most commonly it involves the second metatarsal head, but it can involve the third and fourth also. And it can be bilateral in 10% of cases. It is seen in adolescent female as it was in our case, and it is associated with high heels. So next is spotter, a 60-year-old male. So this is a chest radiograph, but we have to look for the bony cage and bones also.
We've got answers in with necks and left scapula.
Yeah, so left scapula is abnormal. And what we are seeing here is that destruction of the scapula. We are not finding the normal borders. And there is extensive soft tissue swelling in this region, and there is presence of calcification. So ring and arc pattern of calcification can be seen. And in the lung parenchyma, we are seeing multiple soft tissue nodular lesions. So this is a case of left scapular chondrosarcoma with right lung metastasis. A 30-year-old lady with pain and swelling in right knee joint. I think bone tumors are already extensively covered, but let's see.
GCT is one answer we've got.
Okay, so this is a giant cell tumor. We are seeing classical imaging features of GCT, like it is subarticular. It is seen in a skeletally mature patient after epiphyseal closure, and there are trabeculations, and the margins are not sclerotic. So there are 4 characteristic radiographic features that we have to look for, and like closed tooth plate, well-defined non-sclerotic margins. It abuts the articular surface. It is typically subarticular, and it is eccentric. Next case.
You could have answered myocystis.
So we are seeing multiple rice-like radiodense opacities spread almost everywhere. It is seen in muscles, intermuscular plane, subcutaneous plane, and the pelvis also. So, and on the ultrasound, we can see a cystic lesion with eccentric nodule, that is a scolex. So this is a case of myocystis, and it is very well diagnosed on ultrasound also. So this is another companion case where we can see a different stage of myocystis where the cyst has almost collapsed. There is a lot of inflammation going around. So this was a case of myocystis, and the calcification here we are seeing is because of calcification in the scolex. Next case, a 7-year-old female presented with a large mass lesion around the knee joint.
Osteosarcoma.
Okay. So what we are seeing here is that destruction of the lower end of femur, and it is osseous matrix, involvement of the soft tissue, poor zone of demarcation, permeative pattern of destruction. So all fine features suggestive of malignant bone tumor. And this patient underwent MRI. And what we found was presence of multiple fluid level within the tumor matrix. So what variant of osteosarcoma can present like this?
Telangiectatic osteosarcoma.
So this is a case of telangiectatic osteosarcoma. It is a rare variant of osteosarcoma. Age and gender predilection is same as conventional one. And in order to classify it as telangiectatic osteosarcoma, we have to have at least 90% component as a telangiectatic component. And distal metaphyseal of femur is the most common location. Next case. A 45-year-old diabetic male with painless boggy swelling in the right foot.
Charcot's joint people have reported. One has said mycetoma.
No, it is not mycetoma. What we are seeing here is that there is destruction of the tarsometatarsal joint. There is a lot of destruction, collapse of the bone. There is widening of the space between the first and the second metatarsal bases. So this is a divergent wrist flank dislocation of tarsometatarsal joint as a result of Charcot neuroarthropathy. So what happens in Charcot's joint? There is abnormal pain sensation. So minor injury will lead to inflammatory response that may go undetected. It leads to excessive bone destruction, and it can present as atrophic or hypertrophic form. Atrophic form is most common, and there is resorption of the bone, less of osteosclerosis and osteophytes. Whereas in hypertrophic, we can get more of osteosclerosis and osteophytosis. 18th case. History of long-standing soft, non-tender swelling in the prepatellar region.
Prepatellar bursitis, and one has said lipoma. Housemaid's knee.
Okay, so it is not prepatellar bursitis, because what we are seeing here is that the density or appearance of the lesion is similar as the subcutaneous fat, and it is not like it is filled with fluid. Okay, so we performed an ultrasound again, and we found that the lesion was completely hyperechoic. It was not fluid. So this is a case of prepatellar lipoma. So lipoma can be seen anywhere across the body, and this is not a rare location also. A 50-year-old male with multiple joint pain. So knee radiographs was beautifully covered by Dr. Chetli.
Cartilage calcification, chondrocalcinosis.
Okay, right. So what we are seeing here is that there is presence of calcification in the joint space in the expected location of menisci, and there are a lot of degenerative changes. But the unusual thing is that there is more severe involvement of the patellofemoral joint as compared to the tibiofemoral joint. So this is a case of crystal-induced arthropathy. And on ultrasound, we can see presence of multiple calcific foci with distal acoustic shadowing. So this was a case of crystal-induced arthropathy. So it can be of two types, gouty and pseudo-gout. In gout, we have monosodium urate crystals deposit. The most common location is first metatarsopharyngeal joint, and there is a strong male predilection. But in pseudo-gout, men and women are equally affected, and knee joint is the most commonly involved joint. There is one more important difference is on the basis of pattern of deposition of the crystals over the cartilage. So in gout, we see a deposition over the surface of the cartilage. It gives to double contour sign. Whereas in chondrocalcinosis, we see cartilage that urate calcium crystals deposition within the substance of the cartilage. Last spotter, 25-year-old male with right shoulder pain. So what's the radiographic view and what's the diagnosis?
You could have answered swimmer view versus hill sack versus striker, or a shoot through or a Y view.
Okay, so this is a striker's notch view, and what we are seeing here is depression over the posterior aspect of head of humerus. So this view is especially performed to look for the posterior aspect of the head of humerus, to look for Hill-Sachs lesion. So this is the striker's notch view, and this is the Hill-Sachs lesion. And what we are seeing here is that there is involvement of the anterior part of glenoid, bony glenoid. And in AP radiograph, this lesion, this Hill-Sachs lesion is not standing out rightly, but on striker's notch view, we can see very beautiful Hill-Sachs lesion. And this is performed with abduction in the shoulder, and the hand is kept behind the head, and there is caudal angulation, 10-degree caudal angulation of the X-ray beam. So this is striker's notch view, and it is especially used to look for Hill-Sachs lesion. So that's all. I gave 20 spotters, and it was a short talk. Any questions?
Anyone has any questions to ask of Dr. Sonal, please? They're asking whether you can explain the 15th spotter again. Can you go back, or you are still sharing the screen?
Yes, sir. Okay, 15th spotter. That is myocystis. Okay.
Yes.
So it is a easy one. Actually, what we are seeing a rice grain radio opaque shadows throughout the soft tissue, not in the bone. And on ultrasound, we can see a well-defined cystic lesions. Ultrasound is very good modality to look for myocystis, and we can see eccentric scolex, calcified scolex here, and there is adjacent soft tissue swelling also.
Rajeshri is asking whether we can diagnose Perthes versus SCFE. Is it possible to differentiate?
Yeah, of course. Both are completely different disease. So in Perthes, what we are going to see is flattening of the epiphysis. Okay, and in SCFE, there will be posteromedial dislocation of the physis. So that is completely different. It is either it is generally post-traumatic. SCFE is post-traumatic. There is Salter-Harris type 1 dislocation of the epiphysis. Whereas in Perthes disease, you will not find any dislocation of the epiphysis, but flattening of the epiphysis and sclerotic areas in the epiphyseal region that we are not going to see in the SCFE. We can see that because as a complication of SCFE, which can lead to avascular necrosis of the epiphysis, but primarily it is dislocation of the epiphysis.
Deepthi Ashok asks whether we can give a DD of leukemia for the osteosarcoma spot that you showed with only the radiograph.
It is a classic appearance of osteosarcoma. What we are seeing here, lot of osseous matrix. So osseous matrix is not going to be seen in leukemia.
All right, Sonal, thank you very much. It was wonderful, and you did a nice wrap up of all the pictures that we've seen over these 2 days. Thank you, everyone watching here, almost 175 people. And we will be just sending you a Google link form on the Masterclass WhatsApp app so that you can fill in your state council number for the points that will be generated and sent to you online in about 2 weeks or so. And also have a look at our breast imaging masterclass. It's again a similar program like this one. And we value your feedback if you can send it back to us on our social media or by email or by WhatsApp to us. Thank you, everyone, and goodbye. And thanks, Sonal, once again. Thank you.
So, thank you.